For pre-registered delegates. I would like to invite the mentors on the dais, Dr. R. Alligason, sir, and Dr. Nitin Burkole, sir. Can we have some applause, please? Welcome both of you on the dais.
Hello. Yeah, and we'll start with the main conference, rather the hands-on training and the body of the conference today. Let me introduce the plan of the whole day today. Well, we have two sets of people. We have delegates and we have hands-on trainees. The hands-on trainees who have registered for the hands-on, they'll be allowed to handle the machine. And the other delegates, you are all welcome to come and continue and we see this whole proceedings. What we are trying to actually do in this session is, we generally have the hands-on personnel, they are already known echocardiographers or they are doing echos. We have tried to choose people like that, echos in different centers. It's not a training session, it's rather a learning session for both of us, for you and as well as for us. What we'll try and do, we will just brush up our memories. We'll try and do the echo correctly. And if we can formulate a standard code of action so that when reports come from different centers, they do not have a very major disparity between them. We will try and do that thing in a right way. And we have very senior cardiologists, mentors, Dr. Nitin Burkole and Dr. Alligason. And we have senior cardiologists of Kolkata like Dr. Abhijit Vishwas, Dr. Soumitra Kumar, Dr. Devika Chatterjee, Dr. Aniruddha De. They'll be all present today to help us out just to refurbish our memories. And we'll try and do the echoes correctly, bring the views correctly, and try and analyze the echoes properly so that in coming days, we have good reports coming out. When I was a student, what I was taught and I was said, I still remember that echos is a sort of a tool for a cardiac clinician or a cardiac interventionist. We stand in between, we give them a proper understanding of what they want to do on the patient. And my teacher, he told me it's like a tabla player. Without a tabla player, you cannot get a good music in Indian music. But a tabla player rarely performs on his own. We are like that. We are an interface between a clinician and an interventionist or maybe a cardiac surgeon. And we have to provide them with maximum information we can give and in the right order. That is what we will try and formulate in today's and day-long session. Tomorrow we will be having a little bit of advanced courses, and today we will do with only the basics of a 2D echocardiography and of course a Doppler study. No echocardiography is complete with a Doppler study today. And so echo and Doppler, they go side by side, hand in hand, and they are not different things. So I'll go to the today's basic examination views in today echocardiography. Can I have my slides on the? Can I have my slides? So what what today 2D echocardiography is? It's a key and non-invasive cardiac imaging modality and used for a real-time assessment of the heart structure and function, and requires standardized imaging techniques. Most important, requires standardized imaging windows for accurate interpretation. So you need to have a good window first. These are the basic windows that we generally do: parasternal view, an apical view, a subcostal view, a suprasternal view, and each window will offer different anatomical perspectives. So a patient position in a plaques view or a parasternal long axis view, you have left lateral decubitus. We generally keep the patient's head on the side of the machine and we face the machine. We have the patient on the right side of us. That is the way we do it. The head end towards the machine and the patient turns to the left. The probe is placed in the third or the fourth intercostal space near the sternum. That's very academic, but what we generally do is we can do two ways. If you put your probe on the chest wall of the patient, you have to move the probe. You can do it in two ways. You can do it from up downwards, or you can do it from down upwards, the way you have exposed your patients. You cannot expose your patient every time very generously. You have to have some bit of manipulations done from your side. So you can do it from down upwards, you can do it from up downwards. I generally prefer it doing from up downwards. And you can get a good window in the third intercostal space or in the fourth intercostal space. What will happen is, if you have to make a correct picture out of it. So you need to bring your probe more medially, that is more toward the sternum, and more upward to get a good plaques view. That is practical understanding that I had over the last almost 15 years. So the structures we see is the left ventricle, the left atrium, the aortic valve, the mitral valve, and the interventricular septum. Some amount of right ventricle you also see, but plaques view generally doesn't give you much of it. So in our early days, what we used to tell, what we were taught, that if you get a good plaques view, you will not be able to see the apex of the left ventricle. But in today's machines, the machines are giving a big sector, so you can sometimes see the apex as well. So this is a plaques view. And the most important thing which I want to, can I get a pointer please, show you is that this, I have a pointer here also. This part, that is the apical side of the interventricular septum. If you can align this part, that is the aortic part, on the same level, your picture is more or less correct. It is not always possible. This is a picture of an elderly person, so you cannot just, I couldn't just bring both at the same level, but it is more or less in the same level. And if you can do that, what will happen is, from the apex, and if you drop a straight line downwards, your aortic valve will be more or less on that line. And if this is your picture of the plaques view, then you can convert this plaques view to a PSAX view and so on. So this is a M mode done on that. And see, this sided M mode is on the aortic valve, and this sided M mode is on the mitral valve. In the aortic valve, we see the size of the aorta from the leading edge to the leading edge. And you see the size of the LA, this is the size of the LA, from the trailing edge to the trailing edge. And that is the way we measure generally in the M mode. And most important, if you see the mitral M mode, you will see the EPSS. That is an important measurement for us to find out whether the LV is dilated or not. So this is the actually the plaques M mode in the plaques view of the ventricles, and this is the interventricular septum. This part is the right ventricle. This is the right ventricular wall. This is the LV and the posterior wall. This is the diastolic, and you measure the TCOIS, EF by the TCOIS method. We still do it. We'll carry on doing it, and I'll tell you when not to do it also, please. And this is the end diastolic, and this is the systolic. Yeah, thank you. That is what we see. So in parasternal short axis view, we just turn our probe in the third intercostal space 90 degree in the clockwise, and what we get is this. This is the view. This is the view of the ventricle. Then the ventricular view is more or less in between the mitral valve and the papillary muscles. So you can see the papillary muscles, and sometimes the mitral valve is also coming in the in your view. And with this, keeping your hands there, if you tilt your probe upwards, you can see the aortic valve. And if you slowly tilt your probe downwards, just a tilt, it is not a movement, it's a tilt upwards and downwards, you will see the left ventricle, the left ventricular apex, and the mitral valve in the Sachs view. And that is important to find out the area of the mitral valve at that level. That will be taken now during our course. And this is another view, a tilt upwards. See, this is the aorta. If you can get a good view of the aorta, you will, if you can keep the aorta in your plaques view right under the apex, you will get just a good view of the aorta. And you will see all the three leaflets, which is not very evident in this view. And in the right side, this is the pulmonary artery and the pulmonary valve. The pulmonary artery, it branches like the pantaloon shape. And come to the apical four-chamber view. In the apical four-chamber view, you see everything. You see the left ventricle, the left atrium, the right ventricle. This is the interventricular septum. Actually, you cannot see the apex if you get a good view. And if you see the apex previously, it was said that it's a foreshortening view. But nowadays, the machines are well equipped, and you can see the apex as well. And this is the mitral valve, this is the tricuspid valve, this is the left atrium. And most important is, if you want to get a good view, you need to align your view in such a way that your interventricular septum should try and come below the apex, if it's a very good view, and it should be straight. You shouldn't keep your view tilted. For that, you have to go down and out. For the first thing, in the plaques view, I said it should be inwards and upwards. And in the apical view, it should be down and out. And if you can place your probe right on the apex of the heart after palpation, the things we had learned in our third year or fourth year medical school, you can get a very good view of this. And here also, this is a left ventricular sided view. You can also tilt your probe a little bit to find a right ventricular sided view as well. So also, with a four-chamber view, you need to have a three-chamber view. This is by tilting, rotating your probe anti-clockwise by 30 to 40 degrees, you can get this view. And this will be a three-chamber view in which you see the left ventricle, the left atrium, the aorta, and the aortic valve. And this is a two-chamber view in which you can see the mitral valve opening. The mitral valve is displayed in a better manner in this if you want to find out your where you are having a mitral regurgitation or not. And you can see the left ventricle and the left atrium. So you have a subcostal view again. The subcostal view, you keep your probe on the Xiphi just below the Xiphi sternum with the cursor of the probe facing outwards, that's laterally. And if you have to tilt it a little bit upwards and you find this, this is the IVC that we are seeing, the IVC entering the right atrium. So there is again a suprasternal view. I don't have a good picture of a suprasternal view. We will show you on the machine. And in the suprasternal view, what we see is the patient is supine, the neck is extended. We put it on the suprasternal notch with the cursor facing upwards. And you see the aortic arch, the great vessels, the innominate artery, the other two branches, the left carotid and the left subclavian. And we see for the aortic pathology. So this is the summary table. I had said it. So we'll go to the what we get from the images, how we diagnose and go into the later part of the story. What informations we are supposed to have from 2D echocardiogram are the anatomical information, the functional information, the systolic and the diastolic function, and the volumetric informations. So for this, we take the help of these small things. These are the systolic function, the diastolic function, the wall motion analysis, the hemodynamic functions, and the valvular functions. Let's go one by one into them. So the systolic function assessment is very important. We do it from the fractional shortening of LV, and the formula for that is very easy. I'm not going into the details of the things, and the ejection fraction you have to find out, the stroke volume and the cardiac index, they are calculated by your machines. And let me tell you in between that we are not using the old aged machines. So the new machines, if you can keep your view very correctly, if you can give the proper feedings to the machine will calculate 50% of the thing, rather 90% of the thing for you, and you don't have to go back to the ages of bows and arrows and keep your pens and papers ready to find out the other small things and calculate it from the machine. The machine does calculate it for you. So the ejection fraction, the stroke volume, and the cardiac indexes are all calculated by the machines. The systolic tissue velocity of mitral annulus and the myocardium has to be taken. The tissue tracking is to be done, but these have to be done. They are done by the machines, but you have to correct them. We will show you in the later part. And the regional wall motion abnormality is done. So about the stroke volume, the calculation is this. If you can take a VTI of the LVOT and the CS, the surface area, you don't have to look for the surface. The circular area, you find out the diameter. The rest of the calculation is done by the machines. And see if you have a good picture like this, and if you can see the LVOT diameter, the rest of the things are calculated by your machines. And this is done from the aortic valve laminar flow. So the systolic function assessment, the most important thing that I want to impress upon you is that the ejection fraction should be calculated by the Simpson's method. Again, for the Simpson's method, in today's machines, both the GE and the Philips people will show you, you don't have to really go into the two frames, freeze them, get the systolic, area length methods and all. You just have to trace your patient, see the systolic, freeze the systolic frame, trace the systolic frame and the diastolic frame, it will give you. In the high-ended machines, they just you don't have to even trace the machine. You will just get a good view, and they will give you the systolic Simpson's ejection fraction by the Simpson's method. I am telling this because of the practical aspect. You want to do it very fast, and in a small time you want to get a good outcome from your patients. So you can do it that way also. And the global longitudinal strain is also very important. If you do a global longitudinal strain by all the three views, and the 50% machine calculates everything, and you can get a very good understanding of what you are dealing with in your patient. And look at this patient. This is a post-CABG patient, so you have scarred IVS. This is a scarred IVS. See, the IVS is also pretty thin, and this is the posterior wall. And if you see that in this patient, I have just allowed the machine to calculate it, and they have calculated the ejection fractions around 39%. In the previous field, it was somewhere around 40-45% ejection fraction was shown by the Tekoya method. So, and if you do, this is more or less a normal GLS. If you do a GLS like this, and this part, this X part, this was not taken very correctly by the machines, so they couldn't calculate in this black part. The rest of the part they have calculated, and you see the wall motion is more or less similar in all the, except these two sectors. That you can see if you can put your thing on the in the real time. If you put your cursor on that, it will show you that which quadrant it is showing and which sector it is showing that they didn't pick up well. And this is a normal, and this is from the same patient of that post-CABG patient, and if you can see that here the regularity of the sectors are not there, and the wall motion abnormality has been picked up by the machine. Here also, if you see, the global longitudinal strain is minus 9.4, and see the ejection fraction 39%. That is the same that we had got from the Simpson's method calculation of the machine. So that is a part with the systolic function. We'll come to the diastolic function. What is very important for us in diastolic dysfunction is that we keep on writing that this patient has diastolic dysfunction. But what is important? The important part is, yesterday we were talking about the heart failure with preserved ejection fractions, the LA volume, and the PCWP, which when goes high, the patient goes into early stages of heart failure. If you want to pick that up, whether if the patient has a good systolic function, whether that diastolic function is impaired to that extent in which we need to really intervene on the patient, we need to look at these three basic things. You need to have a mitral flow velocity. Mitral flow velocity is a pulse wave Doppler kept on the tip of the mitral valve in the 4-chamber view. And here, if you see that the EA ratio is more than 1, that is E more than 1, then you are more or less dealing with a normal patient. Even if in that case, it can be a pseudo-normal, we will come to that later. With this mitral flow velocity, you need to have a mitral annular velocity. That is the tissue Doppler on the crux of the left ventricle, that is in the medial annular velocity. And you have a lateral annular velocity as well, and you see whether the E by A ratio is altered or not. And the third thing you should look for is the tricuspid regurgitation, the peak velocity. These are the parameters and the cutoffs that if the E by E prime is more than 1, from this annular velocity, you see the E prime and the A prime. So you just feed to the machine will calculate the rest for you, and they will show you if the E by E prime is more than 14, you are dealing with a patient who may have a raised pulmonary capillary wedge pressure. And if you do a tricuspid, if you have a tricuspid regurgitation of more than 2.8 meters per second, that means this patient is having a pulmonary hypertension. And you have to do another thing, if you can, is if you look for the atrial volume, the left atrial volume. That is also very simple, like the same Simpson's method. You just trace the atrial volume. It will give these nowadays these machines will give you the atrial volume, but you need an atrial volume index. For that, when you are entering your patient, just take the weight of the patient and the height of the patient and enter it into the machine. The body surface area will be calculated by the machine, and everything will be given with respect to this body surface area. I will take another 5-6 minutes for this. So the mitral in the mitral inflow velocity, what you have seen that the mitral EA ratio is less than 0.08 and E value is less than 5. If that is your finding, you are more or less dealing with a normal left atrial pressure. So this patient's diastolic dysfunction is not that prominent. So you may not report this patient as a patient of diastolic dysfunction. So, and if you have a E by A ratio more than 2, the left atrial pressure is definitely raised. But there are some cases you get E by A ratio more than 2 in younger individuals, athletic patients. And in that case, the left atrial pressure raised may not be clinically important. And if you see that the EA ratio is less than 8 and the E is more than 50, or EA ratio more than 0.8, less than 2, you have to find out these three criteria which I was telling you: the E by E prime ratio, the left atrial volume index, and the peak tricuspid regurgitation velocity. If 2 of the 3 are negative, that means you are dealing with a normal left atrial pressure. So if you can now, if you can interpret our findings of the echo, whether the diastolic dysfunction is clinically significant or not. We will go from this finding of whether we are having a less left atrial pressure or not. That will be a better way to interpret and to give your reports. And these are the very easy parts. If you see the E by A more than 0.8, this is the mitral inflow velocity, pulse wave. If this is less than 0.8, you go for the E by E prime ratio. If the if the E prime ratio is less than 8, then probably you are dealing with a grade 1 or impaired relaxation. And here the E by E prime ratio will be less than 8. But only the E prime velocity, if it is less than 8, probably you are dealing with a grade 1 diastolic dysfunction, which is a impaired relaxation. So these two things let's take into consideration together to report a case of DD1. Then you have a pseudonormal pattern in which the E prime is definitely less than 8 and the E by E prime is somewhere between 8 and 15. That is, you don't have a raised capillary wedge pressure, but you definitely have a diastolic dysfunctions, and the restrictive part is, sorry, I forgot to put it in the remote. In the grade 3, if you have a restrictive, you will have an E by E prime, E by A ratio more than 2 and the E by E prime definitely more than 15. This is a very easy way to classify the diastolic dysfunctions. So these are the structural things we can find during your studies, in which we can see that if you have an early mitral valve closure with a diastolic fluttering, it's a case of a severe AR. A free alveolar collapse is due to pericardial tamponade. So if you are doing a case of pericardial effusion and you go into pericardial tamponade, let's find out whether the free wall collapse of RV is there or not. Don't look at the RA and try and report from the RA whether you have a RV wall collapse or not. We have definite sessions in which we will show you how to look at those cases, because we don't have patients along with us. The mid-systolic closure of the aortic valve shows that whether you have a dynamic LVOT obstruction or not. The systolic anterior motion, or the SAM, is very important to look for the HOCM and see whether there is a dynamic LVOT obstruction or not. There is a typical paradoxical motion of the IVS in left bundle branch block, or in a post-CABG patient in which there is a absent pericardium on that. So the gradual closure of the AV valves in the less dystolic dysfunctions, the absent A wave, which we seldom do nowadays. It's a M mode on the P wave, pulmonary valve, we seldom do nowadays because we have other parameters to look into. And the flattening of the IVS is seen in diastole, in which there is right ventricular overload. We will show you. The septal bounce is seen in pericardial constrictions. The bulged IAS towards the LA is seen in increased right atrial pressure, with towards the RA in the increased left atrial pressure. LV dilated, large EPSS was seen in LV systolic dysfunction, and so on and so forth, and diastolic dysfunctions we have told you. So these are the 5 mathematical principles that guide us to the further understanding of echocardiography. I'll be very short with it. This is the Doppler. Sorry, my thing is not playing in the animation. About the Doppler, it is the sound, whether you are coming towards the sound or you are going away from the sound, that gives you the Doppler signal in the constricted or in the spaced way manner. The Bernoulli principle is also taken into consideration, in which what we have learned from our school days is that where the velocity is high, the pressure will be low, and when the velocity will be low, the pressure will be high. And these two principles are taken into consideration by saying that the V1 multiplied by P1 will be equal to V1 multiplied by P2. And if you keep that thing, this translates into what we call is this continuity equation, in which we have to find out the area of the aortic valve. We see that the volume that is entering through the LVOT should be equal to the volume that is going out of the aorta. And what we practically do is we do a VTI of the LVOT, we do a VTI of the aortic valve, and we multiply that with the area. We don't have to use the area, you just use the diameter. So you can get the diameter of the aorta, means the aortic orifice, from this continuity equation, and this is very much utilized to see the aortic valve. And this is again age-old saying, what goes in must come out. So what goes in through one orifice has got to come out through the other orifice. And if you have a mitral regurgitation and you want to calculate the mitral regurgitation volume, then remember that what is going in through the mitral orifice should come out through the aorta. If there is mitral regurgitation, then this is getting split into these two parts. That is, some part is coming through the aorta and some through the mitral orifice. So to calculate this volume, you can just have the volume in the going through, that is the VTI through the mitral valve, and the VTI through the aortic valve, and if you subtract that, you get the mitral regurgitation volume. So these are again the basic hemodynamic principles, in which I'll go very fast, try and tell you. This is how you look at the left ventricular functions. The EPSS is less reliable if your patient is in AF, any valve pathology like MS, and if you have a mitral valve prosthesis. So in these, what we see, we look at the left ventricular ejection fractions, the end diastolic volume, the end systolic volume, the E by E prime, as I told you, the AR and A will show you later, the LA volume, peak tricuspid velocity, and this will slowly guide you towards whether you are dealing with a patient of systolic failure, whether you are dealing with a patient of heart failure, whether there is a pulmonary embolism in which you have an abnormal septal movement, the thrombus in the right chambers, if you have a dilated RA, the RV global hypokinesia, the McConnell's sign that we will show you later during the episode. And if you have to see whether you have a tamponade, if you have a huge collection in the pericardium, your heart will be literally swinging. You will get a swinging motion of the heart. The RA collapse, rarely the LA collapse is there, but you will always have to look for a diastolic collapse of the RV free wall, the IVC dilatations, the LV flow, tricuspid flow. And this is a picture in which the RV is hugely dilated. See, the RV is hugely dilated, and the IVS is almost constricted, and the LV is getting chinked. There is a little bit of pericardial effusion is also there, but you can jolly well understand that the RV free wall is not collapsing. Rather, the RV free wall is quite hypertrophied. This is again another picture to show you that how there is flattening of the IVS, which shows that the RV is hypervolumic. This is another picture to show that the apex of the LV is not actually moving at all. And in this case, if you imagine this case, you have taken a Plaque's view and taken a TCOS at this level, and you will not be able to get the correct ejection fraction, so you need to have the Simpson's method done on this patient. And this is the IVC size. The IVC size, if it is more than 2.21 millimeter, it is you have an elevated right atrial pressure by 10 to 20 millimeter of mercury. If it is less than 21 centimeter with a partial collapse of 50%, it is intermediate, that is 5 to 10. And if it have a normal IVC, it is 0 to 5. To my clinical understanding, the IVC what I get through the GE machines is more or less 14 to 17 millimeter. Anything more than 19 millimeter is raised right atrial pressure. So this is how you look at the IVC, and see, this is the respiratory movement of the IVC. And this is what a dilated IVC looks like. See, this is what I was talking about, that in spontaneous breathing, what you have in expiration, the IVC is maximally dilated. In inspiration, it is collapsed, and this collapse has to be found out whether it is more than 50% or not. If you have a normal volumic, the IVC if a hypervolumic IVC, the collapse you will not find, and if you have a hypovolumic IVC, probably there will be a paradoxical movement outward during inspirations. So in severe hypovolemia, the IVC is less than 15 with more than 50% collapse, and in hypervolemia it is more than 25, that is more than 21 with a little collapse. This is required. This is the right side of the heart. You have to look for the TAP C. The TAP C, the right atrial area, the eccentricity index, the RV fractional shortening, and the RV longitudinal strain. We will show you during the time. I have gone over by almost 20 minutes, so I will stop here. And this is how pulmonary arterial systolic pressure is seen from the tricuspid regurgitations. If it is high, more than 3.4, likely to be very severe. Low, less than 2.8, likely to be normal, and intermediate is between 2.8 to 3.8. That is the tricuspid regurgitation velocity. And this is how you calculate the right regurgitation velocity. See, in this regurgitation velocity, you have a tricuspid TR max PG of more than 44 and the TR V max of 3.3, which is more than 2.8. And this truncated look of the Doppler signal, this shows that there is some obstruction somewhere. And I will I'll finish up because I will leave it to Dr. Biswas to carry on with the valves now. Thank you.
Okay, thank you. Good morning, everybody. Good morning, mentor sir. And thank you, Dr. Paramartho, for making my job much easier because you covered half my talk. And slide দেখাচ্ছে কোথায়? The slides are visible? Okay. I have been assigned to talk on assessment of cardiac valves and pericardium, the basics. So I personally think you know many things about valve, and you do echo regularly. So I like to brush up the views, 1 or 2 points, and show you the clips. What are the things to be noted? One thing I must be very clear, that your eyes must be so sharp and you must be so focused that as soon as you hold your probe, your brain picks up signals and tells you that something is wrong somewhere. Otherwise you won't be able to detect any abnormality. Many of your echoes will be normal, even if there are serious abnormalities. So usually I start with the views, position, the pathology, anatomy, function, pathology, flows, and Dopplers. These will be all the basics. And the basic valve views are, as we all know, as Dr. Bhattacharya has told, it is the parasternal long axis view is the basic standard beginner's view. You have to be accustomed to the Plaque's view. Unless you bring a good Plaque's view, you cannot see the chambers valves, you cannot assess the hemodynamics. Once you bring a classical standard parasternal long axis view, you go into the parasternal short axis view, and then only you will be able to identify the physiology, the anatomy, and the pathophysiology of the valves. So this is the sacs aorta view. See the tricuspid valve, the pulmonary cusps, the Mercedes-Benz signs of the aortic valves. And this is the apical view. The best method to bring the good apical view is to put the patient in left lateral position, palpate the apex. The apex, if the apex is palpable, you put the probe in that direct position, and the pointer should be to the left shoulder and the face should be in the right shoulder. So you must remember, you will seeing the heart from the apex, not from base to apex, but apex to base. So these are the views, and there are certain parasternal other views, parasternal three chamber view, this thing, that thing. I'll go into details. So I start with the most important valve, the mitral valve. The mitral valve is actually what we see and what we assess and what we calculate is the mitral valve apparatus. Mitral valve apparatus has 5-6 parts. Now the leaflets, anterior and posterior, the papillary muscles, and the bridge between the papillary muscles and the valve are the chordae, 3 types, the annulus, the LA valve and the LV valves. So this is actually cadaver clip. Here you can see the chordae are attached to the leaflets, and this is the specimen. You see the number of chordae are projected from the papillary muscle inserted into the leaflets. So the actual valve morphology, just for a theoretical point, the diameter is around 4 to 6 centimeters square. There are 2 leaflets. The larger is the anterior and the posterior is the smaller. There are nearly 25 chordae. The subvalvular apparatus, and these together all are called mitral valve. And if you include the LA and LV, it becomes the mitral valve complex. And now the importance of LA LV is that because nowadays in the era of diagnosis and management of HFpEF, there is a atrial annular disjunction concept where you gradually the annulus gets pulled up with the dilatation of the atrium. So you must be knowing this basic point. Now what about the commissure? It's not a flat straight annulus, it's like a potato chips bend. So this concept you have to keep in your mind. Now there are 2 basic things. One is you have to identify the leaflets. You are seeing the mitral valve. When you put your probe in the apical 4-chamber view, you will seeing from down. So you have to identify the 3 parts of the anterior mitral leaflet, A1, A2, A3, and posterior mitral leaflet, P1, P2, P3. This is not the surgeon's view because surgeons usually approach to the atrium, and so the reverse is the picture, and there are 2 papillary muscles. So when you go for assessment, you must see whether, as soon as you hold your probe, you must see what is the condition of the leaflet, how is the annulus, can you see both the chordae, and what is the condition of the myocardium, what is the size or the thickness of the ventricle or the left atrium, is there any vegetation or thrombus. So just for theoretical part, there are 2 papillary muscles, anterolateral posteromedial. The anterior one has dual supply, LAD and D1, and the PM posteromedial papillary muscle has got single supply. So when you this is the 4-chamber view. The 3 parts of both the anterior leaflet, you don't see all the 3+3 components of the anterior posterior mitral leaflet. You see the P1 and A2, A3 in the apical 4-chamber view, and it's a AP lax view. You see A2, P1 and P3. So this basic thing you try to remember when you do. So when you give information to the surgeon, for example, it's a ischemic MR or is a papillary muscle dysfunction, it's better if you mention which part is the leaflet is dysfunctional. So second point, if it is not an ischemic heart disease, if it is a rheumatic heart disease, how do you it's probably rheumatic, because in rheumatic heart disease there is a valvular leaflet thickening, commissural fusion, the thickening is the subvalvular apparatus, there is diastolic doming, and there may or may not be MR. Associated AR may be there, but one thing you must remember, you don't get all points in all patients. I have faced such situations where you have commented in the report that it's probably due to rheumatic etiology, because that etiology, giving a etiological diagnosis by echocardiography is very important to clinician. Clinician shot back and made a big circle. How do you know it's a rheumatic? So you can face such situation. In that case, I usually follow this Vijaya's criteria. You see what are the criteria. There are 16 scores where you can put the score and tell the patient, the treating doctor, look sir, I have found say 10 points out of 16. So I feel through this criteria, you must give any reference that it's, to me it's a rheumatic heart disease. Second point, if there is a prolapse, if you think it's a prolapse, when do you call a prolapse? There is more than 2 millimeter displacement of the either anterior, posterior or both mitral leaflets. Whether it's there is thickening or not, whether it's a regurgitation or not, you must mention. Now, these are the thing you can see in short axis and modified plaques. And if you put a, you can very well see the scallops and the coding. And if it is a 3D echo, the delineation is far better. So I have got 3 clips. Now this clip, this is sometimes as I was telling, there is heavy mitral annulus calcification. There is thickening of the aortic valve. So whether it's, if it is an aged patient, you definitely favor degenerative etiology. But if it is a young patient, you also may think of a rheumatic, but remember, rheumatic mitral annulus calcification is rare. The caudy seems to be free. Now, the second clip, see the AML is prolapsing, the aortic valve is not thickened. So this is more in favor of rheumatic etiology. And the third clip, notice there is thickening, there is eccentric MR, and there is a hypokinesia in the basal segment of LV. So this is a definite ischemic etiology. So you, as soon as you get your probe, you must ascertain what etiology it should be. So many hemodynamic points I think we'll be discussing in the hands-on training. 3 methods of detecting doing Doppler: a pulse method by continuous Doppler method and color flow imaging. As we all know, but blue away, red towards you. So there are definite areas where you can specifically use the pulse wave, pulse Doppler or continuous Doppler. We'll discuss that later. Now, second is, third point is, the mitral stenosis is one of the common disease. Now, there are definite points where we will be discussing in second half, where how you can assess the severity of mitral stenosis. I am going to detail, and how you can definitely say it's a rheumatic. Of course, rheumatic is the most common etiology. How you can assess the mitral valve area and give your report to the surgeon or the treating physician, and one thing you must remember, if when you measure a pressure half time, the third method is the appropriate, because there is certain, sometimes you get high velocity in the initial part and slope in the later part. The actual correct method is method C. So, and when you put a Sachs view, you can very clearly see the commissural calcification, mild PE, the left part, and there is also probably left ventricular hypertrophy. Now, this is a rheumatic valve, dilated LA, LV with MR. Now, when you get a MR, what are the things you like to see? Mechanism, severity, what is the hemodynamics, how big is the LA or LV, what is the probable pulmonary pressure, what are the associated mitral valve findings. So, if you get an MR, as soon as you detect what kind of MR it is, you must see if it is a degenerative MR, whether it could be due to degenerative mitral calcification or not, and there are certain CT-based readings where you can assess the severity of the mitral disease. So, there are the three classifications of Carpentier, type 1, type 2, type 3. This is the trace MR, mild MR, moderate MR, and the severe MR. So, these are the basic MR, and there are three methods of where we assess: color Doppler method, jet area ratio, and the density and the shape of the envelope, the EROA calculation by PISA, and sometimes, as Dr. Bhattacharya was telling, by continuity method. Now, sometimes the diagnosis is not very difficult and the assessment is also not that easy. You can see this is an ischemic MR with an eccentric jet. So, this is each regurgitation, each stenosis needs separate time and discussion. These clips are simply foods for thought for you. Now, PISA method we will talk in detail later on when we talk of hands-on training. Now, aortic valve. Now, as soon as you go into aortic valve, focus your vision or focus on aortic valve, you must find out, you want to see whether you think it's a bicuspid or tricuspid. If it is a normal valve, even a normal bicuspid valve, you may miss it. It's very commonly missed. You must watch out for the aortic bicuspid valve in the very beginning when you get a parasternal long axis window. The aortic stenosis can be due to rheumatic or due to degenerative. So, there are definite points, and what are the measurements you need to give along with the degree of stenosis? You want to give a annulus diameter, the sinotubular junction size, the sinus diameter, and the proximal aorta size. So, these are the points you can see. This is the LVOT diameter, the annulus diameter, the sinus diameter, the sinotubular junction diameter, and the proximal aorta diameter. This will be of immense help when the surgeon does the OT. Now, bicuspid valve can be of several types. Now, the commonest is one where your right leaflet and the left leaflet or right RCC, LCC gets fused, and sometimes the RAFI is very vague. You cannot find a RAFI sometimes, and though majority case you can find. So, sometimes it can be unicuspid also. This is a unicuspid aortic valve with a RAFI. Though the unicuspid valve should not be having a RAFI, we did a case where there was a very atypical case where you saw there was a RAFI. And about AR, oh sorry, I didn't finish. As soon as you assess the AR, you must give what is the status of the LV function. You must give whether you feel it's a high flow, high gradient aortic stenosis, low flow, low gradient, high flow, high gradient. There are 4 combinations. So, you must be giving all the measurements, and the clinician will assess Whether if it's a low flow, low gradient, in that case he may advise a dobutamine stress echo. So how to measure LVOT diameter, we'll see later on. The AR, the severity of the AR, AR can be as like MR. You can have a qualitative measurement by simply seeing the area of the jet ratio between the jet area versus the LVOT area, the degree of the semi-quantitative method by vena contracta calculation, and the third is by PISA. So the third one is the tricuspid valve. Tricuspid valve is the probably the most neglected valve, but nowadays we are more focusing on the tricuspid valve. There are 3 leaflets. It needs a bit of modified view from the parasternal long axis. It can be seen also in the subcostal view. You can see, and when you assess a tricuspid valve, you must be mentally calculating what is the RA pressure, because RA pressure calculation will give you the pulmonary artery pressure, and in that case you must determine whether the patient is having a pulmonary hypertension or not. So these are the views. Without going into detail, I'll proceed. Now this is a case we did it because tricuspid valve regurgitation calculation is very important, because as Dr. Bhattacharya was telling, it's one of the 4 components of the diastolic dysfunction assessment. Suppose you give a wrong TR velocity gradient and there is no pulmonary hypertension, and you calculate the PA pressure to be around 40, now the normal patient or intermediate group patient will fall into the HFpEF group or the grade 2 or 3 diastolic dysfunction patient. So, and when you focus on RV, I've got 2 clips. So you must see whether the tricuspid septal annulus is displaced apically in case of abstain, or the attachment is normal and the RV itself is dysfunction. This is the second clip is from ARVC, and the tricuspid regurgitation gradient and the severity can be assessed. You can go through the literature. Now, what about the pericardium? As soon as you go into the get your probe and get a parasternal long axis view, you want if the pericardium is probably most refractory structure in the plaques view, and if it is thickened, your eyes must be so sharp, you must be so practiced that your mind will tell you this pericardium is not normal, even if there is no pericardial effusion. Whether it's thickened or not, thickening is more than 5, whether calcification, whether is pericardial effusion. Normally there can be pericardial fluid, but it is not effusion. If there is effusion, how big the pericardial effusion is? What are the hemodynamic effects? Is there is constriction, or there is associated finding that suggests the patient is having constriction or masses? So you can see this. If you think there is a pericardial thickening with certain degree of fluid, may or may not be, you see the first clip, there is septal bounce. In that case, if the LA is big, the patient is plethoric, you must think for the first impression, the patient is having constrictive pericarditis. And the IVCC, it's also congested. And this one is the classical tamponade. So this is the RV collapse, and there is one basic thing. If there is effusion with pleural effusion, how to determine? Usually the pleural effusion is located anterior to aorta, and it's behind aorta, and the pericardial effusion in front. Thank you.
We will start with the hands-on session now. Our hands-on trainees, you can split yourselves into 2 parts. We have a set of Philips machines on that side and a set of G machines on this side. And please, you come forward and let's start the session. Sir, we'll start the hands-on session and we'll have 2 machines with display. This hands-on training program, I'll call out the names. You please, 9 of you come to this side. Bipasha Ghosh, Chandroma Das, Debari Chakraborty, Debarchana Sarkar, Khalid Kaushik Sarkar, Novanil Bishwas, Oishi Ganguly, and Pratik Kumar Singh. You please come to the right side of mine. And another set will be Raka Thakur, Rakhi Chakraborty, Ram Rahul Ghosh, Ranjini Rai, Shobhyasachi Rai, Shubhojit Pal, Shubhankar Dotto, Tomal Priya Bormon, and Tridev Kanti Bhattacharya. You come to the left-hand side of mine with that machines. Kaushik Sarkar to this side, perhaps, yeah, this side. So are we done with the division? Yes. Perhaps.
So we'll be starting with one. However, we'll start with one machine.
Yes.
Okay.
You will be there.
Yeah. So you want to, yeah.
Be there near the. Thank you, sir. একটা ওদিকে দিতে পারো হ্যাঁ ওকে না not necessarily that someone who is doing the echo has to say. Let someone do, the other one can describe.
Yeah, otherwise I think that would be better because this is little cumbersome. It's little cumbersome. I think you can just hold it while I'm talking. You can have just ECG because that's very important to have the ECG. They have it, huh?
I don't know.
Yeah, she has the ECG.
Check. Hello, hello.
So you can keep it. Yeah. Hello. Yeah, I think we are here. So I think we'll start scanning the normal patient. I think all of you are doing echoes, isn't it? So we may not be really have to go into very basics of it. But see, the first thing I always now see, these are all modern machines. They have got a very good frame rates, but always remember that if you are staying in a metro city, you know how expensive the real estate is, isn't it? So we have to make a big use of all this real estate that you have on the Echo. Okay, so we have got this big real estate here. Okay, so your LV should be completely filling up your sector. Okay, and as you can see that we also have the frame rates here. Okay, so what is the frame rate currently? 59 hertz. Okay, so we can always reduce it by reducing the sector width. Okay, so we have a sector width here. So here, as I am reducing the sector width, you can see the frame rate is improving. Okay, see I'll tell you, among all the modalities, Echo has the best temporal resolution, and we have to make use of it. Okay, and Doppler has the ultimate; no one can beat it. Okay, so we have to get the best one. So always have a sector width which should be just enough to see our structures. Okay, just don't go on a very huge sector widths, and and always remember about the depth. Okay, we don't want to see the stomach, isn't it? So why keep something like this? Okay, so whenever you see somebody's echo, recorded echo, you know whether he's thinking about the physics and instrumentation or not. Correct? Then as you know that we also have here the focus. Okay, so this focus should be at the place where we have the yeah, your focus is here, correct. So your focus should be here where you have the where the structures that you are interested in. So what does the focus do? The focus does narrows the beam. Okay, as you know, the ultrasound beam while passing keeps on fanning, correct? So as you go deeper and deeper, your lateral resolution reduces. So focus, what it does is that it narrows the beam at the center. So it makes it hourglass, correct? So here you want it. But now what has happened is that the very new machines, they have the digital beam formatting, and this focus thing has completely gone now. You will not find it in the high-end machines. The focus is completely removed. So we have it here. Then see, I always say Echo is a work of art. Okay, so it's both science and art together. So your image should be aesthetically pleasing. So you will always adjust the lateral gains. Okay, so you have got these lateral gains which take care of every sector here. Like here, I increase the gain in the center, I am reducing it. Okay, so always try to keep it. Always your hand should be here to keep on adjusting. We don't want see, always the gains will be here very high because the ultrasound is traveling less distance and going back. Correct. The lower gains also, always there will be a very high gain at the pericardial reflection. Unnecessarily don't think that is a very thick pericardium. Okay, reduce the gains there. We don't want any gains in the cavity, try to reduce it, but we want a good gain at the valves, correct? So that way keep on adjusting, it should be very aesthetically pleasing. Then obviously you also have other factors to make the the image more diagnostically useful. So those, apart from the overall gain and the focal gains, is to look at the compression. Okay, the first, the choice of your penetration, that means your frequency. So as we know that we want to keep the frequency, the lower the frequency, higher is the penetration. But the frequency, when you reduce it, the waves become, they are longer. Okay, so that means what happens is your resolution goes down. For the higher resolution, you need higher frequency. So you have a trade-off. So just use the best frequency that you can have, and generally you have that those adjustments here, where some machines give you the range to change, some machines tell you whether you want the resolution high or whether you want the penetration high. Okay, so you can always choose the way you want. Okay, so if you want if it's a thinner chest and younger child, lesser penetration, go for a higher resolution, and so that will choose automatically the higher mean weighted frequencies. Okay, because generally you have a range of frequencies coming. Now you don't have only one frequency, correct? Then second way that you can change is the harmonics. Okay, so you all generally now all the machines go on to harmonics by default. Okay, so here is the harmonics. Now you would say, what is the point now, because all the machines go on harmonics? The harmonics were actually developed, you are very interestingly, they were actually developed for the contrast. Okay, because what was happening that when you send your ultrasound on the contrast bubbles, okay, what resonates back is in the first harmonics or the second harmonic. Okay, so that is why they develop the harmonic imaging. Okay, so that means you send 1.8 megahertz and you receive only 3.6 megahertz. That was the first harmonic. But when they were doing it, they suddenly realized even the regular 2D echo images also were looking much better. Especially what was happening was that they found that the apical clutter reduced and the endocardium became very sharp. Okay, so now everyone has gone on to the harmonics. Never use harmonics in pediatrics. Okay, now what is the problem with the harmonics is that all the leaflets look rheumatic. They all look very thick. Okay, now all of you, your generation has seen only harmonics, so you can relate with this thickness of leaflets. But when we shifted from the regular frequency to harmonics, suddenly we started finding the leaflets very, very thick. Okay, so the leaflet thickness is, but now you have got used to it, is fine. But suppose if I go here and I change the harmonics, see now the leaflets have become very thin. Okay, they have become thin. Okay, but as you can see, generally the apical clutter will increase. The apical clutter is increased. Okay, you can see the apical clutter has increased. The sharpness of the endocardium has gone. Okay, so that's why in adults we always shift to the harmonics. See now how the endocardium looks so better. Okay, and the apical clutter is gone, but the leaflets are so thick. Okay, so if you really want to make out something that whether the leaflet is thick or not, go on to the non-harmonic image and look at it. Okay, so that is the harmonics. So you adjusted the sector width, you adjusted the depth, you adjusted the focus, you adjusted the transverse gain, overall gain, harmonics, choice of your frequency. Now also look at the logarithmic compression. So there is always a button of compression. Do you have the jelly here? Just keep the jelly with me. Yeah. So let us look. There is always the button for compression. So here it is written as compression. Okay. So this is called as logarithmic compression. So so what it actually manipulates is the grayscales. Okay. Now what happens is that you are getting some 0 to 250. Suppose you have got only 250 grayscales. Okay. Those are also too much, because all of us in this light will appreciate only 30 grayscales. Okay. Or rather less 30 grayscales. When your ambient light goes down, we can start appreciating 25 to 30 grayscales. The radiologist or the echocardiographers can identify up to 40 grayscales. Okay, but so while you are getting the decibels which are coming back, okay, you are sending the ultrasound, you are getting the decibels back. Okay, higher the decibel, higher echogenic structure, lesser the decibel, lesser echogenic structure. So what you are doing, all those decibels you are giving grayscales, correct? But you really don't, but you are getting thousands and thousands of decibels coming back to you. Okay, from 0 decibels to 1000 decibels, anything can come back. So you can't give grayscale to everyone. Okay, so you are going to choose a range which is diagnostically important to give those grayscales, correct? So those grayscales, how many grayscales you want to give will decide the logarithmic compression. So suppose if I reduce the compression, what will happen? There will be less grayscales. You will see everything very, very sharp, but you will not see any myocardial texture. If I increase the compression, the image will become very smooth and you will see many, many grayscales, okay? But the image will not look sharp, okay? So here we are generally, so I'll get out of the harmonic first to show the effect of this thing. If I go on increasing the compression, you can see that it has become very, very smooth, okay? While if I go on reducing the compression, it has become very, very sharp. Okay, so when you want to just look at the endocardial delineations, I think lower compression is good enough. Okay, higher compression, suppose if you want to see the myocardial texture, if you want to look for vegetations, okay, you want to have more grayscales. When you are looking at the myocardial perfusion on contrast, you want more grayscales. Okay, so that way you change the grayscales. Okay, so always make use of all these buttons. Okay, so you know the how you can make the not only aesthetically pleasing, but also that can always improve the diagnostic. Okay, it's not, that's why it is art and science both. Okay, so this is how it is. And now what we will do is that I'll just escape from this particular that measure thing. Where is the escape button? Yeah, erase. Yeah. What scale? Which scale you're seeing? This color? Yeah, color will come. So first we are just looking at the 2D echo image, correct? So this is how we are going to get it. And then, so what I'll do is I'll just first talk about the, taking the images with, making good use of it. Now I'm here in the short axis view, correct? Now I really don't want these things down, so I can always change the depth. Okay, so here I am at the level of the mitral leaflets. Okay, so you know that the LV, first you are going to take the base, and then you are going to take the LV at the level of the mitral annulus, mitral leaflets. Okay, now always remember that if I take the pointer here, at this base you are dividing the LV into 6 segments, correct? So you know this is the RV insertion point, this is the RV insertion point. Okay, so this is the whole septum. So you have got an anterior septum and inferior septum. Now anterior septum is supplied by the LAD perforators, because LAD will be running in this groove. So it will supply the anterior. Almost 2/3 of this is supplied by the LAD, while the PDA will be running in the posterior groove. So the PDA will be supplying this territory. So you have got 2 segments here, okay, anterior and inferior segment. Then you have the anterior wall, okay, and on the opposite side you will have the inferior wall, correct? Then what remains is the papillary muscles. Okay, papillary muscle. Near the papillary muscle is your lateral wall, also called as anterolateral wall. And on this surface between the inferior and the anterior wall, you have got lateral, which you call as now inferolateral. But you can call it posterior also, because it's very easy to say lateral posterior rather than anterolateral, inferolateral. It becomes very easy to say lateral posterior. But remember, the accepted nomenclature across different modalities for lateral is anterolateral, and for posterior is inferolateral. Okay, so that is the one that you should remember. Okay, so when you go down, you have got the, you are at the level of papillary muscle. Always adjust again so that you don't waste much of the time. At least you should be seeing both the papillary muscles, the anterolateral and the inferoposterior papillary muscle. Again, you have got the same 6 segments here. Okay, and when you come to the apex, okay, when you are near the apex, you have got only 4 segments left. Okay, so what is not there is your posterior is not there and inferior septum is not there. Okay, you have got only septum. Why? Because generally the apical septum is supplied by LAD. You don't want now any differentiation. So that is why you have got only septum here, and the lateral wall is gone, because you know that the diagonals will be supplying the anterior wall here. Then you have got lateral wall. There is no more posterior wall. You have got only inferior wall. So you have got septum, inferior, lateral, anterior. 2 segments which are missing is posterior and inferior septum. Both are removed from there, because generally all the apex is supplied by the type 3 LAD, or even type 2 LAD can also supply the entire apex. Okay, so you have got all the above. Now, most important thing, okay, while we are going to other places also, I'll again talk about the optimization of the images, because your echo should look like a work of art. Okay, it should be very pleasing to see, and also to compare. Your interstudy variability should be low, so you should have a certain discipline of recording it. Okay, always record 3 bits. Okay, and if it is AFib, at least 5 bits. Okay, at least 3 bits you should record, never less than 3 bits. Okay, and secondly, what happens is you sometimes take prospective bits or retrospective bits. When you are taking retrospective bits, you should, while you are looking at this, I would say 1, 2, 3, and I will accept, because I know that those 3 bits it was stable, because that is retrospective 3 bits. If it is going ahead, then the moment I press, I will hold my hand steady to see 1, 2, 3, and then I'll stop. Correct? Why it happens? I will know. I'll tell you what happens is I'm adjusting this, accept, adjusting this, accept. Then what is gets recorded is something like this. Something like this gets recorded. Okay. So always see, take one view, say 1, 2, 3 in your mind, accept. 1, 2, 3 in mind, accept. Okay. Otherwise, many people I find it is like this. Okay. Whenever I read the echoes of my fellows, I'll find something like this because they are adjusting and then accepting. The moment they see a good image, they accept. Okay. Then it looks very, very shabby while you are reviewing the echoes. Okay. So this is how it is. Then secondly, all those tricks I asked you to get the best 2D grayscale image is in this view. What is my idea is to look for the endocardium. Okay, so I should get the best endocardium here. Okay, in all the views. Okay, if two consecutive segments I don't see endocardium well, that's supposed to be the indication for using the LV opacification contrast. Okay, so I have to see the endocardium well. Why I have to see endocardium well is because epicardium is generally seen well anyway, because there is a pericardium which reflects it very well. Okay, so whenever there are two objects which have got a very different acoustic impedance, okay, at their interface you get an extremely good specular echoes, okay, very good sharp echoes. Okay, so myocardium to pericardium, you see a very nice sharp ones. Okay, blood to myocardium also you should get it, only generally laterally you may not see it so well. Why do you want to see the endocardium is because to appreciate the wall motion. Now what happens is wall motion is actually a misnomer, because it means that you are just looking at the motion, but you are not actually looking for the motion. What you are looking at the local segmental activity which involves endocardial excursion and systolic thickening. That's the healthy myocardium. Okay, there should be endocardial excursion towards the center and systolic thickening. Okay, because the endocardium and epicardium do not move in the same speed, so there is a thickening. Okay, both should be appreciated. If I just look at the motion, even an infarct territory may also move, because the healthy segments which are holding it can also move it. Okay, so that is supposed to be just translate. It's not translation, but it is a pseudo motion, because the healthy muscles on both sides are also pulling it up and down, but that segment will not show systemic thickening. Correct? That is why it is important that you take one cursor on and keep it near one segment and look at the endocardium going towards it, and also appreciate the systolic thickening. Now, the basic principle of looking at the regional wall motion abnormality, which is expected out of echo, which is very, very basic, but most difficult to master, is appreciation of RWMA, regional wall motions. So how do you do that? The trick is never look at the entire LV together. Okay, just go segment by segment. Okay, so here there are 6 segments. You put your cursor 6 times here. Okay, and appreciate the systolic thickening, and suddenly things will improve, rather than looking at the entire. Okay, so every time put it, look how the endocardium moves towards it, look how the systolic occurring. Okay, so that is how you go for everything. So if I am in the long axis, if I am in the long axis view like this, now again I have got 6 segments. These are the basal segments, these are the medial segments, and these are the apical segments. Each one I will keep it, and also I will look for systolic thickening. So that's why you should have a stationary object, endocardial visualization, epicardial visualization to assess the systolic thickening. That is, I'll never look at the entire LV together, I'll see bit by bit for RWMA. Okay, so this is very important. Then, as we discussed here, all the short axes, I'll again get you oriented for the 4-chamber, 2-chamber, and long axis axes. Okay, so when I'm in short axis view, always remember my 4-chamber view is going to run through the inferior septum and to the lateral wall. Okay, it will be directed like this. Okay, so if I got the, I'll take this and I will put it across it. Okay, okay, can I get the line here? Can get the line probably if I am measuring it. No, I don't think I'll get the, I think in the measure probably I'll get the line. If I go onto the measure and I take the diamond, shall I get a complete line there? If I put the, if I go into the, yeah, so I'll just I press the measurement. Okay, okay, so not Q app. No, I just want a simple measurement just to get a line. That is what I wanted. Just put, yeah, so, but I'm not getting a line there. Or I'll get a line after pressing. No, I'm not getting the line there. No, but I'll get only vertical line. Okay, okay. I'll freeze it. I'll try that. Let me get it here, and then I get no. I'm not getting it. Anyway, so this is the direction of your four-chamber view. Okay. Now, what is the direction of your erase this. How? What is the direction of your two-chamber view? Two-chamber will cut through the anterior wall, will run parallel to the septum, and will go through the inferior wall. Okay. So that is your two-chamber axis. Okay. And once you have, and what is the axis for your long axis? Your long axis runs through the anterior septum and goes across to the posterior wall. Okay. So that is why when I am in the base, my axis will be through the LVOT in the long axis. So that is how those three axis, long axis are there. Okay. So that is why when I am here in my four-chamber view, so what I am cutting through is at the base is, this is the entire lateral wall, okay, and this is inferior septum, okay, not the anterior, okay, and this is the apical septum. So this is my inferior septum. So that is why when four-chamber, my basal and mid is supplied by the PDA. Okay, while the apical septum is supplied by the LAD, and this all my lateral wall will be supplied by the obtuse marginus coming from the circumflex. So when I am in two-chamber, now the septum is no more seen, we are parallel to the septum. What we see here is the anterior wall, okay, supplied by all the diagonals, and this is my inferior wall which is supplied by the PDA, correct? So this is it, and then when I go to the long axis view, also called as the three-chamber view or the apical long axis view, what you are seeing is the anterior septum, okay, and not only that, okay, so it's not only the anterior septum but the here, okay, and this is my posterior wall, also called as the inferolateral wall. Now always remember, the posterior wall is a watershed zone. It may be supplied by a PLV branch coming from PDA, or it may be supplied by the distal obtuse marginal also. So PLV is a watershed area. Okay. Now this is the anterior septum, and as I see this view, we were having the proximal, mid, and inferior. So always remember, the proximal septum will be supplied by the first septal perforator. So when you see regional wall motion abnormality coming from here onwards, you know that the MI is post S1. Okay. After the first septal. While your akinesia starts right from the base, you know that you have got a preseptal occlusion, okay, which is a very bad sign. Okay, so that is how you get the idea. Okay, now what we will do is that, so I think we'll instead of just going through the standard one, the right ventricle we want to assess, always take the right ventricle in the center, and it is called as the RV focused view. Okay. Now whenever I am looking at the four chamber, the same thing. I will never take a four chamber like this. If I want to see the LA, I will check the depth so that up to pulmonary veins only I will be able to see it. Okay. But when I am looking at LV regional wall motion abnormalities, I will keep the mitral there. Okay. So that is how I will be looking at it. Okay. So then I will come to adjustment of color Doppler and Doppler. Okay. So what we will do is, color Doppler here, you have a color window, okay, this color window which is showing you flow data in terms of velocities and direction, okay, only the things which are happening inside this particular window. Okay, what is this doing is, obviously you know that in one direction it is showing you the shades of red, which is the by convention the flow coming towards you, and the one which is going away, different shades of blue, which is the flow going away from you. Now always remember, whatever you choose the color map here, look it carefully. If the flow is towards the probe, as the velocity goes on increasing, the color shades are changing. The fastest one is yellowish, okay. Intermediate is medium red color, while the lower flows are dark red. Okay, whatever goes away from me, dark blue, medium blue, and very, very light blue. That tells you about the velocities. How does the machine, what does the machine do? The machine does it in the simple ways. Okay, first what it does is, it divides this entire space into multiple vertical ultrasound beams, okay, and in each Doppler beam it puts 8 uh, pulse wave Doppler signals, okay. So pulse wave, you know, no, the pulse wave has got a gating, that means it has got a volume, pulse volume, you can keep it bigger or smaller, okay. So what it does is that if for each ultrasound beam it is putting 8 pulse volume samples, okay, and each pulse wave samples for all these ultrasound beams here, it is going to find out the mean velocity, neither the peak nor the low. It is going to find out the, at that particular instant in cardiac cycle, it is going to take the mean velocity, and that mean velocity will be mapped as per the color scheme, okay. So why I told you about this instrumentation is like this. If I keep this color window very, very wide, there will be too many calculations for the machines to do, because now there will be multiple ultrasound beams, each one with 8 PW samples, correct? Now you would say, how can 8 PW samples can cover this entire area? What it does is that it will measure it here, 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 it will measure it here. And in between where is there is a missing data, it is going to give intermediate color. Okay, so this is all virtual reality. It's not actually the true flow that you are seeing. The flow is measured, because imagine it has to measure so many pulse within seconds and update it. Okay. So there is a lot of Fourier transformation mathematics happening at the back, okay. So in between the pulse wave sample, it is going to give you intermediate colors, okay. So it is not a very linear flow mapping, correct. So why you should know this is because in that case, never ever keep the color window very, very large, okay. So something like this, we have the color window, yeah, this width, you have got the color window box size here. Never keep it like this, okay. That means you don't know the instrumentation, because see what is the frame rate now, 10, because the machine has to do so many calculations, okay, that it cannot afford to create one frame over the next RR interval. It is going to take a long time to make one frame, then long time to make one frame. So what it is doing, it is only doing 10 frames per second, okay, which is useless, because in RR interval, if you are getting only 10 shots of your color flow, you are going to lose a lot of data in between. That means your temporal resolution is very, very poor, okay. So never make like this, okay. Neither make it very huge, because for the simple reason, in this direction also, if there are only 8 samples going to be placed, intermediate data is actually just created by the machine, which is just an eyewash, okay. So always you can keep, see, the moment you reduce the width of this color window, you can see how it is changing from 10 to it is becoming 22 to it is becoming 35. It doesn't change much by changing the axial length. It doesn't make much difference by changing the axial length. It does make little bit, but not too much, okay, because obviously the ultrasound beam has to travel longer now when you go deep, correct. So always keep the color window just enough to see one event at a time, okay. So don't be like, you know, you don't be so greedy that I want to see the aortic flow also, mitral flow also in one window, okay. So always rather scan the entire echo image by moving your color box, okay, rather than going by this shortcut of changing the box size, okay. Okay, because then you are losing on to temporal resolution, okay. That's why you should know the this thing. So always keep it skinny, okay, and a long one is okay, it doesn't make much difference to the one, but not obviously going from all the way from the apex to down, okay, because as you can see that as I move towards the apex, it has become 43, if I go down, it is becoming 30. For the simple reason that now the ultrasound beam has to travel longer, so one frame is being created much longer time, correct. So that is why always try to use the smallest color window to get the best temporal resolution, okay. So that is the one principle. Secondly, how do you adjust the Nyquist limit? So what happens is, as you know, all of you know, is that as the velocity in one direction starts rising, and as it crosses this 61.6 centimeter per second, okay, and if it becomes say 70 centimeter per second, now what happens is that the machine doesn't know this is a flow which has been moving in this direction or whether it was moving in the opposite direction. So what it does is that it starts giving it a color which is in the opposite direction. So what will happen is that the moment you become 65, it will be lighter blue. The moment you become 75, it will be medium blue. The moment it becomes 90, it will be dark blue. So that means it will all wrap around. Okay, that is how the color scheme will be given. And this Nyquist limit issue is a fundamental issue of physics. Okay, so that is why it will be there for both echo also and for the cardiac MRI also. The same aliasing issue is there in both the modalities. So that is why choosing the Nyquist limit is very important. Okay, so in a color Doppler, okay, in a color Doppler, since color Doppler is basically based on the pulse wave Doppler, the Nyquist limit issue will be coming. Okay, color Doppler doesn't use CW data; it uses only pulse wave data. Okay, so that is why there is always the issue. So there is another way that you can do to prevent the wrap around if you want to see higher velocities in one direction or you want to reduce the Nyquist limit in one direction, is just by changing the baseline. If I take the baseline up, I am reducing the Nyquist limit in the direction of my probe, or if I go down, I am increasing the Nyquist limit towards the probe but reducing it in the opposite direction. This change in baseline, you will be using it for the pizza, okay, because in pizza you want to create aliasing. Okay, here you don't want to create aliasing, so you generally keep it in the center. Okay, so that's the first thing about the color Doppler. Okay, so next time your color Doppler should be like this, no big windows. Okay, now let us go for the PW. Now suppose if I want to go for a PW, when I am taking the mitral flows for diastolic function assessment, the PWs should be at the tip of the open mitral leaflet. So once I have got my cursor on, okay, once I have my cursor on, where is the cursor here? I think the cursor comes, okay, anyway, I'll go for the PW. Okay, so yeah, you have the PW here, correct. So I'll take the PW here, I'll keep it at the open leaflets. Okay, so I'll take the, and I'll tell you how to adjust the baseline. Okay, so the first thing is that my PW is at the level of the tip of the open mitral leaflet. That is the place where I will take velocities, E velocity, A velocity, E by A ratio, E deceleration time and all. However, if I want to take the duration of say A wave, it's very difficult to get the duration, the beginning and the end here. So in that case, what do? In that case, you bring the PW towards the annulus and now you will see a much sharper A wave, much sharper A wave. Okay, you can see a much sharper beginning and the end of the A wave. So when you want to see the durations, like say isovolemic relaxation time, A velocity durations, that time you bring the PW towards the annulus. Okay, while when you want to see the velocities, E, EDT, A by A ratios, it should be at the peak, correct? So that is one thing. Now, once I have got it, now you will ask me how to adjust the PW gains, okay? So there are two things, rather three things to adjust. One is what is the gain setting of this PW spectral Doppler and where should be I will be putting my baseline and what would be the, again the logarithmic compression. Let me tell you something about the PW, what it is doing. On the x-axis, you have got time. So it is showing you the Doppler signals over time, okay? And on the y-axis, it is showing you velocity. So it is showing you velocity over time. So any curve that you get, the area is velocity time integral, okay? Because you are multiplying velocity with time. So that is why VTI. Okay, so any area under the curve is velocity time integral. That is one thing. Secondly, does the how do you know that I have got the best gain setting for the PW? Okay, the best gain setting is like this. Suppose if I am seeing the Doppler like this, I will go on increasing the PW gains. So how much I should be? So let me first reduce the speed first just for the second, and I will go on increasing the gains. Okay, I have increased the gain. Should I be keeping this gain or should I be keeping this gain? No, because when I reduce the gain, the velocities are reducing, and when I am over gaining, there is a too much of blooming and feathering. So what do I do is that I just go down, okay, till I get it black, okay, and then I go on increasing till just watch this space, the background space here, okay? I should get some noise there, and that is the time when you stop increasing the gains, okay? So here I am increasing the gains till I get a little bit of noise here. Perfect. So this is the gain where I have got a little bit of noise here. That is the time I stop. This kind of a gain setting is there across the modalities. Even in the MRI, when they want to look for the gadolinium, they do the same thing. They will go on making it black and go on increasing till they see some noise in the healthy region. Then they know, okay, now I can look at the fibrosis. Here the same thing. You go on increasing till the black background shows some noise, but not excess noise. Okay? That is the time when you are probably getting the best signal. That is one thing. Secondly, your swift speed for measuring VTIs, for measuring the velocities, for measuring the durations should always be very, very fast. The minimum that you should be keeping is, okay, the minimum that you will be keeping is here. You have got the, the swift speed here should be at least 100. Okay, you will get it to somewhere 75, 100 mm per second. Minimum it should be 100 or above. Okay, why? Because now suppose if it is as the Doppler spectrum is my accuracy of measuring velocity time integral and peak velocity will improve, and there will be a better inter observer variability and better interstudy variability. If I am taking this, suppose at this swift speed, okay, and now if I try to take the velocity time integral, I can make lots of mistakes, correct? So unless I make it fast, I cannot, okay? Now some of the machines allow very fast even after you have acquired it, okay? And while some of the machines you acquire at a higher speed, okay? So both ways you can remember at least it should be 100 milliseconds to be the best, okay? So we talked about the gain, swift speed. Now what should be your velocity range? The velocity range and the baseline. If I am looking at the mitral flow by PW, I am not interested in the reverse flow. It is not MR, I am going to look at PW, okay? What I am interested is only the forward flow. And as I told you that all of you are staying in the metros, you know the value of the real estate. And what real estate we have here is only this much Doppler strip, correct? So I don't want to see anything below this. I just want to see only this. So I will take the baseline down, okay, because I don't want to see the event, okay? I will see only in this direction, and that direction I will increase the scale just enough, okay, just enough. Just enough that I can see the peak velocity here, okay? So I will, it's okay, 100 is okay for me, okay? But I mean 120 is okay for me. I don't want too high or too low, because if I do it with a very, very high scale like this, again the problem is that my chances of measuring the VTIs will reduce, and if I make the scale very, very low, then I am going to get the aliasing. See, now what has happened? Now what has happened is, now my baseline is here, I 60, and I know that the Nyquist limit is 62, so any velocity going up started showing you from the opposite side. As the velocity went slightly higher, it was shown here, and the highest velocity in this direction is now come here. So it has wrapped around like this, okay? So these peaks are wrapped this way. So similarly on the color, it will look like from the faint blue to dark blue. The highest velocity will now look dark blue, correct? So that's why it has wrapped around, okay? So the similar thing what I will to do is that I will take the baseline down, okay, and I will increase the scale. That means the Nyquist limit in that direction, that is, it is just sufficient for me to look at the peak velocities, correct? So you got that point. Now the next point is, what does this grayscale tells you? Okay, what does this grayscale tells you? Okay, I'll just take one better view, then we will discuss about that. Okay. So what does this is called as spectral broadening or the grayscale, okay? So what does this grayscale tells you, okay? Suppose if I take a time point here, okay, and if I look at the velocity here, okay, Then in this particular time point, I'll just put some vertical measurement there. So I can just, 1 minute. I will just take the time duration. So like say if I take the isovolemic relaxation time or something, I can take the I will take this distance, or yeah, I'll just this way, correct. So here, so now, or then it goes off, fine. Okay, so what I will do is I'll just take and I'll move this away. Okay, if I take this particular time point, okay, you can know that at this time point, okay, there is a very dark color or the very bright white spot is shown here. Okay, while down here there is gray and almost black here. Okay, so what does it tell me is that most of the velocity, most of the RBCs, the quantum of RBCs which are moving at this velocity. So that velocity has been shown with most brighter image because most of the quantum of RBCs are moving at that. Okay, and there would be very stray ones which are moving at low, or when it is black, that means almost no RBC is moving at that particular speed at that particular time point. Okay, so what does that mean? You would see this when there is a laminar flow, you are seeing a white band going all the way, going up and going down. That means a quantum of RBCs are moving at that particular speed in unison, okay, over the time. Okay, and this is called as the modal velocity. That is, most of the RBCs will be moving at that time. Okay, suppose there is a turbulence, then what will happen is that the entire spectrum will become dense white, because that at any time point most of the RBCs are moving at random fashion at random speeds, and that is called as spectral broadening. So when you look at even the color gain here, okay, on this color gain, I'll just come back to the I'll remove the calculation, I'll come to the PW, okay, and yeah, and here, okay, okay. So always adjust the compression also to know the particular I'll just go major, I'll remove, okay. So as you can see that there is a hollow black thing in the spectral Doppler, okay. So that means this is a laminar flow. Most of the RBCs increase their velocity over time like this, okay. So this white band is called as the modal velocity. Actual velocity is the midpoint of this white band. But what the experts realize that what you think is the midpoint of this band and what I feel may differ. So that is why most of the, all the guidelines say that when you want to planimeter it or take the peak velocity or take a velocity time integral, you should take the outer border of this modal velocity. Got it? So now if I want to say trace, I will always take the outer border, and then again it will tell me why I should have the swift speed higher. Okay, so like I am putting it here, I will take the outer border of this modal velocity. But as I told you, in actual physics term, it should be the center point of this modal velocity. Okay, that should be the true velocity. Okay, but to reduce the interstudy variability, we are taking the outer border of modal velocity for velocity time integral. This is very crucial when you are taking the LVOT stroke volume, because that is so crucial while aortic stenosis measurements that the stroke volume should not change. So all of should be taking the LVOT flow. Okay, let us take his LVOT flow. So that should be a good example. I'll come here. Let us look at the LVOT and let me zoom it. Okay, I had to discuss the zoom also with you. I'll putting the color flow there. Okay, so here is my color. Okay, and as I said, I'll keep the box as much small as possible, correct? As much as possible. I will go to the cursor, I will keep it in the LVOT, okay, and I will put my PW there. I will reduce the scale. I'll take the baseline up, I'm not interested in anything else, okay. Okay, I will increase the PW gain till I get a little bit of background noise. Fine. Then how I know that this is good one, because I should not get ejection click, but I should get the closing click. Okay, and when I'll put it actually and then whenever I'm now here, actually I'm not getting a very, because I think he has let me see, I'm not getting a good modal velocity here. The reason maybe, I think, fine. So here we have, as you can see here, I'll just reduce the PW gain a little bit here. I will increase the compression little bit. Let me check the compression level here. Okay, fine. So as we can see here, I'll put this one. Okay, so this white band is the modal velocity. Okay, white band is the modal velocity. Now what if I want to now trace this? How will I'm going to trace? Go in, I take the trace here. I would be tracing the outer border of this modal velocity now, okay, and just observe where I am going up. I am not taking the feathering, okay, I am not taking the feathering, and I am going on the outer border like this, okay. This is very important that I'll just show you to take these featherings, okay. So these are called like the beard. You have to take the chin and not the beard. Okay, you will find the variability, especially in CW, it is very much likely, especially in aortic stenosis. You will see a lot of feathering. Okay, this feathering is called as transit time artifact. It is supposed to be related to the turbulence, okay, and the Doppler interrogation with it. Okay. You will get a lot of serrations like this. They should never be taken into your velocity time integral, or never to be taken as peak velocity. Any peak velocity should be always the outer border of the modal velocity, and the velocity time integral also should be outer border of modal velocity. This will reduce your variability of low flow, low gradient aortic stenosis and so forth, aortic wall areas and everything. Okay, so that is the another discipline of measurement. Correct. Now what we will do is that we will just take one more little bit of time on the zoom. Whenever I want to see any particular structure, remember, as you know, that I have to keep the sector width lower so that I get the best temporal resolution. I have to take the depth as much as possible lower, as much as low, to get the best temporal resolution. But to improve the spatial resolution, what should I be doing is that I now know that if this is the sector that I am working into it, okay, this is my real estate, okay, all these grayscales are being shown by the image display by a finite number of crystals, okay, here. Okay, what are the finite number of pixels are there on this screen is showing me the entire heart. Why not I utilize all these pixels to see only one structure, and that is what a zoom is. Okay, so always put the zoom whenever you want to concentrate on some area. So I just want to concentrate on mitral wall, I will put my zoom and keep it on. Now imagine that entire this entire screen, okay, that I had, all those pixels are now utilized to look at only this small structure. So my spatial resolution is going to improve. Okay, so again the same thing for the zoom, lesser the width, higher will be the temporal resolution. Okay, the lesser the depth also will improve the temporal resolution, and spatial resolution is going to go high anyways, correct? So that is how you are going to use the zooms. So always zoom each wall, and PW samples precisely. That time also zoom and put your PW precisely, so that you know that you are exactly not into any pizza area in aortic stenosis, okay, because your PW should be above the pizza, okay, in the aortic stenosis, okay. Or when you want to precisely put it at the tip, always zoom and look at it carefully, okay. So zooming is another function, you should be liberally utilizing it, okay. Now suppose for the simple reason, as you know, the diastolic guidelines are now putting too much of pressure on taking pulmonary vein, okay. You know, here is the pulmonary vein, okay. Now it's best that if I zoom it, I would be able to see it much better, okay. I will be able to see it much better, okay. So I have reduced the zoom and I will zoom it, Okay, now I would be able to see it much better, and in that I am going to keep a color Doppler. Okay, that color Doppler also I am going to reduce the box size. Okay, and I am going to shift it little bit down. Okay, and then I am going to reduce the scale. Now I'll see the color Doppler very well. And as the guidelines mention that if you want to take the pulmonary vein flow, then what should happen is that your cursor should be at least 3 to 5 millimeter inside the vein. So that precision has improved because I am going on the zoom function, correct? And now I am putting the PW on, okay? And that PW should, the gate should be not more than 3 to 5 millimeters. 3 to 5 millimeters. Okay. Now I want to see the pulmonary vein flow in both the direction. That means in forward and the backward, because I want to see the air reversal also. Okay, so and I'm at a very high speed and I have got an ECG there, so I can identify the systolic peak, the diastolic peak, and the atrial reversal will be somewhere here after the P wave. Okay, I got the atrial reversal here. Okay, so I got the S wave, I have got the D wave, and I have got the atrial reversal here. Okay, so that is how the zoom function can help you. Okay, so after that, now let us come to the a tissue Doppler. So what does the tissue Doppler does? It again gives you the velocity over time over a small myocardial structure. So what it is going to do is that it is going to take the low frequency, high amplitude filter setting, so that the Doppler, which was earlier high frequency, low amplitude to look at the blood flow, will now change to low frequency, high amplitude movement. So that it will show you the movement of the myocardium. Okay, so in that case, if I put the tissue Doppler on, okay, so what will happen is, let me go to the tissue Doppler here, TDI. Where is it? The TDI. Where is the TDI in this tissue Doppler? Yeah, here it is. Okay, okay. So here I am onto the TDI, but that I don't want the PW. I just want to turn the TDI on. Yeah, no, it is going into the PW. I don't want the PW. I just want the tissue Doppler on. I don't want the PW. Where is this? Okay, only TDI. Okay. So now, what is the frame rate? 60 hertz. Okay, we don't want that frame rate. This is the frame rate of a regular grayscale image. Okay, I want to have a very high frequency and high fidelity events to see the peak velocities also and the duration of the velocities also. So in that case, what you do, you always go for the box size which is the minimal one. Okay, so actually you can't take it separately, like actually it goes with the color window. Okay, okay, fine. It goes okay. So you now for the yeah. So for the medial annulus, I am reducing it to as much small as possible. Okay, so I am reducing the box size. Okay. Now what is the frame rate? 87 hertz. Correct. So now what I will do is I will put my cursor in the center there. Okay. Here I will have to put my PW at least 5 to 10 5 to 10. Okay. So you have a PW sample size here, you have got the sample volume here, which you can increase or decrease. Okay, it's not changing there. Okay, anyway, so I will increase the gain setting till I got little bit of noise there, and at a very high swift speed. Correct. So always avoid the featherings, and I will take this here. This is my E prime here. Correct. Now, as you know that this is my E prime, this is my A prime, you can see that this is the isovolumic relaxation period. You will see two opposite waveforms there, and then you have got the S prime here. Okay, and again while isovolumic contraction period, you will again see one negative, one positive. Okay, and during isovolumic contraction, you will see one negative. Okay, while in the isovolumic relaxation period you will see one negative, one positive, then you are going to see the E prime. Okay, Now I want to take, say, a distance. Suppose if I had to take the time duration, so we'll go for time duration 1. Time duration 1 here, we have time duration, so this is a velocity, I want a time duration. Do you have time duration here? This is the ellipse, this is a distance will be time duration, I don't know whether it is a... Yeah, just show me the time duration caliper. Time duration caliper only. Another measurement, I can get that. Okay. So suppose I put it here, it is going to give the, it's going to give me only the velocities. I want a time duration.
Then sir, you have to take the measurement from here only.
Because it's velocity time, so here is in the tools. Okay. So yeah, where is the time here? Yeah, time and slope. Yeah, time and slope. Correct. So there is a suppose let me position my, yeah. So this is the peak, suppose this is the peak of my R wave, okay, this is my peak of the R wave, and this is my distance to the beginning of the E prime. How much it is? 400 milliseconds, okay, 400 milliseconds. Why this is required, that we'll discuss when we get the guidelines, okay. This is your E velocity, as you know, of course here the velocity, because we are in the time slope, when we just put, we go into the caliper and then we'll get the E prime here. So E prime velocity you got something like 13.7, okay, but this is what the difference you got for the one, okay. So let me go here, okay. Okay. So similarly for the lateral E prime, try to make it as perpendicular as possible. Don't take it when it is absolutely lateral like this. Don't take E prime like this. The way your septum anyway comes in the center, okay. So try to minimize the angle of movement or the displacement of the annulus and the ultrasound beam. Try to reduce that angulation. So try to take the E prime in the center. Again I will go on to the tissue Doppler here. Okay, and as I told you, again I will take it, okay, I will try to take it in the center here. I will put my cursor in the center, okay, at a very high frame rate, so that I get much better in, and I'll always keep my PW, which is, and at a very high swift speed, and I will increase the scale here. Okay, and of all these featherings, I am going to take only the modal velocity, I will keep it here, okay, for my E prime here, okay. And so also you can see the feathering here, this is the modal velocity, so my peak velocity is going to be here for the S prime, and so also for the A prime, okay. Okay, now I will come to this particular measurements. These measurements obviously you know, because the E and E prime are the most important measurements that you take. Okay. Okay, I'll go to the tools. Let me take the time. Okay, 4. The time tools here, and where is the time? Time, yeah. Okay, so so we knew how to take the mitral flow, how to take the pulmonary vein flow, which are very important parts of the diastolic function assessment, and then obviously for the TR, as we know that always focus again, zoom it. Okay, try to take the look at, so that you can pick up a very small TR jet also, correct? Okay, with the smallest possible box size. Okay, always put your cursor properly into it, okay. Now your accuracy will improve of taking up the TR jet, and then you press the CW. You are not getting the entire envelope here. So what do you do? Now generally you are not getting the entire envelope, as you can see here, that I can just getting some velocities here, but I'm not getting the complete interval. In that case, you can always give, say, saline bubble contrast to increase the backscatter and improve the TR spectrum. Okay, the TR CW spectrum, you can always improve it to get the peak velocities here. Okay, but don't assume something. Don't assume that this may be one. Okay, whichever you are seeing as the real signal, that only you should take. Okay, you should not assume that okay, this could be here, that way. No. Okay, no assumptions here. Okay, so as you know that TR velocity is going to be another most important part. Now comes the another very important part of your diastolic function assessment in is the LA volumes. Correct. So how do you take the LA volumes? Now remember, this is the perfect long axis of the LV. In that case, LA is always foreshortened. LA will never be in long axis when your LV is in long axis. The LA will be in a true long axis. Isovolumic relaxation time. Correct. So we'll go for IV, after the LA volume, just remind me, we'll go to IVRT also. So we are here in the LA volume. So why it is so is because the LA long axis is like this and the LV long axis is like this. Okay, if you take from spine to this thing, it is like this. Okay, so in that case, when I am in the long axis view, actually the LA I am cutting in a paraaxial view. So in that case, what I have to do is that instead of my beam like this, I have to slightly go up and then tilt up. Okay, and how do you know you have entered into a long axis of LA is that the mitral annulus should become larger and the long axis of LA should become larger. Okay, so this is how we will be doing it. So here we are at the true long axis of the LV. You can see the apex is so well and LA is so small. Okay, what I will do is I will slightly go para-apical and will start pointing upwards till I see a large LA ampere. Okay, so see, suppose here again I will do the same maneuver. Here I am in the perfect long axis. You can see the triangular apex here and see how the LA looks. Okay, now I have gone para-apical and tilted up. Now LA has opened up. Okay, the mitral annulus now looks bigger, correct? And now if I go further up, I will open up the LVOT. So again I come back to get the best long axis, correct? And then I also want to have the best long axis view of LA also. Okay, so what I will do is I will zoom it. Okay, and I will try to get the best end systolic. Okay, so here is the end systolic view of mine where I have got the, now see how big it has become. Okay, I got the largest annulus now and the largest long axis now. Okay, and since I have zoomed, I will be able to do the LA volume much better. So now I will trace it. So what I will do is I will start from here. When I start going, never take the LA appendage also. I will go down, never enter into any pulmonary. I will not enter the pulmonary when I will go on to the thing, and then I will go along the interatrial septum to the medial. Okay. Now once I put this, if I go for the area here, where is the area? It must be tools, no? Where is the area? This is the area.
Area 16.6.
No, but it is not showing me the long axis. That is the problem. No, I'm not. But when it is taking the area, it should show the. Forget. Yeah. Pardon. Okay. So anyway, so what I will do is I will show you. Your long axis measurement should always be perpendicular. Okay, never this way. It should be perfectly perpendicular. So many times you get an area where the axis is like this. You correct that axis to make it long. First you will measure it in 2 chamber. Then what you will do? You will go into 2 chamber. Again the same thing. Okay. So I will get a very good 2 chamber view, and then I will go para-apically and I will try to adjust the LA in such a way that, and again I will zoom it. So that I get the largest mitral diameter and the longest diameter. Okay. So here I have the, here I got the largest mitral annulus and the largest diameter. Now another important thing is that what you got in 2 chamber and what you got in the 4 chamber, the long should be between 5 millimeter of each other. If they are more than 5 millimeters, one view is very skewed. Okay. So these long axes should be the this way, correct? Then again here I will go by the, I'll measure it. Now I'm not seeing a very good margin here, so I'll have to adjust it, adjust the gains. Yeah, 5 minutes, yeah, good. So I will adjust it in such a way that I get the lateral wall very well. Okay, I got the lateral wall very well, and what I will do is that I will, if I go for the tracing, here I will not enter into the LA appendage. Okay? So I'll be going on the mouth of the LA appendage all the way down, okay, and take it this way. Fine. So that is how I will be getting my LA appendage. Okay. Now we'll go for the isovolemic relaxation time. Again, it is best to have a zoom view. Have your color Doppler take up both the blue and red flows. Okay. Why blue and red flow? Because you want to see both the inflow and outflow. Okay. Now there are two ways. Some experts likes to put the PW sample at the junction between the inflow and outflow. Okay, so you have this particular cursor that you put it at the junction here. Okay, okay. But the another one is that you just put your CW slightly medially. Okay, and take the view. Now, why it is suggested is because in this particular view you get the aortic wall closure click. You get the aortic wall closure click. Okay, so that is why CW is recommended. Otherwise, another way is that you took the PW at the junction of the red and blue flows to get both the flows. Okay, generally the diastolic function guidelines recommend that you take a CW sample in such a way that it is not exactly going through this or exactly going through the mitral, but and obviously at a very high swift speed, so that you get both the closing click and the, so where is the distance here now? Time here, correct. So you get the closing click of the aortic wall here, and also you are getting the origin or the beginning of the mitral flow. Okay, and here you got the isovolemic relaxation time. Got it? Isovolemic relaxation time. Okay. Another obviously the another one which is a little bit difficult ones but has been proposed in certain clinical situation is to look at the time interval between the, where is my time interval again? Let me go into the tools, and I got the time here. Yeah, is to look at the origin or the commencement of the E wave. Okay, that is TE distance. So you start from the peak of the R wave to the beginning of the E wave. Okay, that is the TE distance. Okay, and then you take the tissue Doppler. So I'll go to the TDI. Okay, and in the TDI I will again run the TDI. Okay, and again I'll go on to the time factor here, and I'll take it from the peak of the R wave to the beginning of the E prime. Okay, you got it around 407. This is a very young guy, so there is not much difference. Okay, but tell me, right from the beginning of the R wave, we are taking the beginning of the E velocity, and from the peak of the R wave, we are taking the beginning of the E prime. Okay, what is going to be the earlier? Event should be earlier. Okay, whether it is the commencement of flow across the mitral wall or the recoil of the annulus in the early diastole. Generally, generally what happens is the moment there is when the LV is relaxing and there is a pressure crossover from the of the LA pressure. So LA that time will be at the peak of its V velocity, correct? So when the LVDP falls just below the V wave, the mitral valve will open, okay, and the flow will start. So the commencement of the flow is immediate, okay, and then as the LV starts its suction force and rapid relaxation, the recoil will happen. But the difference between the two intervals is so minuscule in very young people. Here we got it, say like almost, this was like 407 and that was like 410. It is minuscule, okay. But as the LV becomes myopathic, the commencement of E prime or the recoil will get postponed. Okay, so that is why the distance will increase. Okay, this particular time duration, which is called as T E minus E prime, that means the E prime minus the TE, is taken in certain special situations. It is not as a regular part of it, but we should know how to measure it. Okay, so I think we'll stop it here, and I think you can start with the next session. No, IVRT is completely different. Isovalmy relaxation is just the end of the LVOT flow. I mean the aortic click. That means the closure to commencement of the E flow. That means the early diastolic flow. So that is isovalmic relaxation time.
What does this signify, sir? The T means T
Prime. Yeah, generally it is for the, it is recommended in certain situations in the diastolic flexion guidelines, okay, which is supposed to be a very robust indicator of the diastolic dysfunction, but very difficult to take in routine practice. So that is why it is relegated to the last. But IVRT is now upgraded quite higher one, okay, because it's very easy to take. Best to take it by CW, okay, because then you get the closing click. So you know exact time point of the aortic wall closure from which you are starting, where there is a pressure crossover from the LV and the LAV wave, okay, where there is a crossover, that is your mitral wall opening, that is the beginning of the E wave. So you get that isovalmic relaxation time. It will prolong, okay, so it will prolong when there is a slow diastolic relaxation, but it will shorten when the LA filling pressures go high. Okay, so that means the pressure crossover will open at much earlier. So there the isovalmic relaxation time will reduce, okay, as the LA filling pressures go high. Okay, but when in the normal LA filling pressures, if it is only a relaxation issue, then it may get prolonged. Okay. So it will go about say 240 milliseconds or something. So anywhere from, but the moment you have the LA pressures going up, then the isovalmic relaxation will fall below 70 milliseconds. It may become like 40, 50 that way. Okay. So anyway, what is important is the discipline of measurement, so that your inter-observer variability is less, your inter-study variability is less. Okay, so that is why the discipline of measuring is very important. Okay, every image should be aesthetically pleasing, making use of all the controls that you have. Okay, always have the best Doppler signals and sharper Doppler signals, best time duration measurements, and so on.
Sir, one simple query, sir. In the machine, we are having one formula, LA volume. Directly, we can go to the button of LA volume.
So there are two ways to manage.
One is area length method. Area length method. Another is directly.
Sum of this.
0.85 into A1 into A2 divided by
So there are
minimum.
things, but the machine can give you the. I don't know whether. Every machine can give it. Okay, either you can have area length method or summation of this.
Summation.
Either of them you can use.
Anyone we can use. Because in that formula, we have to go to that formula, no? 0.85 into A1 into A2 divided by.
Why do you want to do it? But the machine can do it.
Machine can do. Okay.
I find the summation of disk is much more reproducible.
Okay.
Very easy to do also.
Okay. Yes, sir.
Hello, kind attention everybody. So those who are doing hands-on training on healthy volunteers, the other side on Philips machine, some people can go there. And another thing I would like to bring to your, I think, kind attention, and you'll be pleased to know about it also, that there is post-lunch, we are having the facility of demonstration on a mannequin, and in fact that has various disease settings. So if you think that we are only being able to see the healthy heart and not being able to see the diseased heart, so there are various disease settings of valvular pathologies, pericardial pathologies, aortic dissections, blah, blah, blah. Lot of disease settings where they are inbuilt in the mannequin. So you'll be able to try your hands on with transthoracic today. And tomorrow you can do the same thing with transesophageal echocardiogram. So please keep in mind that you'll have ample opportunity to have a look at various disease settings as well through the mannequin. Thank you.
We will be closing the session of hands-on in another 5-10 minutes. This is to inform all of you. We will be continuing with our session, and once again I would like to invite on the dais Dr. Nitin Burkole sir and Dr. R. Alligason sir.
आने से वो स्विच कर देगा।
आ रहा है उधर?
वो लोग आने से स्विच कर देगा।
हाँ तो उधर स्विच किया है कि नहीं? They are not getting the screen mirroring.
अब एक बार प्रेजेंट
ये मेरे स्क्रीन मिरर में display settings. Yeah, ये display से- नहीं कुछ
Okay. Yeah. So we are on time. Okay. So shall we? Yeah. Shall we start? Yeah, I think we can start now. Correct. So yeah, uh, yeah. Let them finish off there so that we can. Yeah. They can also finish and yeah. Yeah. Yeah, it is coming. So, yeah, I think the delegates who are now doing the normal ones, they can finish it off and come for the lecture, okay? We can finish that. Okay, so here we are, what I thought was, I think the topic given to me was the nitty-gritties of hemodynamic assessment, but I think it's a very huge thing to see the hemodynamics. So what I thought was, our major problem is always the filling pressures. Because as we know, the definition of heart failure is that we have to have an evidence of a systolic or diastolic dysfunction, and with that rise in the natriuretic peptide, and you have to have objective evidence of pulmonary or systemic venous congestion. Okay, so patients presenting with symptoms suggestive of heart failure should have all these three things to call them a heart failure. Okay, so the structural or the functional cardiac problems you can detect by looking at the systolic function and the diastolic function. Natriuretic peptide is obviously a biochem, but echo comes in handy in having the evidence of pulmonary and systemic venous congestion. Obviously, clinically also you look at the raised JVP and the liver congestion, and also you can auscultate. You can see the pulmonary edema on the echo, which can also be an objective evidence. But I'll show you how the echo helps you for both, for filling pressures, for looking at the pulmonary edema, and also looking for the venous congestion. What I would do is that I will skip some of the slides and directly come to the first looking at the left heart measurements. Now the thing is, the diastolic dysfunction guidelines, there were 2016 and then July 2025. Okay, but there are always lots of algorithms given it, very difficult to remember for every clinical situation. Best is you record everything that is required for most of the diastolic function assessment and the filling pressures assessments. Okay. And let me tell you, when we talk of LV or left-sided filling pressures, we are talking of the mean LA pressure, okay? So that means the mean of the A and V wave in the LA pressure tracing and the pre-A LV diastolic pressure. We are not talking about LV EDP per se, okay? So if we, the ones which are shown in the green are the ones which are maximum utilized to look at the filling pressures, okay? And the ones I have shown in the white are the ones which can be used for corroboration, okay? So rather than going into the, so let us start doing the echo in a patient. What are you going to do? You are going to obviously look at the M mode. Why simple M mode? Because you are going to get the left ventricular mass in that. All the outcome trials had been done with a simple M mode LV mass, so we are still utilizing it. So for female, anything 95 gram per meter square, male 115 gram per meter square. But as we know, this is not a true LV mass, but we need that mass because once your pretest probability is high, you know that your chances of getting then high filling pressures are high. So when you started, you always start with P-lax. So your M mode itself will tell you something about the LVH and will bolster your decision about the filling pressures. Next, generally you go to the short axis and always take the pulmonary flow. But now also start looking at that PR and get a very good PR jet and try to get the end diastole, because this somewhere you may need downstream. And anyway you are acquiring it. It is better that don't go backwards and again try to find some some of those parameters. It is better that in the flow of your echo, you can register these things and keep it recorded. You may not measure it, but when you require it, it will be there. Okay, so you start with that M mode, then you go on short axis, you see the pulmonary flow. That time, remember to record the PR jet. Okay. Then generally when you finish your short axis views of the parasternal, you always go for the 4-chamber. The moment you go to the 4-chamber, the most important parameter on which the filling pressures depend is the E prime, which has now given the central role. So at a high frame rate, measure the medial E prime and the lateral E prime, okay? Make that habit to record it, okay? So you will be recording the medial E prime, you will be recording the lateral E primes, and we discussed how to get the best under, okay? So keep them recorded, okay? Then in the 4 chamber, you are always going to take your PW sample in the mitral flow, and you are going to get E and A, that is going to give you E, A, E by A, everything, okay? And as I told you that we are also going to have the take the mitral, that PW sample slightly towards the annulus to get the A duration, okay? Now, most of the things in the diastolic function are going to go around this. They will be looking at the mitral flow, they will be looking at the annulus, they are going to look at the ALA, and they are going to look at the pulmonary vein. 90% of the work will be over when you are focusing in this area and keeping those things recorded well, okay? So in the mitral flow, you are going to get that E by A, you are going to get the L wave, you may do Valsalva to take the mitral E by A ratio in Valsalva, you are going to look at the A primes, okay? So this is very important, and also you know that in the same view, you are also going to get the isovolumic relaxation times, okay? So here you are going to get your E durations also, and also you are going to do the Valsalva, and also you are going to have your isovolumic relaxation times, okay? Now, as I told you, isovolumic time, you will have to just shift from the PW to CW, okay? That is the only thing that you are going to do differently, okay? Once that, you are just sliding down, focusing onto the ALA, and going to get a very good ALA volumes, okay? Both 4 chamber and 2 chamber. And once you have recorded those grayscale images, you don't have to do anything, because the machine is automatically going to calculate the LA strain, okay? And then your sample is just going to go down into the pulmonary vein and going to record your S, D and A reversals, okay? And you are going to record them in a long, in a fast view to see the S, D and the A durations, okay? So once you have done, so remember, most of the things are in the vicinity, okay? 90% of your things are there in that vicinity. Your the ALA, the focus view, LVOT, pulmonary veins, mitral annulus, mitral flows, everything will be there, and it will be very easy for you to have all those parameters which later on you will use to think about the LA filling pressures. Generally, when you are in the 4 chamber view, you also go ahead and take the RV focus view and record the TR. Everyone does that, okay? What you were additionally doing in the flow of your echo was to take the PR jet. That was the only extra thing that you are going to do, okay? Once you are done, actually your job is done, okay? You have almost all the parameters with you from which you are going to look at the LV filling pressures, okay? That is the way to put it, okay? Rather than going into the algorithm and mugging them, just visualize everything while you are doing the echo. Then, as I told you, the E prime becomes a very center focus for the left heart filling pressures, okay? Why it is so? Because we know that the LA prime, or the E prime is going to be the factor on which, okay, most of your parameters of diastolic dysfunction and the filling pressures are going to be built upon. So everything starts with the E prime. So that is why you should know the lowest limits of E primes for each age group. Interestingly, in the literature, the outcomes, that means the heart failure hospitalization, cardiac mortality, everything has been correlated with E prime only in the population above age of 65 years. We don't have the evidence for the outcomes at the lower age group, but we have the lower normal datas for below 40, between 40 to 65 and above 65, okay, for both lateral and medial, okay. So just remember, it is 1076 and 766, okay, they are the lowest limits of the E prime for lateral and medial, okay. So anything dropping below this should raise your antennas that there is going to be a diastolic dysfunction, okay. So what are you going to do is, first, what you are going to look at is whether the patient really has a diastolic dysfunction or not. See, diastolic dysfunction is a separate category. Knowing about the early myopathic process and filling pressure is a different thing, which is clinically relevant to adjust your diuretics and doing the the diagnosis for HepPef and so forth, okay? Because you are going to have a grade 1 diastolic dysfunction, which is just a relaxation issue without any increase in the LA filling pressures, okay? It is only that the LV now starts filling late in diastole by atrial creak rather than the early diastole, okay? But your LA mean pressure remains normal, and that is grade 1, okay? So, but that is still a diastolic dysfunction. So, diastolic dysfunction doesn't directly mean that you are talking about the filling pressures. So, to know that there is definitely a diastolic dysfunction, you will have to just look at the E primes that you have already acquired, okay? Once those are below those thresholds, you just need one more parameter to look at it. Now, why the things have been simplified so much is because if you go by these cutoffs, your specificity is going to improve, but your sensitivity is going to drop. There are no free lunches in medicine. Whenever you have a threshold, higher the threshold you make, you improve specificity, but you lose on sensitivity. Okay, you have then more false negatives. So that is why they have reduced the number of parameters so that you improve the sensitivity. Okay, so that is why now you don't need so many 3-4 parameters as those 2016 guidelines. You need a this, then you do this, then you do this. Very difficult to remember also. Here it is very simple. Start with E prime. If your E prime is already below threshold, you just need one more parameter, and that is also you have acquired in the vicinity, and that is just looking at the E by A ratios. Okay, and as you know that normal E by A ratios are between 0.8 to 2. Okay, those are the normal ones. Okay, anything going below 0.8 tells you that, okay, the relaxation problem has occurred. Anything going above 2 is know that this is abnormal. Obviously, you will not talk about those athletes and anemias and very young people with hyperdynamic circulation. But most of the time in the adults, about 2 is going to be abnormal. Problem is between 0.8 to 1.2, you know, it can be pseudo-normal also, normal also. So that's a different thing. But the moment you know that it is below 0.8 or above 2, and with these E prime ratios, you know that he has a diastolic dysfunction. It is so simple. And obviously you have got it in the very vicinity. If you want further, you can just look at the E by E prime and also look at the LA volumes, okay, and also at the LA strain, and you already have LVH. Either of these you can use as only one extra parameter once your E prime is less, okay. You look at E by E prime, which you already got in that vicinity. You had also taken LA volumes, you had also taken LA reservoir strain, and already you had an M mode data telling you about the LVH. So of all these 5 things, along with the E prime, you are already sure. Now suppose if you don't reach this very I would say very strict thresholds of E primes according to the age group. Okay, we are talking about the age group. If you are not reaching those thresholds, okay, then either of these, just looking at a large LA and your E by E prime ratios being abnormal, or large LA associated with LVH, you know that there is going to be diastolic dysfunction. You don't need anything more. Okay, so this way, just bringing down everything to only 2 parameters, you are trying to improve the sensitivity. But at every parameter, the thresholds are very strict to maintain a good specificity. So that is how these guidelines have made the things very, very simple. And you know, if you just look at this, they were all, just visualize while you are taking the echo, they are all in the vicinity. Okay, your E prime was there, your mitral flow was there, your LA volume was there, and already when you have a grayscale image of LA, you are going to get residual strain. So that's all fine. So you already know about the patient having diastolic dysfunction or not. Now, so the thing is, if you want to little make complicated, go into those algorithms, not require that. Okay. Next things, we want to know whether the filling pressures are high or not. And why you need it? Because as we know, if you are looking at the heart failure guidelines, you have to show that there is the filling pressures are high, either non-invasively, invasively, and the venous congestion. Apart from patient symptoms, raised natriuretic peptides, and obviously the signs of pulmonary congestion. So high LA pressure is the center point in your clinical decision making. You are not interested in just knowing diastolic dysfunction. You want the high LA pressures or not. Here again, it's a very simple thing is that we are all starting with the E by E prime, okay, and the only E prime that you have already acquired. E by E prime you already got because you had a mitral flow, and you already have got your TR, okay. You have got these 3 things which generally all your echoes will definitely going to have it, because the way we are acquiring in that sequences you have already acquired. And if all these 3 are abnormal, the LA pressure has to be raised, okay, and all their cutoffs are quite stiff, As we know, we looked at the E prime lower limits as per the age. We also looked at the E by E prime 14 is a very stiff cutoff, and also we looked at the TR velocities, anything going about 2.8, okay, because the moment is 2.8, 4V square, it goes about 30. So we already know that. So if you have got all these three factors which you have already acquired, all of them are already reaching the thresholds, you don't have to do anything. It tells you the LA filling pressures are high. Now obviously the things are never so kind, because one or the two parameters will always be off the mark, okay, they will be still not reach threshold. Then do what? Again, there are no algorithms required. You already have certain data points with you, which if you add to any one of them, okay, so because you can have so many combinations. You may have all the three positives, no problems, all the three negatives, again no problem, because the LA filling pressures cannot be high. Problem comes when you have got only 2 or 1, okay, that's the only issue. But then here also there is no complicated algorithms. You already have something with you which you can just add to any one of the problems with this, and you already know the filling pressures are high. And obviously those two you have already acquired, which you already seen was the LA pressures and the LA reservoir strain. Okay, so suppose if you have just got the E by E prime higher and also the LA looking big, you don't have to worry much more, because while you are taking that E by E prime also, you are seen visually also the LA is big. You know the filling pressures are going to be high, except that the patient is not athletic, not anemic, and doesn't have any severe MR. But otherwise that LA large is going to be a direct structural reflection of raised filling pressures that you already know. So you have to just look at any one of these parameters going abnormal and the LA looking large or the reservoir strain going down, okay, you already know that your filling pressures are high. Suppose even if you don't take LA volume, suppose if you have your pulmonary vein, and if the S is lower than the D, that means you are having a more diastolic filling, and your systolic filling is very low because of a tall V wave coming in the LA, which is a very classic in the HEPs, that if you take the LA pressure tracing, the V wave is very tall. In that case, obviously the pulmonary venous flow is going to be less, and that is why the S is going to go down. If your S is going down almost 60% of your D wave, okay, that itself tells you, okay, the LA filling pressures are high. So with all these three, any one of them corroborating with one of these, it is very simple. So you have already in that same vicinity there. And you really don't have to go further if you look at the isovolumic relaxation time. You are also in the same, the PW which was taking your mitral flow, just shifting the beam towards the LVOT, converting into CW and taking one trace for the isovolumic relaxation time, you already have that data on your machine, or it is in your study. So any of these parameters, okay, with any one of them, okay, already tells you your filling pressures are high, okay, except in one situation where probably your E primes are lower, but the other twos are the E by E primes are normal, your TRs are normal, and in that particular case, only you can look at the E by A ratios, which is less than 0.8, and call it grade 1, because you know that this is a diastolic dysfunction without filling pressures increment. So grade 1 is always without raised filling pressures, okay? Anything else is going to be this, okay? So then the question comes, if you are seeing high LA pressure, how are you going to grade it? Moderately elevated, severely elevated, and that is what we talk about, those grade 2 and grade 3 dysfunction. So here it is simple that you have already acquired the E by A ratio, and if that E by A ratio is less than 2, you call grade 2. If it is more than 2, you call it grade 3. So the things have become much, much simpler, okay? And you don't have to go away from that focused view of LV inflow and your LA in your picture and mentally thinking about the parameters around it. Look at the mitral flows, look at the IVRTs there, look at the E primes, and look at the pulmonary vein flows. You actually have everything in hand to know about the LA filling pressures, okay? Instead of mugging about those, algorithms, it is as simple. Everyone gets the E by E prime, everyone gets the pure E, everyone gets the TR. If you not have got all the three to one of that, then just look at the LA volumes going big, residual strain, the reservoir strain going down, your S flow in the pulmonary vein going down, your IVRT shrinking, you know that the LA filling pressures are high. And then just looking at the EA velocities when they go above 2, you call it grade 3. That's all. It's a very restrictive filling pattern. So your LA pressures are there. It is that simple. Now, I don't think you really require anything more than that, because all these signals are very easy to get in every patient, okay? Because even if the worst kind of an echo image also, except for the LA volume, everything else you can get. You can get reservoir strain also, you can get the Doppler also. They always say that Doppler is your friend, even in the bad echo window. Doppler never lets you down, okay? Generally, Doppler is your friend always, okay? So it is very unlikely that you will not get any one of these parameters or all the parameters, okay? And if you want to go into the further depths of it, if you want to look at further ones, then they are also in close vicinity. Like you already taken the pulmonary vein flow, you just look at the A duration and subtract from that the mitral A duration. That data was also there with you. This is just supplementary data. Any one of them will bolster your decision of telling you that the LA pressures are high. You can do Valsalva if you want. You can just look at you have already taken that PR velocity and you have taken the end diastolic pressure. If it is high, you know that the filling pressures are high, provided he doesn't have any pulmonary disease. You are also looking at the diastolic MR here. You can look at the diastolic MR. That is going to tell you that your LV EDP is high. And if you get an L wave, you also know that it is high. These factors are already there, except that you took the extra precaution of picking the PR jet. That was the only thing which was not there. Otherwise, the rest of them were there, all in that vicinity. Okay. So just visualize that you have your LV inflow, 4-chamber view, LA there, mitral wall there, pulmonary vein here, LVOT here. Just look at that vicinity. All your parameters have come from that territory. Okay. So it is very unlikely that you will not pick up any parameters, and you don't have to enter into very, those algorithms and looking at if these two positives, then take this. If that is not there, look at this, not required, okay? It is that simple. You now need only 2 parameters, and only thing your thresholds have been made very robust so that you have a balance of sensitivity and specificity. See, despite that, let me tell you, despite that, you will lose at least 25% of HEPs. They may still have all these parameters normal, and those will get unmasked only with exercise, okay? So try to do exercise in these patients and look at these parameters of E by E prime and the TR jets at peak exercise, okay? Almost 50% of the time you will get the TR jet at peak exercise, and at least 80% of the time you will get E by E prime post exercise in the patients, okay? So remember that means everything being normal, because you cannot 100% diagnose all the filling pressures, okay? With this strict thresholds, try to have better specificity, and just looking at only 2 parameters of that, try to improve sensitivity. But still you are going to miss some filling pressures that you can unmask by doing exercise, okay? So I will stop this left heart filling and I'll quickly take you to the right heart filling, okay? Because we are still mired into only looking at the IVC as RA filling pressures, and I want to make it more clear, because again it is clinically relevant, okay? So the one that is most important, okay, with that, since we were on the left heart filling pressures, let me just very quickly go through looking at the lung ultrasound, okay? Actually make it a practice on your clinical rounds in the wards or in the OPDs to look at the lungs, okay? Always make it one, because this is a direct evidence for you to look at the pulmonary congestion, okay? Just looking at these rays coming from the pleural margin all the way down to the sector bed width, okay? Just take your probe up on the second intercostal space, and then to the anterior axillary line and to the mid axillary line. Okay, just in the third intercostal space, just slide it down and look at this. Don't look at back, because you will get some raise there. Best is just second intercostal space, just slide it down to the third intercostal space, the anterior axillary line, just go to the mid axillary line and you will pick it up. Let me tell you, this is the most sensitive sign to pick up pulmonary congestion, especially interstitial pulmonary edema, much sensitive than auscultation, much sensitive than chest X-ray, even a digital chest X-ray, and even more sensitive than HRCT. Let me tell you, this is the ultrasound is a winner here to pick up an early interstitial edema. And you will find that if you discharge a patient with these comments, is going to have a second heart failure hospitalization. At discharge, if your diuretics have not been common, if you have not reduced these lung comets, patient is going to have a repeated heart failure hospitalization. So not only that, this helps you because this tells you directly about the raised wedge pressure and the pulmonary edema. You don't have to go through all those rigmarole of diastolic filling pressures. This is direct filling pressure. Not only that, if you are doing stress echoes, peak exercise, while you are looking at the regional wall, just go into the lungs and look at this. Some of the patients will literally will show you these comets. You don't need anything more to tell you that he had a heart failure with exercise. So try to use this lung comets as a left heart filling pressure as probably the most specific sign. Okay. Now I'll come back to the right heart filling pressures, and somehow all of us are just fixed to this idea of IVC and these respiratory changes. Okay, just IVC and then whether 50% with sniff or not, and we estimate the pressure. Okay, well and good, but we have to move forward. What do we move forward? Okay. Just slide it down, the axilla, and look at the hepatic vein, distal hepatic vein, portal vein, and renal vein. It is very, very doable, very, very doable, okay? And I'll show you why, what is the fundamental behind that, okay? What happens is that the veins are highly, highly compliant structure. Unless they get completely filled, then they become taut, and then the compliance is less. So what happens is that there is no walls there. So IVC will reflect the pressure changes in the right atrium just like a JVP, okay? However, it is such a compliant structure that these pulsatile changes literally die down as you go to the tributaries. That means you go to the hepatic veins, distal hepatic veins, portal vein, renal vein. They should all have a non-phasic flow. They should have a continuous flow because they cannot reflect the RA pressure backward, though there are no walls in between, because it's so compliant structure that whatever the pressure changes that were happening in the IVC do not get reflected back. They just die down. The moment you have got a lot of congestion, the whole system has become so taut that the RA pressures get reflected into distal hepatic veins, into the portal vein, and also into the renal vein. And actually that is what causes the rise in the creatinines, and most of them is congestive and not the forward flow. Most of them we think that the renal arterial flow is reduced. Stroke volume is maintained in a very late heart failure also. It is the diastolic pressure that gets reflected to the renal venules actually reduce your GFR. So just see them that you get a phasic flow in the portal vein or in the renal vein. It directly tells you recurrent heart failure hospitalization and that you have not diuresed the patient well. And I'll show you how. Okay, so this is your JVP and that is how the pressures will go ahead. Okay, so if you go down into the IVC and hepatic vein, generally you will get only a little bit of a phasic flow in the early hepatic vein. Okay. Forward S and forward E flow, okay? As you go to the distal vein, you are just sliding your probe down. As you go into the distal vein, you will get only a continuous flow like this. Only continuous flow like this, okay? In the distal hepatic vein. Then what you do, you just go down, then you will see a very thick walled vein with the flow which is towards you. That has to be portal vein. There cannot be any hepatic vein where the flow will be red. It is not possible because all the veins are going away from you. So just come down and you will see a very thick vein like this in the center part of the liver, a very thick one. The hepatic veins are not so thick. And you have a flow towards you. That has to be portal vein. Okay, and the portal vein will show non-phasic flow like this. Okay, it will just very slightly undulating flow. Now, as the hepatic pressure increases, see finally what the portal veins are going into the portal triad, and then they are go through these hepatic sinusoids. Again, the venules are going to join and form the hepatic vein. If the hepatic vein pressure goes backwards across the hepatic triad, your portal vein will start becoming phasic, and that actually causes the enteropathy, and that also tells you about the gut edema. Okay, and obviously the next things. Okay, so the portal vein should look like this. Then just slide down and look at the kidneys, okay? And just bring down the Nyquist limit, just bring down the Nyquist limit, and you will see both red and blue flows there. The red are the arteries and the blue are the veins because they are moving away from the cortex. You have to take this vein here, which is the which is the cortical vein. You don't have to take the hilar vein, okay? And just put the sample there, and what you will get is that on the top, you will have the arterial phasic flow telling you about the systole, and you will have pan-diastolic non-phasic flow in the hepatic vein. Okay, and that tells you that your the filling pressures are not very, very high. And obviously, you can look at the internal jugular vein and see its change with the one. And I'll just finish in another 1 minute by showing you how these have changed. I'll just take one patient and we'll see how it has become so phasic, okay? So let me take this patient and we will just quickly go through the patient and I'll finish my case there, okay? So here is the concept of congestive organ injury. Okay, so congestive organ injury will lead to all the clinical manifestations, and this is what we were talking about, the gut edema and the microbiome releasing the toxins into during heart failure, so on and so forth. But we can now actually see that, okay? So here there is a case, is a sarcoid and dilated cardiomyopathy, okay? So first we'll look at the hepatic vein, okay? The hepatic vein, obviously the IVC is obviously showing, the hepatic vein is already showing you a very phasic flow, only forward diastolic flow, and there is a great A reversal. As I go into the distal hepatic vein, I don't have a continuous flow. Now I still have, if I am here in the distal hepatic vein, I am now looking at the portal vein here, and let us look how the portal vein is there. So here is the portal vein, and if the pressure gets reflected into the central, from the central vein into your hepatic vein, what will happen is like this. How the hepatic vein now is showing a very pulsatile flow. You can see a tall and deep, because you are not decongested it well. So hepatic vein now, instead of becoming a continuous flow, is now become phasic, okay? And then there are phasic indices for that. Those you don't have to really remember them. And then let us go down into the hepatic vein. So here is the hepatic vein of this DCM patient, and this is the flow. And now you can see that the upward is the arterial flow, tells you between the RR interval, and between two RR interval, now you are seeing two spikes, okay? One systolic and one diastolic spike, instead of getting a continuous forward flow in the hepatic vein. There is no business for a renal vein to have a phasic flow. It has to be continuous. Why it has become phasic? You can easily look at this RR. The one which are below the baseline are the veins, and you can see that there are two forward flows only. In between there is no flow. This is all because the RA pressure is getting transmitted to the renal veins, and that tells you that your venous system is now engorged. It is non-compliant, and that tells you that you have not diuresed this patient well. And this patient, if gets a creatinine rise, okay, most of the time what happens, you are treating the heart failure patient, the creatinine starts rising and you are worried. You rather try to reduce the diuretic, thinking that you are reducing the stroke volume and that's why the EFR is rising. Actually, if you look at this flow and the patient's blood pressure is fine, peripheral pulse volume is fine, rather raise the diuretic and try to make this biphasic flow into a single forward flow, okay? And that will actually reduce the pressure onto the glomeruli, and rather the eGFR may improve, okay? So now you can actually look into the pathophysiology of congestive nephropathy by looking at the echo. So make full use of echo. There is no other imaging modality that can go to the bedside and can give you minute-to-minute change in the filling pressures. Neither your natriuretic peptide can give you minute-to-minute change. The natriuretic peptide has a long lag period. When you decongest, it takes a long time for the natriuretic peptides to fall. Here you are getting day-to-day, hour-to-hour changes in your filling pressures of the right and the left heart ones, and try to make one. And remember, any alteration, any phasic changes in the portal vein or the intrarenal vein flows are associated with recurrent heart failure hospitalization and high mortality also, and rise in the creatinine too, and not only that, they can guide your diuretic management, okay? I think with this I will finish in the interest of time, and I just wanted to give you a different perspective how you can use the echo bedside to manage your diuretics. Thank you. Okay.
Thank you, Dr. Nathan. So always we always admire at Dr. Nitin. He's a complete cardiologist. So, so we look at the liver and get away. I mean, we don't look at the other things. So this is the first time I am hearing a talk on the intrarenal flow, renal vein flow, and the portal vein flow. How you can get? I've looked at lung echoes. Yeah, I routinely see some. If I see a patient with severe LV dysfunction, I routinely see the lung echo, but not the renal vein flow and the portal vein flow and all that. It is really excellent, and always he has some points to learn for all of us. So what I am going to discuss is common day-to-day problems. So since I don't have a presentation as such on the nitty-gritties of the thing, so valve assessment, I will show you a few cases. You can stop me whenever you want a break for lunch. So I will start with mitral regurgitation first. Okay, because a number of young people, they were interested how to assess the mitral regurgitation, everything. So this I am presenting with the echo pack. So can any one of you tell that this patient is having what type of regurgitation? He has definitely a mitral regurgitation, which is very significant. You can see, even without shifting the baseline, you can see a proximal isovelocity zone, a PISA zone, even without shifting the baseline. When you see a PISA zone without even shifting the baseline, then it is definitely a significant regurgitation. Most probably, this is a severe tricuspid regurgitation. So what is the cause of this regurgitation? The next one is what is the cause of this regurgitation? Okay. I'll show you again the previous image, and I will play the side by side. If you see carefully, what is here in this, the left ventricular contraction looks almost normal. Left atrium is markedly dilated. But you see the anterior mitral leaflet is not co-opting with the posterior mitral leaflet. Anterior mitral leaflet goes inside. So if it is, most of you may think it is a flail anterior mitral leaflet or something like that. But it is the posterior mitral leaflet which is abnormal. It is not the anterior mitral leaflet which is abnormal. This is the posterior mitral leaflet which is abnormal. Okay. So I'll go on again. Say now you see the wall motion abnormality. You see the wall motion abnormality in the inferior portion of the septum, the inferior wall. So this is a case of inferior wall, in fact, that is tethering of the posterior mitral leaflet with mitral regurgitation, significant mitral regurgitation. Okay, so this is normally it is opening, but in systole there is a restriction in the mobility of the posterior mitral leaflet due to tethering, producing a severe mitral regurgitation. So now that we know the cause of the regurgitation and also most probably the severity of the regurgitation, we'll go ahead with, say, assessing the severity. Whenever I do the assessment, even if it is a mild case and all that, the thing which I do first is this one. Look at the E velocity first. So that is one of the things which will give you the idea about the severity. In this case, you may not be able to rely on that. In a normally contracting ventricle, normal LV function, if the E velocity is more than 1.5 centimeters, then it is 1.5 meters, then it is definitely it is a severe regurgitation. That is one of the things which is important. 1.5 meters in a normally contracting ventricle. When there is LV dysfunction, this criteria should not apply. That is one thing. And then second one, which I look at, is always the pulmonary vein flow. So look at the right superior pulmonary venous flow. There is a systolic reversal. When there is a systolic reversal, usually it is a severe mitral regurgitation. Normally, the S wave is the large one, as Nitin was telling. The D wave is a smaller one. If the S wave becomes less and less, then the mitral regurgitation is more. If the mitral regurgitation is severe, there is a reversal in the flow. So second one is look at the pulmonary venous flow. The third one is the look at we'll take this one. Okay. We'll freeze a frame. So we'll take this frame. So the next one is measure the vena contracta. Where is the vena contracta? Vena contracta is little below the anatomical valve orifice. So this is the Pisa zone, and this will be the vena contracta. Measure the vena contracta diameter. So if the vena contracta diameter is less than 3, usually it is mild. More than 7, it will be severe. So in this, it is about 8. So third one is measure the vena contracta. Then the other one is usually what we do, we can measure the area of the jet and compare it with the left atrial area. That is one of the earliest method described by Dr. Naveen C. Nanda. So we can also utilize it. Usually the color flow corresponds to the severity of the regurgitation. Usually, even though it is a velocity which we are visualizing, not the flow which we are visualizing, volume we are visualizing. The color flow depends upon number of factors. So when it's a flow like this, then we can measure the area and compare it with the area. The next one, these are all semi-quantitative methods. The E velocity, pulmonary vein reversal. Third one is the vena contracta width. You should also do some quantitative methods. The quantitative methods is one is shifting the baseline and measuring the proximal isovelocity surface areas diameter, Pisa diameter. So for this, I can shift the baseline. Where is it? I don't know where it is, the thing. Say without shifting the baseline, I'll measure. So this diameter we have to measure. So in this is the diameter without shifting the baseline. So this is about 8 millimeters. So we can take off the color also and see whether you have measured it correctly. Then you have to measure. You have to get the mitral regurgitation velocity time integral. So this is the mitral regurgitation velocity. Sorry, this is the tricuspid regurgitation. So the TR velocity is markedly increased. And this is the mitral regurgitation velocity time integral velocity. Then we can measure the mitral valve trace. You can go by like this and measure the velocity time integral and the peak velocity. So it is 4.7 and the velocity time integral is 1.67. So we have measured the radius of the pisa and the pisa at which we are, the velocity at which we are measuring it. We have measured at minus 0.64. So the other one is the velocity is 4.68 and the velocity time integral is 161.9. So from these 4 parameters, we can calculate the regurgitant orifice area and the regurgitant volume using the formula. Of course, if you go into the software and do it, it will automatically calculate your regurgitant orifice and it will tell you. So this is how we should do the mitral regurgitation in each case. So we'll just see this case alone. It is a little interesting one. So I will show you all the frames. So this patient actually got a dyskinetic, almost an aneurysm of the inferior septum and the inferior wall. At the level of the papillary muscle, the contraction is normal. Tricuspid aortic valve with sclerosis. You can see the mitral regurgitation, which is very severe. And there is a mild aortic regurgitation also. This is the E velocity and pulmonary vein reversal. And there is an aneurysm here. This is the apical long axis view. There is a mild tricuspid aortic regurgitation. This is the aortic regurgitation, which is seen in the continuous wave Doppler. There is a mild tricuspid regurgitation, and the velocity is high, almost it's 3.8 meters. So you can measure the velocity. You can see it has automatically measured. This one is very small, you can discard it. And then the, say, average of these two beats is 3.77, and the gradient is 56. Of course, you have to look at the IVC and the variation with respiration to assess the right atrial pressure added to that. Apart from that, you can see there is a ventricular septal rupture also. You can see there is a ventricular septal rupture with left to right shunt. That is the flow across the ventricular septal rupture. The IVC is dilated, reduced respiratory variation, and there is a mild pulmonary regurgitation also. You can see the jet is narrow, but it is almost 2 centimeters in length, but still it will qualify only for a mild pulmonary regurgitation. If you take the continuous wave Doppler, you can see there is the waveform is almost normal. Only thing, the E velocity, the early diastolic velocity is slightly increased because of pulmonary hypertension. You can see here. The E velocity is almost 2.85. So from the end diastolic velocity is about 2.25. If the E velocity, early diastolic velocity is more than 2.2, it will qualify for pulmonary hypertension. If the end diastolic velocity is more than 1.5, it will qualify for pulmonary hypertension. So from this, we can calculate the end diastolic pulmonary artery pressure and also the mean pulmonary artery pressure by using the formula. Okay. Any doubt on this case? We'll go on to the next case. Somebody was asking about, see, the mitral valve orifice area by short axis, it is severe. But when I take the pressure half time, the pressure half time is, say, small, and the pressure half time is 160, 180, and the mitral valve area becomes a larger one. So what is the cause? That was a question asked by one of the person. So we will take this case. So we shall discuss about, we can discuss about aortic mitral stenosis, and also we can discuss about other things. So this patient has got definitely a mitral valve disease, rheumatic mitral valve disease, and there is a rheumatic aortic valve disease also. So this patient, the mitral stenosis is definitely severe. The left atrium is dilated. We can measure it. We can measure the diameter, volume, etc. The aortic valve also is calcified. There is a restricted opening. There is definitely an aortic valve disease also. Maybe there is some amount of left ventricular hypertrophy. So we will go ahead with further examination. So we are putting on the color. There is a mitral stenosis, maybe a mild mitral regurgitation. The aortic valve, again, there may be a trivial aortic regurgitation. We have to look at the aortic valve better. Okay, we have enlarged it. Now we can see there is a systolic mosaic pattern. There is a trivial aortic regurgitation. So this patient has got a mitral stenosis, probably severe. Aortic mitral regurgitation is trivial or mild, and aortic stenosis and a trivial aortic regurgitation. So from the look of it, we are saying it is a mitral stenosis severe. So we will try to assess the mitral stenosis first. So here, so this is the aortic valve, which is tricuspid. So, and it is calcified. So it's a rheumatic aortic valve disease. So this is the short axis of the mitral valve. It is densely calcified. The anterior mitral leaflet is calcified. Posterior mitral leaflet is calcified. The lateral commissure is calcified. The only place is the medial commissure is not that much calcified. So we can stop it and then go frame by frame. Even in this calcified valve, you can see an orifice here. Maybe this is the orifice, and we can do a planimeter of the orifice area. So like this, we can go and do the planimeter of the area. I'm not doing it exactly correctly, but it's about 1.0 square centimeters. So from this, the mitral stenosis is definitely a severe one. There are two other methods by which we can get the mitral valve orifice area. One is by continuity equation. So another one is by pressure half time. So the question was about the pressure half time. So we'll try to get this one. So this is the apical four-chamber view. You can see this is the apical four-chamber view. There is a mitral stenosis and a mitral regurgitation. Definitely the mitral stenosis is severe. So then we have the continuous Doppler across the mitral valve. The mitral regurgitation is a faint one, so it's mild or minimal. And if you measure the gradients, so you can measure the gradient. I will put the auto measurements. So it is measured automatically. By doing auto measurements, it takes some of our work easier. So here it has marked it correctly because I have marked, so it remembers so what I have done. So it gives an average. The gradient is 39 and 14, which is definitely a severe one. 39 and 14 with a heart rate of 72. So sometimes the heart rate may be a little high, which may give a false high value. But in this patient, there was no mitral regurgitation. The aortic regurgitation also was very minimal. So yeah, 39 and 14 is definitely a very severe mitral stenosis. Only in the, say by mean and peak gradient, it is severe. By planimetry, it is severe. Now, when we measure the pressure half time, I will cancel it. Now I am measuring the pressure half time. The pressure half time is 108 and the orifice area is 2.0. So it only tells you that there is some problem with the left ventricle, left atrium, or both. So whenever there is a increase in the resistance of the left ventricle or the left atrium, then the pressure half time will be abnormal. So that will not accurately reflect the mitral valve orifice area. So in this patient, I have shown you already, this patient is having aortic stenosis, which is significant, and then he has the left ventricular hypertrophy. So because of that, there is an alteration in the left ventricular compliance, and then because of that, the EF slope, the pressure half time can vary. Even without the say left ventricular aortic valve disease, sometimes when the left atrium markedly dilates, the left ventricular elastance decreases. So the elasticity decreases and the pressure half time can become abnormal. We can actually calculate how much is the abnormality by using, there is a formula for calculation, and there are papers on that about the ventricular-arterial elastance, how to measure it and all that. So whenever you see a mitral valve orifice area which is severe by planimetry and the EF slope the pressure half time so abnormal, it only tells you that this patient is having associated left atrial and left ventricular disease. That's the meaning. What is the practical implication of it? This practical implication, if it is a mitral stenosis, you take this patient is a mitral stenosis patient alone. This patient has got only mitral stenosis. You want to do balloon mitral valvotomy for this patient. You have to be very careful because there is an alteration in the ventricular arterial compliance in this patient. If you produce a mitral regurgitation in this patient during a closed mitral commissurotomy or a balloon mitral valvuloplasty, that patient will not tolerate the mitral regurgitation, even if it is moderate or severe. So whenever there is an alteration in the ventricular arterial compliance, then you have to be very careful not to induce any mitral regurgitation. That patient will you have to go in for a urgent mitral valve replacement after that. So if it is ventricular arterial compliance is good, then they will tolerate even moderate. Sometimes I have seen even severe regurgitation they tolerate, and then we can plan and do the mitral valve replacement later. So, but whenever the pressure half time is more like this in a patient with severe mitral stenosis, be careful if you are going to plan for the thing. There is another thing which is present in this patient. We can discuss that one also. So the other thing is, this is the velocity across the aortic valve. So this patient has got aortic stenosis, I showed you, tricuspid aortic valve calcified with restricted opening. So if you see the aortic stenosis velocity, the aortic stenosis. Oh, okay. So here, say this is automatically measured the aortic valve peak velocity and mean velocity. Has it correctly measured it? No. Dr. Nitin was telling, I think I was hearing that beard and the chin. So this has included the beard also. So it has included the beard, whereas the chin is here. So we have to alter it. We have to reduce the sensitivity like this. I am altering it till I am satisfied. So this is somewhat okay. Now it is measuring at the chin area. So the actual velocity is 3.9, 60 and 36. So this will correspond to almost moderate to severe stenosis. Okay. So in this patient actually the LVOT BTI, this is the LVOT, a little lower down, but I don't know, so we have taken it little lower down, that's okay. But the LVOT BTI is about 28.1. So if you use this one and measure by continuation, if you measure the area, it was say severe stenosis in this patient. This patient has got a severe mitral stenosis with a severe aortic stenosis. But the velocity, somewhat it was in the, say, moderate range, a little below 4 meters, little below, for mean gradient was about 35. And we can calculate actually the flow. The flow is completely normal because it is about 28.1. Any flow, the stroke volume of more than 35 ml per meter square body surface area is usually a normal flow. Below 35, we have to think in terms of reduced flow across the left ventricular outflow tract. So in this patient, the flow was normal, but the gradient was slightly lower. But the severity of aortic stenosis is severe. Okay. There can be sometimes say differences in the gradient and also the area which is calculated. So when cases like this, we use some other methods. Anyway, we are going to have a talk on aortic stenosis. So I think we will have that at that time. So I will show you rapidly two cases. One is the one which we don't discuss that often. So, no. I'll go through rapidly. So, what you can see is dilatation of the right ventricle here. And the mitral aortic valves are normal. RV is dilated, paradoxical septal motion. So you have to think in terms of an ASD, severe tricuspid regurgitation, severe pulmonary regurgitation, or both, or sometimes TAPVC. So those are the conditions which can produce marked RV dilatation. So the pulmonary valve is normal. So very unlikely there is a significant pulmonary regurgitation. There is a trivial pulmonary regurgitation. So the pulmonary regurgitation velocity is normal. The pulmonary valve, this thing is normal. Now what you see is this is the RV inflow tract. This is the anterior tricuspid leaflet, and this is likely to be the posterior tricuspid leaflet. If you see here, there is a very severe tricuspid regurgitation. So there is a flail anterior tricuspid leaflet with a significant tricuspid regurgitation. And if you see the Doppler pattern, it is triangular. So a triangular Doppler pattern indicates that the right ventricular end-diastolic pressure, is increased, the right atrial pressure is increased. That's why you get a very low velocity tricuspid regurgitation with a triangular pattern like this. So this is a patient with severe tricuspid regurgitation due to a flail anterior tricuspid leaflet. This is a septal leaflet, this is the anterior tricuspid leaflet. RVRA are dilated. So in these patients, you have to assess the severity of the regurgitation. Here it looks almost like a laminar flow. So you don't see the multicolored mosaic pattern of tricuspid regurgitation. It's almost a blue color with varying degrees of blue, that's all. It's a laminar flow, which is laminar tricuspid regurgitation. So in these cases, we have to measure the vena contracta again, the vena contracta of the, say, jet. And that needs to be done in two planes, especially in the, say, this is the biplane. So this is the 4-chamber and they are almost like a 2-chamber. Then in these two planes, you can visualize the regurgitation jet. So measure the vena contracta in both the planes and take an average. That is one measurement which you have to do. And also we can measure the E velocity of the antegrade flow. If it is more than 1.2, it usually indicates a severe tricuspid regurgitation. And then we can also do the PISA method for the tricuspid valve. So we can go frame by frame like this. How to change the baseline? Below, okay. Baseline is okay. So, okay, like this. So the baseline, I have changed it to minus say 2.5, minus 25 centimeters. Okay, then we can measure the PISA diameter. So we can measure the PISA diameter in this view, and the other view. So both the views we should measure the pizza diameter and then calculate the regurgitant orifice area from the TR velocity and the pizza radius. So it is not enough if you do it in one view. You have to do it in the two views, two orthogonal views, and then assess the severity of the tricuspid regurgitation. So one is the vena contracta measurements. The second one is the PISA method from two views. And the third one, we can use the continuity equation method to calculate the flow across the tricuspid valve and flow across the pulmonary valve or flow across the aortic valve. The difference will give you about the tricuspid regurgitation volume. The third one, this we have done it, it's because of want of time I'm running it through. It's okay. We'll go through the other things. This is assessing the right ventricular function in that. This is a regurgitation thing. So we have taken the color flow. This it may not be so great. So this is the color flow and the 3D color flow. So from this, we can go through the vena contracta level. At the vena contracta level, we can freeze and then measure the regurgitate area at the level of the vena contracta. So we can go frame by frame like this. Even though it may not be accurate, you have to do it accurately by the multiplanar method and then get the regurgitation orifice area like this, and then we can measure the area of the vena contracta like this. There is a different method, so we can use a different method and calculate it. So we have to use the different methods and calculate the area of the tricuspid regurgitation jet. So why this is important? So because they have come out with a newer classification: mild, moderate, severe, massive, and torrential tricuspid regurgitation. They have divided the TR into 5 grades. Why again they have done it into 5 grades? Because they are going to do some interventions for the tricuspid valve to reduce the tricuspid regurgitation. Most of the time, surgery on the tricuspid valve carries a higher mortality, whereas structural intervention, if you are able to do, that will be a better option. So that's why they have divided the tricuspid regurgitation into 5 grades. Even if there is a reduction of the severity by 2 grades or 3 grades, if it even torrential regurgitation, if it becomes moderate or moderate to severe, then it is a good intervention which may prolong the lifespan of the patient by a few years. The trials are going on, the results are not yet out, so we will be knowing it in future. The other one, this one I would like to discuss again. The last one, another 5 minutes I will finish. We'll go on to the last one. With this, we'll finish. So this is a patient obviously with an aortic stenosis. So how to get the LVOT diameter? The LVOT diameter we have to measure. Here we are seeing my aortic valve better. So we are seeing it accurately. Don't take, even when the aortic valve is normal, if you are seeing the right cusp and another posterior cusp accurately, don't measure at that level. Measure at a level where the anterior cusp is clearly visualized, but the posterior cusp is only visualized partially. That is the level at which you have to measure. So for that, you have to tilt the probe, slightly tilt the probe. I have tilted the probe so that we are slightly angulated. Why we have to angulate? That I will tell you. because say when you say here if you see the measurements, the measurement of the annulus should be taken from the right coronary cusp here to the commissural level. Sorry. I'll take from here anteriorly to posteriorly at the commissural level. When if you that's why because we are going through the commissure between the non-coronary cusp and the left coronary cusp, none of the cusp will be clearly visualized. So take the measurement when you are not seeing the posterior cusp clearly. That's the frame from which you have to take it. If you are able to see both the leaflets, then it means you are cutting like this. Say the anteriorly right coronary cusp and the non-coronary cusp, or here anteriorly the right coronary cusp and the left coronary cusp. If you are cutting like this, then you will get a shorter diameter. This one, the correct position is between the anterior cusp and the commissure between the right coronary cusp and the non-coronary cusp. To get this in the 2D, you have to tilt the transducer and see that you don't clearly visualize a posterior cusp. So at that level you have to take it. So this I will run it because here when you see it is actually moving from say commissure to right side. So even in this it is very difficult. You have to go frame by frame and be sure, even if you are using a biplane method. If you have a single plane only, then we have to tilt it and position it in a proper place to measure the LVOD diameter. The other thing is, after getting this, the measurement should be done in systole for the LVOT diameter, and you should not measure like this over the valve itself from here to here. It should not be measured like this. Then you will get a larger diameter. You should take it just below the aortic valve, little inside the LVOT. So then only it will be accurate. So like this, somewhat here. Okay. Or not further down into the LVOT. Then it will be very small. So you have to take at a proper place with a proper position of the transducer. Then only you will get the aortic valve diameter correctly. The second most important thing is the LVOT velocity time integral. If you see this patient, you can see here there is a flow acceleration just below the aortic valve. You should not take it in the area of the flow acceleration, little below. Say you have to so this is a position we have marked 1, 2, and 3. You have to take it at position 2. That will be the ideal place when you have a flow acceleration like this. So this we have taken at the level well below the acceleration. It is not a correct one. This is at the level of just below the acceleration, and this is at the level of the acceleration. So you have to adjust your pulsed Doppler sampling volume inside the LVOT. Whenever there is actually increase in the velocity and there is an aliasing like this, then you have to be careful to avoid this aliasing, keeping the pulsed Doppler sampling volume over the aliasing and measuring the LVOT VTI. So this is the second thing we have to be careful. The third thing, if all of you know, in a patient with in a mitral stenosis, it is always easy. Because if you see the apical four chamber view, most of the time from the apical four chamber view, you can get the peak velocity of the mitral stenosis and measure all the parameters. In aortic stenosis, say the jet may be in a different direction. 80% of the times you can get the maximum velocity from the apical 5-chamber view or from the apical long axis view. But in 20% of the times you have to use the high parasternal, suprasternal, even right parasternal. Right parasternal is one of the most important views for getting the peak velocities in certain patients where the jet is directed upwards, superiorly. So with that, I'll stop, I think, sir. Yes, that's it. I have delayed you by 20 minutes. Please ask an easy question.
It's for Nitin, actually. It's not for you, sir. Dr. Barthule,
Oh, for him.
you have mentioned 3 parameters for diastolic dysfunction: E prime, E by A ratio, and enlarged airway volume. I think the third parameter should be TR velocity, more than 2.8. Because in 10% of patients with normal diastolic function, you get an enlarged airway. What about the cause maybe? You have excluded or still there is enlarged airway in 10% of patients with normal diastolic function. So it is proposed that instead of taking the enlarged airway as the third parameter, you concentrate on the TR velocity. More than 2.8, that is an important criteria to observe. What is your comment on this?
Yeah, see, it's true that each one of these parameters, the cutoff had been quite stiff, okay? So that is why if you're not reaching that, okay, you always have the other one readily available there, okay? So even when you don't have, see, when your basic parameters for the filling pressures that we are talking about is that if your TR velocity is still low and suppose, as you said, um, uh, the suppose the TR velocity is high, already you have got one parameter. Even if your LA is not enlarged, your LA reservoir strain will be very sensitive parameter to pick up. Even if it is not there, you can look at the pulmonary vein. Pardon? Yeah, that is true. As you will keep on adding more and more parameters, obviously your specificity is going to go on increasing. Okay, so that is why at least if you have got two concurrent parameters going in the same direction, okay, you are getting an optimal sensitivity specificity. But as you keep on adding more and more parameters, obviously your chances of picking up high filling pressures will be much more accurate. That is definitely true. But somewhere you'll have to draw a line, because when you put four parameters to be positive to get a particular clinical value, you will reduce the sensitivity. So that is why you have to somewhere strike the balance. So that is why they are restricting to 2 parameters.
With normal individuals without cardiovascular risk or cardiovascular structural disease, in normal persons with normal no risk factors, the E by E prime ratio comes to more than 15. Or E, so what to do in that case?
It's very see, that is why they, if you see the even the lowest E primes for the age group, okay, still getting an E by E prime average more than 15 is definitely abnormal. I think then we are definitely missing something, because it's very unlikely that in a healthy person you will get that, because the lowest E primes, even if you take, and the E velocities you will take, it's very unlikely you will reach 15.
No, I agree with that with children and adolescents, the E by A ratio is more than 2 because of good suction.
Yeah.
But in those, apart from those patients, the normal population, it is studied by a paper from China. They are saying that it is associated later on with increased adverse events.
The E by E prime.
E by E
yeah,
prime.
true. So those thresholds above age of 65 had always been shown to be associated with the outcome. That's true. But I think when we are way above 14, definitely we are picking up not a normal patient. It has to be an abnormal one. Yeah. But obviously we cannot rely only on one parameter. So even if your E by E prime is above 14, you will try one corroborative factor looking at the LA strain, LA volumes, and also looking at the E by A ratios less than 0.8 or about 2. So you are adding something to that and you are not relying only on one, because there can be measurement mistakes also there. So that is why you need 2 or more parameters that you are looking for.
Fair enough. Thank you.
Nitin sir, fabulous talk as always. Sir, I have a question. Hepatic congestion. So we have a RV dysfunction, sort of a tricuspid regurgitation, constitutive pericarditis, pulmonary hypertension we deal with. So, sir, we see the diameter as well as systolic flow reversal.
Yeah.
As we come down in intra-abdominal, so more than 12 and 20 more than, there is a compartment syndrome. So how to corroborate, sir, in septic phase, there is a leaky capillary and there is fluid accumulated inside the abdomen causing renal dysfunction. It is a mechanical sort of a dysfunction.
Correct.
How to corroborate these two finding, echo finding and...
So the thing is, you are looking at the, see, what you are indirectly looking at the gut edema, correct?
Yeah,
Isn't
yes,
it? Because
yes.
gut edema, ascites, and then that is causing restriction. So the thing is, if your portal vein is not a continuous forward flow, and if it is a phasic flow, and especially if the phasic change is more than 50%, so very, very highly likely that this patient is going not to do well. Okay, that is what we know. So looking at the phasic flow, the moment you have got a phasic flow, that can actually corroborate this, your theory that there is a external tamponading effect on the organs because of the ascites or increased intraperitoneal pressure. However, suppose the congestion lasts longer and the phasic flow again goes down and becomes more uniform, that is also a bad sign. That means what has happened is that no more the hepatic veins can reflect the pressure into the hepatic sinusoids because of fibrosis, that is cardiac cirrhosis. So again you pick up a cirrhosis also later on. Okay, so that is how it is. Okay, so when you are diuresing, if it is normalized, well and good. If it remains for a longer period but then it normalizes on its own, is not a good sign. That means you are developing a cardiac cirrhosis.
Thank you very much.
Thank you so much. We break for lunch and we'll be back for the next session by 2:10. Welcome back everybody post lunch. We'll be starting the next session, live in-box demonstration. I would like to invite the chairpersons on the dais, Dr. Achyut Sarkar, Dr. Shourangshu Chatterjee, Dr. Debashish Bandyopadhyay, Dr. Mahesh Choudhury. Requesting our chairpersons to please join on the dais.
আসুন দেবাশিস, বসুন। হ্যাঁ,
রেকর্ডেড কেসেস দিয়ে দেখানো, রেকর্ড করা আছে। হ্যাঁ, আপনারা যেভাবে বলবেন ব্যাপারটা, আপনি যেটা বলবেন সেটা ওরা চালাবে। পরপর করে ছখানা কেস রেকর্ড।
না ঠিক পরপরই ডাকবো তো।
ডাকতে হবে না, মানে এটা
আচ্ছা
স্ক্রিনে দেখানো।
আচ্ছা, তো এরা সবাই এসে
সেটা একটু আপনি বলে দেবেন।
তোমারটা প্রথম শুরু করে দেবো।
না না না,
অভিজিৎ আছে তো? আছে তো, আছে, দেখিনি, দেখতে পাচ্ছেন?
জিনিসটা একটু বলে দিই, এটা প্রি রেকর্ডেড।
হ্যাঁ, ঠিক আছে।
People are there to answer the questions at the end of the session. এরপরে এই দুটো আপনার
কিস প্রেজেন্টেশন না, এরা সবাই এসে তো, সবাই এসে কাউকে দেখতে পাচ্ছেন, দেখতে পাচ্ছেন। আচ্ছা
Good afternoon, everybody. We are going to start the post-lunch session. This is really nice, and we try to make you awake throughout the session by nice demonstration of the already recorded case, and will be presented by the respected doctors. And in the last of the video session, you have some question to be answered by you people. So we are going to start the first case, very common, mitral stenosis and regurgitation by Dr. Abhijit Bishwas. That case, please start the case and MSMR.
This is basically recorded session, and this will be projected, and then after the session is over, the questions and other discussion will follow.
Hello, greetings from West Bengal Academy of Echocardiography, or WBAE, which, as you all know, is the West Bengal branch of Indian Academy of Echocardiography. So here at WBAE, we have a very good intention of making a video presentation live in box on practical echocardiography cases from our day-to-day practice. And with the help of our colleagues at WBAE, we are going to make presentations on several topics, which will include valvular heart diseases, that is native valvular heart diseases, both aortic and mitral. Then tricuspid valve cases associated with pulmonary hypertension and RV function abnormalities. Then prosthetic valve assessments and abnormalities. And then we are going to have a look at cardiomyopathies, basically dilated cardiomyopathy, both ischemic and non-ischemic. And then we are also going to show some cases of restrictive physiology. And finally, we are going to end it all with infective endocarditis. So, dear friends and colleagues, I am sure that you are going to find this extremely enjoyable, educative, and it is going to be some take-home message for you in your day-to-day practice. So, happy viewing, and all the best to my colleagues as well.
My patient is a 38-year-old male subject from Murshidabad, was admitted with history of shortness of breath and palpitation. He also gave history of balloon mitral valvotomy about 7 years back. He got admitted in the ICU, and we did the echo in our lab. The finding is, we found that he is having thickening of both anterior posterior mitral valve leaflets with dilated LA, prominent LV, and there was also thickening of the aortic valve. The mitral valve opening was restricted. There was mild subvalvular fusion. So immediately our diagnosis came out to be a rheumatic mitral valvular restenosis, and he was treated accordingly, and the patient was in atrial fibrillation. So as soon as we got the patient of this rheumatic mitral restenosis in atrial fibrillation, we tried to ascertain what grade of severity the patient is having. So as we can see, visually we felt that the stenosis was severe with moderate grade of calcification of both anterior posterior leaflets. The posterior leaflet calcification bit somewhat more. And we also tried to find out what are the associated valvular lesions the patient is having. So we, from parasternal long axis view, we went into the apical 4-chamber view. We found that his LV was also a bit prominent. The LA was, as we told, is dilated, and but surprisingly, the RA and RV was not so thick, not so big. So our diagnosis was mainly mitral valvular restenosis. As soon as we put on the color Doppler, we found that there was mild to moderate mitral regurgitation with a flame-shaped mitral stenosis jet. So we wanted to quantify the degree of mitral stenosis. So we changed the view from parasternal long axis to parasternal short axis view, and we selected the proper plane using the multi-D mode, and by planimetry we calculated the mitral valve area, and it came out to be around 0.9 centimeter square. And to confirm, we tried to find out actually by the 3D whether the valvular stenosis is severe or not. We found that actually there is a huge chunk of calcification in the posterior mitral leaflet with a severe degree of probable stenosis. So in all the levels, we found that there is severe degree of stenosis. Now, we found by planimetry, the degree of stenosis was severe, both by 2D method and by 3D method. So next step, we tried to ascertain the degree of stenosis by pressure half time. So we changed the view from apical, from parasternal long axis and parasternal soft axis to apical 4-chamber view, and we put on the continuous wave Doppler across the both leaflets of mitral valve, and the patient being in average atrial fibrillation, we calculated the mitral valve area for at least 5 to 6 cycles, and the mitral valve area by pressure half time method, that is Hartley's method, it was around 0.62. So it correlated well with the planimetry calculation. The mitral valve area is 0.62, and by that method it's 0.82. So it's severe mitral restenosis. Now, while calculating the mitral valve area by pressure half time, we carefully selected the proper the median slope, leaving out the early tall part, because this is the sky slope area which as per recommendation has to be left out to calculate the mitral valve area by pressure half time method. So by pressure half time, my mitral valve area was 0.62, and by auto-generated formula from our machine, we also calculated the mean mitral valve gradient across the mitral valve. That was for consecutive 5 cycles. It was around 3.6 to 3.4 millimeter mercury, and this portion of the mitral gradient did not correlate with the severity of the stenosis. But as we all know, it may not correlate with all the methods may not correlate with each other while calculating the mitral valve area. So, the next step of calculation of mitral valve area is we used continuity equation, where we found that by continuity equation we calculated the aortic valve area diameter in the parasternal long axis view, and then calculated the VTI of the aortic flow. And by dividing this product by the mitral valve VTI, we found out the area of the mitral valve, and that also came out to be 0.49 centimeter square. So by these 3 methods, the pressure half time planimetry and continuity equation, we got the result to be severe mitral restenosis with moderate degree calcification of mitral valve with mild subvalvular fusion, and if we calculate the Wilkins score, if we go via the degree of thickening of the anterior mitral valve leaflets, the degree of calcification, the mobility and subvalvular thickening, I will put it around 6 to 7. So, my conclusion is this is a case of severe pliable mitral valve restenosis. Now, next we wanted to assess the degree of mitral regurgitation in this patient. So, to assess the degree of regurgitation, whenever there is regurgitation, one must ascertain three things. One, whether it is a rheumatic or functional, but this step we skipped because we already know the patient is a known patient of rheumatic valvulitis, and so it was rheumatic mitral regurgitation. The next step was degree of or the severity of mitral regurgitation. If we look at the picture, naturally the immediate eyeball method, the impression is you are having a mild mitral regurgitation, but still this is a very qualitative method. The semi-quantitative method is calculation of vena contracta. Vena contracta calculation can be done both by 2D method and the 3D method. So, vena contracta method calculation, you calculate the vena contracta or the diameter of the jet that is emerging immediately out of both the leaflets of mitral valve during the diastole. So, this should be remembered. The vena contracta method, the diastole valve, the area came out to be, or the thickness came out to be 0.3. And the third and the most important method is via PISA method. For PISA, you must have three things. One, the PISA velocity, the radius of the MR jet, and the Nyquist velocity. So, we calculated the PISA, the regurgitant jet by PISA, and the PISA radius was, MR radius was 0.82, arising velocity was 0.36, and the flow rate was 153 milliliter per second. Now, we traced the mitral regurgitation rate, and the ERO came out to be 0.3 centimeter square. This suggests the mitral regurgitation is mild or borderline moderate. Most probably the degree of regurgitation is mild, because the MRO should be less than 3, it's mild, 3 to I think 4 it's moderate, and more than 4 is severe. So, my case is mitral regurgitation of mild severity. Now, next step is my patient also has a very atypical finding. As we can see, he has mild TR. Severe rheumatic mitral restenosis with mild TR, and without pulmonary hypertension is not so common. As you can see, the pressure TR gradient is 6 millimeter mercury. So, calculated pulmonary pressure is around 10 to 12 millimeter mercury. Now, his IVC is not plethoric and collapsing with inspiration. So, there is no systemic venous congestion, but peculiarly he has got severe systolic dysfunction. When we did study of his right ventricle, we found that his fractional area change was 20%, his TAPSE was 2 millimeter, and the free wall RV free wall strain was minus 3.6%. So, this implies he has got RV systolic dysfunction. So my subject has severe mitral restenosis, pliable, with mild to moderate MR, with mild TR, without pulmonary hypertension, with biventricular systolic dysfunction.
We'll call the next. Discussion. So we'll call upon the next presenter or us to. Okay, the next will be ASNAR. You know, by Dr. ASNAR by Dr. Rajat Shubro Ghosh. We can have discussion at the end.
No, but you can have a small talk. He's not
Friends and
ready.
colleagues, we at WBAE have been trying to organize training programs so that the standards of echo evaluation across all laboratories follow the same protocol. My talk is on aortic valve disease, and the exercise is particularly aimed at the fact that recent times there's been recent advances in management of aortic valve diseases. Both percutaneous and surgical AVRs have been done. So with that in mind, we need to have accurate data so that we can choose our patients correctly and get the right morphology of the aortic valve to aid in the management of the patients. So before we start, there are certain basic things that I would like to highlight. One is we must have an ECG connected to the patient for all our cases, and then enter the height, weight, and blood pressure, because blood pressure is very important when we are doing a hemodynamic evaluation. So, and we do a brief clinical examination before we start the testing. The first case,
I'm going to share with you a few cases of echocardiography in aortic valve disease. As we all know that there have been recent advances in percutaneous and surgical interventions in aortic valve disease, and it has become imperative that we learn how to accurately define the morphology, assess the hemodynamics, and evaluate the left ventricular function for these cases before intervention. Before commencing any study, we need to have a clinical background of the patient, do a clinical examination, look at the ECG, X-ray, take the blood pressure, enter it in the patient data, take the height and weight, and also connect the ECG cables before commencing the study. So as in any study, we start with the parasternal long axis view to give us an idea of the chamber dimensions, the left ventricular function, the wall thickness of the left ventricle, the aortic size, and the aortic and mitral valve. In this case, the aortic valve appears thickened, not very calcified, but shows restricted opening. Perhaps the most difficult aspect of evaluating the aortic valve area by the continuity equation is assessing the left ventricular outflow tract area. So the recommendations are to measure the LVOT dimension by zooming into the LVOT and take the measurement just below the aortic valve leaflets and avoid any calcifications. And then this diameter is used to calculate a circle area. However, we know now that the LVOT is usually not a circle but an ellipse with the anterior-posterior diameter less than the medial to lateral diameter. So we can use the X-plane imaging to actually planimeter the LVOT area, but we have to do it very carefully so that we are doing it just at the level where we are going to place the pulsed wave Doppler sample volume to assess the stroke volume. Next, we zoom in on the aortic valve to look at the morphology. This is a bicuspid valve with a raphe posteriorly. The fused cusps are of the left coronary and the non-coronary cusps, and there is an elliptical orifice, which is the hallmark of a bicuspid valve. You can observe the calcification on the raphe and modest calcification of the cusp margins. Next, we move on to the mandatory measurements of the aorta and the aortic valve. These are done in a zoomed view. The LVOT measurement was taken in systole earlier. Now we take the measurement of the aortic valve, again in systole, and then freeze it in diastole, preferably in diastole, to measure the aorta at the level of the sinuses and at the level of the sinutubular junction and of the ascending aorta. Now we take a look at the short axis of the left ventricle to see the left ventricular systolic function and wall motion abnormality, and then a short axis at the level of the aortic valve to look at the aortic valve stenotic orifice and the jet that is passing through the stenotic orifice. So next we take a look at the apical long axis and the apical 5-chamber view to take a look at the stenotic jet and align it so that we get a good CW Doppler spectral tracing to measure the peak velocity across the aortic valve and the mean gradient across the aortic valve. The LVOT velocity is recorded with the PW Doppler from the apical approach, either from the apical 5-chamber view or from the apical long axis view. The sample volume is positioned just proximal to the aortic valve. It should be optimally positioned so that a smooth velocity curve with a well-defined peak and narrow band of velocities throughout systole. It should not be very close to the stenotic aortic valve to avoid spectral dispersion, which happens near the valve. We can just pull it back a little towards the apex to get a clear signal. Then we measure the spectral tracing to get the mean and the peak, mean VTI of the LVOT gradient. In order to take the highest velocity, we need to use multiple acoustic windows to get the highest jet across the aortic valve. Here we are using the subcostal view, but evidently the jet is not aligned with the transducer. Next we take a look at the right upper parasternal view with the patient in right lateral position. We try to get a hold of the jet and see if it's greater than the one we've seen in the apical 4-chamber view. We can also look at the jet from the suprasternal view, look at the arch and look for any coarctation if present. Ideally, a dedicated small dual crystal CW transducer, also called the pencil or the Pedoff probe, is used for these velocities which are taken from the suprasternal or the right parasternal view. And finally, before completing our study, we look at the left ventricular function, wall motion abnormalities, and also the global longitudinal strain, and then look at the diastolic function, look at left ventricular pressures and the right ventricular pressures before we conclude the study. Looking at the PW flow pattern of the mitral valve, it shows a grade 1 diastolic dysfunction with normal left atrial pressures. We take a look at the right ventricular pressures by measuring the tricuspid regurgitation gradient. And finally, we measure the IVC in inspiration and expiration to get an idea of the right atrial pressures before concluding the study. So in conclusion, this was a 64-year-old lady who presented with shortness of breath on exertion with no history of chest pain or syncope. She did not have a history of hypertension, diabetes, kidney disease or anemia. On auscultation, there was an ejection systolic murmur in the aortic area. ECG and chest X-ray suggested left ventricular hypertrophy. Her transthoracic echocardiography shows a thickened, mildly calcified bicuspid aortic valve with fusion of the left and non-coronary cusps and calcific raphe posteriorly, resulting in an elliptical stenotic orifice. The mean transaortic gradient was 42 millimeters mercury, and the peak transaortic velocity was 4 meters per second. The DVI was 0.20. The calculated aortic valve area was 0.5 centimeter square, and there was no significant aortic regurgitation. She had left ventricular hypertrophy with normal left ventricular systolic function and grade 1 diastolic dysfunction. The other valves were normal. There was no evidence of pulmonary hypertension. Effacement of the sinotubular junction was noted. The ascending aorta was dilated on index value, and there was no coarctation of the. Moving on to another case. Here there is a dilated left ventricle with poor LV systolic function, and there is a central regurgitation jet of aortic regurgitation. So here we can see a central jet of a moderate AR. The jet width and the LVOT width can be compared. Here it is 35%. We can also take a look at the ARP half time, which between 200 and 500 suggests moderate AR. We need to have a good spectral tracing for that. We can also measure the VTI of the AR, and combining with the PISA radius, we find out the regurgitant volume and EROA of the AR. Next, we go up to the suprasternal view, look at the aortic size, and also look at the flow within the aorta, whether there is flow reversal. We do a pulse wave Doppler study to see any flow reversal. If there is holodiastolic flow reversal, it suggests at least a moderate to severe AR. Just to demonstrate how to measure vena contracta of aortic regurgitation, I've chosen a case of rheumatic heart disease with both valve disease. Here there is mitral valve involvement with mitral stenosis and aortic valve involvement with a moderate AR. Now we need to zoom in on the left ventricular outflow tract and get a good color Doppler tracing to visualize the regurgitation jet, and we identify the narrowest portion of the jet which occurs just downstream from the flow convergence zone. Now when we measure the narrowest portion, if it is less than 3.3 centimeters, that is 3 millimeters, it's a mild aortic regurgitation, and if it is more than 6 millimeters thickness, then it's a severe aortic regurgitation. Moving on to another case of aortic stenosis. Here we can see a stenosed aortic valve with minimal movement in systole. There is calcification on the right coronary cusp. There is also aortic regurgitation which appears mild. There is mild mitral regurgitation. The left atrium appears enlarged, and the left ventricular function also appears depressed. We shall see later on. So we do our usual measurements, measure the aortic annulus in systole, we measure the aortic LVOT dimension in systole, and then go on to measuring the aortic diameters in diastole at the level of the sinus, at the ST junction level, and at the level of the aorta. These are mandatory measurements that are required for future use. Now, having made those measurements, we can also do the same thing that we did in the earlier case. We can try a biplane method where we measure the area of the LVOT by planimetry. The results of the continuity equation with planimetry is usually slightly larger than with LVOT dimension only. So here the LVOT area by planimetry is 4 centimeters square, whereas the LVOT diameter is 2 centimeters, which comes to 3.14 centimeters square. Here the short axis of the left ventricle showed reduced left ventricular function. Zeroing in on the aortic valve, the short axis of the aortic valve shows another bicuspid aortic valve with a raphe anteriorly. Here we can actually planimeter the aortic valve area, and that has come to 0.8 centimeters square. Next, we move on to continuity equation. We measure the LVOT spectral tracing. So we get the LVOT VTI, the same way that we saw earlier, and we go on to measuring the CW, the continuous wave Doppler measurement of the aortic valve to get the aortic valve area. Usually more than 3 readings are required for averaging. The machine sometimes does the spectral tracing. We can do it manually also. So you notice that though the aortic valve appears severely stenosed, the maximum velocity is far less than in the previous case, it's 3 meters per second, and the mean gradient is about 24 or 25 millimeters mercury. Whereas when we use the continuity equation with these same measurements, the aortic valve area came to 0.8 centimeters square, which appears to be severe. So this is a case of severe aortic regurgitation, aortic stenosis with low flow and low gradient. So, while completing the case, we found that the patient was in heart failure, the IVC was distended, there was pleural effusion and pericardial effusion. So, this case actually brings out the discordance between the aortic valve stenosis, which appears severely stenosed, whereas the pressure gradients do not match up with the severity. This happens when the left ventricular function is less and the stroke volume is less than 35 ml per meter square. So we have to be aware that we just cannot go with the gradients. We have to take into consideration that the left ventricular stroke volume determines the pressure gradients, and even sometimes when there is normal ejection fraction with a small LV cavity, we can have smaller stroke volumes which reduce the pressure gradients across the aortic valve. So these are considerations that must be kept in mind.
So to summarize, we need to follow the protocols that have been set up by ASE, and it is important that we are all on the same page so that the reporting is uniform and it helps in surgical decision making.
Good afternoon, everybody. At the outset, I would like to thank the organizers of WBA Annual Conference Ezecho 2025 for having me here in this live in-box case presentations. I would discuss two cases here today, based mostly on right ventricular quantification, pulmonary hypertension assessment, as well as quantification of tricuspid regurgitation. Let's begin with case number 1. This was a male aged 33 years who came with chief complaints of dyspnea, NYHA class 2 and cough for 5 days, pain right cuff for 4 days. He had a past history of DVD left leg in July 2023. He is a smoker. After detection of that DVT in July 2023, he was on Eliquis, which he stopped on his own without doctor's permission. On examination, his heart rate was 116 per minute, BP was 114/80, height was 176, weight 76 kg with a BMI of 24.54. The systemic examination revealed raised JVP, but there was no pedal edema, right ventricular S3 was present, liver and spleen were non-palpable. This is the parasternal long axis view of the subject, where you can see there is an obviously dilated right ventricle, and in the color, this is color-coded parasternal long axis once more. This M mode of aortic valve left atrium was taken not for any quantification, which has become obsolete now. I just kept this slide to show that you can see some of the aortic valve systolic spectrum is not the box shaped as we usually get in normal subjects. It kind of tapering down towards the end systole. This is perhaps because of compromise in left ventricular contractility or left ventricular ejection at the later phase of the systole, subject to the disease the patient has come in with. This parasternal, this M mode of LV RV cavity for parasternal long axis has been shown again, not for any quantification, but to give you an idea that the RV is more dilated than it is usually, which is better appreciated in this parasternal short axis view, where you can feel that the left ventricle is not the circular as it usually in these views. RV is obviously very dilated, and the left ventricle is kind of D-shaped in systole, which suggests pressure overload of the right ventricle. The short axis at the great vessel level, this has been taken, pulmonary artery appears mildly dilated, not significantly. There is some suspicion of a shadow in the right pulmonary artery, but this doesn't definitely qualify as a clot. The parasternal short axis, same with the color code, shows a clear, rather clear right pulmonary artery branch, but sometimes there is a little bit of whitish shadow which is suspicious but not confirmatory of any clot. The right ventricular systolic function is compromised with a TAPSE of 11.6. This is the RV focused apical four chamber view, which again shows a dilated RV and RA. Another view of that, this picture has been taken for you to appreciate that what we call McConnell sign. McConnell sign is a sign which is pathognomonic of pulmonary embolism. It has a very high specificity, above 90%, but a rather low sensitivity. What is McConnell sign? There is a mid-free wall of the RV is akinetic or severely hypokinetic, while the RV apex shows normal or hypokinetic contraction. This is often due to tethering to the LV and mechanical support RV getting from it. Here you can appreciate the McConnell sign better. As you can see in the upper part, then the RV apex is moving well, but the RV free wall in the mid and basal segment is definitely hypokinetic. Let's go on further with the case. This is the tricuspid valve S prime, lateral annulus S prime. Again to show that it's about 8.8, so it shows once more that the RV systolic function is compromised. There was a TR, mild to moderate, with a peak TR velocity of 3.55 meters per second, corresponding with about 50 millimeters of mercury TR pressure gradient. Another view of the thing, this measurement is somewhere close to what we got the other time, about 48 millimeter of mercury. This was to measure the pulmonary acceleration time. In the next slide, I will tell you why we are doing this, but this obviously shows that the acceleration time is greatly shortened. There is something which is called a 60-60 sign, which again is pathognomonic of pulmonary embolism, acute pulmonary embolism. What is 60-60 sign? Where the pulmonary valve acceleration time is less than 60 milliseconds, and the TR derived RV systolic pressure is less than 60 millimeter of mercury. This sign again has a very high specificity, but a low sensitivity. And in this same patient, you can see the IVC is dilated about 27 millimeters with reduced collapsibility, suggesting fluid overload. So the RV strain was also taken, which is again compromised. The global strain is 10.3 and the free wall strain is 7.5. So the final diagnosis of this patient was a deep vein thrombosis with pulmonary hypertension, RV dysfunction, suggestive of acute pulmonary thromboembolism. We couldn't do any further investigation on the patient because the patient was immediately rushed to a hospital for further management. He's young, 33-year-old, otherwise fit, so saving his life was a priority here. He was admitted to medical super specialty hospital where they did a peripheral venous Doppler of both lower limbs, which showed a right-sided DVT with partial canalization, and the thrombus was seen extending into the short saphenous vein. This is his discharge diagnosis of a submassive pulmonary embolism and recurrent deep vein thrombosis. They had done the CTPA to confirm the diagnosis, which had revealed nearly completely occluding thrombus, involving the lower distal aspect of the right and left branch of the pulmonary arteries. So it was a bilateral thromboembolism. And the patient was treated with TPA, alteplase, and he did well, and he was discharged in a relatively stable condition after a few days. And he was advised to take Eliquis for indefinite period till it was stopped by the doctor. Now, this case was a case of pulmonary embolism. I am going to another spectrum of right ventricular pathologies, where this was a 24-year young girl. She came to a friend of mine with acute dyspnea and was referred to me for doing the echocardiography. Unfortunately, the video slides of this subject has been, is not running, so I have to do with the still images only. This is a parasternal long axis view. This is a parasternal long axis. Now I'll go to the second case, which is another spectrum of right heart pathology. This was a young girl, 24-year-old, acutely dyspneic, had a fever, had come to a friend of mine for evaluation, who subsequently referred her to me for doing the echocardiography. Unfortunately, in this case, the video files are not running, so I have to do with the still images only, which is a gross compromise, but I hope you will accept it. The parasternal short long axis view shows a greatly dilated right ventricle. The right ventricular hypertrophy is not well appreciated in this view. The M mode, again like in the previous case of the aortic valve, shows partial closure of the valve towards the later part of systole, suggesting compromised left ventricular function. The M mode at the chordae level shows a obviously dilated right ventricle with some suspicion of a right ventricular free wall hypertrophy. The short axis view shows a D-shaped left ventricle, suggesting gross overload, and this was a volume and pressure overload both of the right ventricle. The pulmonary artery appears dilated, though it doesn't satisfy the criteria, but a young girl, 24-year-old, thin and lean, 24 millimeter of diameter of pulmonary artery, I would call it a dilated pulmonary artery. This is the 4-chamber RV focus view, which again shows a grossly dilated right ventricle and right atrium, and kind of compressed left heart. The M mode at the pulmonary valve shows short pulmonary acceleration time, suggesting pulmonary hypertension. The right ventricular systolic function was compromised with TAPSE of 11 millimeters. And one more shot of the RV focused 4-chamber view. The patient has a florid TR with a TR gradient of TR velocity, a maximum velocity of 5.04 meters per second, corresponding to a maximum PG of 101 millimeter mercury, and the mean PG came out to be 57. So she has a severe pulmonary hypertension. The inferior vena cava is again dilated and with very poor collapse with respiration. So since I have little time in hand, I would like to appraise the audience of the new guidelines of pulmonary hypertension which came out in March this year. Some special points for the young people or the new echocardiographers in this hall. This is not meant for the people who are sitting on the front row. We calculate pulmonary artery pressure from the peak TR velocity, as you all know. But the jet is characterized by a dense envelope. This is what we should take when we do the TR velocity. The peak TR velocity suggestive of pulmonary hypertension in the new guidelines is if it is above 2.9 meters per second, corresponding to RA-RV gradient of 34, or if the peak TR velocity is above 2.8 meters per second, with at least 2 of the following echocardiographic indirect signs like RV enlargement, any 2 of these, RV enlargement, abnormal left ventricular eccentricity index, mid-systolic notching of the RV signal, mid-diastolic PR velocity exceeding 2.2, and signs of elevated RAP. This is the reason why the TR velocity is often we misread, because we have to measure the height of the TR velocity properly. We have to rather measure the beard, not the chin. The main cause of overestimating TR velocity is rich imagination, as it's shown in the left slide, or an overgain signal, both of which kind of give an excessive TR gradient. Common sources of AR become TR assessment is insufficient TR signal, where it can be either in underestimation as well as overestimation, or if the angle is over 40 degrees, it should be as parallel to the TR jet as possible. If it exceeds 40 degrees, it leads to 20 degrees, it leads to underestimation. And other common source is abnormal triangular TR jet, which is a severe TR, and this can lead to underestimation as well. Pulmonary artery end diastolic pressure is measured from the PR end diastolic velocity, as you all know. and the mean velocity is measured from the ideal way of measuring the mean velocity is if you can get the TR signal properly, as we measure the mean systolic blood pressure, 1/3 of the systolic pressure plus 2/3 of the diastolic pressure gives the. And now, according to the guidelines, the diagnosis of pH has changed, the definition has changed. It has been brought down to MAP about 20 millimeters of mercury from the 25 millimeters of mercury which was earlier there. And the mean TR velocity, mean pulmonary artery pressure can be calculated by many of these formulae, but these are all indirect signs, so always not very reliable. And one thing we must start doing regularly is measuring the pulmonary vascular resistance by this Abbas's formula, which is very simple. PVR is peak TR velocity divided by VTI of the RVOT. The American Society now recommends that VTI of the RVOT should be measured in every single case and reported. And the PVR and the pulmonary vascular resistance, if it exceeds 2 Wood units, it's considered abnormal. Why it is important? Along with it, we have to measure the pulmonary capillary wedge pressure, which is an indirect, which is equivalent to the left ventricular end-diastolic pressure by the Nigui formula. And this is required to classify the pulmonary hypertension into pre-capillary, isolated post-capillary, or combined pre- and post-capillary. These are all there in this guideline paper, which is available in the AAC website, which I would recommend all of our young colleagues to download and go through and keep it handy with them when they do this. Thank you very much for your kind attention.
I believe towards the end of the sessions, everybody will forget the question they are going to ask.
He's a 57-year-old man.
So
he was referred to our
we'll
eco
let it be
department with a history of shortness of breath for a period of 1.5 months. He doesn't give any history of hypertension or diabetes, but he's a known smoker. So with this background and with this complaint, I start doing this echo of this patient. I started doing this echo, and the first view that we took was the parasternal long axis view. Here, I'm going to show you the parasternal long axis, the parasternal short axis, at the level of the mitral valve, at the level of the papillary muscle, at the apical level. And after looking at this parasternal and short axis and long axis view, we can understand that this patient has reduced systolic function. His cavity is dilated, and now we are going to do an assessment for the dimension of the LV cavity and also the function of the LV cavity. So first we will try to see this patient in M mode. However, we will not do a Tycho's method of measurement. We will only measure the LV end diastolic and the end systolic dimension in the M mode, and here you can see that the end diastolic dimension is 63 and the end systolic dimension is 58, which means that this patient has LV dilatation and LV and global hypokinesia of the LV. So after this, we will have to assess the ejection fraction of this patient, and for assessing the ejection fraction, we will do the biplane modified Simpson method, which is recommended for assessing patients' ejection fraction. So here you can see that I have taken an apical 4-chamber view and also an apical 2-chamber view, and here the ejection fraction by this method has come to be at 26%. The EDV and the ESV of this patient is measured at 121 millimeter and 90 millimeter, and if we divide it with the BSA, it will give us the actual indexed volume of this patient. But we have a clear idea that this patient has dilatation of LV cavity with reduced systolic function. And here, when we were assessing this patient, we can easily see that there is no regional wall motion abnormality. There is a global systolic dysfunction. We have examined this patient in parasternal long axis, parasternal short axis, apical fourth chamber, apical long axis, and apical two chamber views. And in all these views, we could ascertain that this patient has no regional wall motion abnormality. After doing the LV ejection fraction calculation by Biplane-Simpson method, we will now examine this patient's global longitudinal strain. Here again, we will strain is calculated in all these three views, the apical long axis, the apical fourth chamber, and the apical two chamber views. And here one has to keep in mind that the proper delineation of the myocardium is very important. Otherwise, this image, the spectral tracking that gives us the global longitudinal strain might become erroneous. But however, in this patient, we could see that the bullseye has given us this kind of a picture which shows that LV has a very reduced strain with a global strain of -5%, and apical long axis shows -4.2%, fourth chamber shows 6%, and the two chamber shows only a strain of -4.9%. So to summarize the LV systolic function, we can say that this patient has dilated cavity with increased end diastolic, end systolic volumes, and global systolic dysfunction with reduced systolic function and global reduced longitudinal strain. So after assessing the LV systolic function, we will now go on to assess the diastolic function of LV. Here, the diastolic function of LV is assessed from the fourth chamber view. In the mitral inflow, we will keep the PW Doppler, and you can see that this flow pattern, the mitral inflow pattern, which shows increased E velocity, decreased A velocity, increase in E/A ratio with a sharp deceleration time of 100 milliseconds, which shows us that this is a grade 3 diastolic filling pattern. We then go on to do the tissue Doppler imaging, where the cursor is placed at the mitral valve medial annulus, and here the septal velocity has come to 0.03 meter per second, and also at the lateral annulus, which is 0.04, and the average is something around 22, which shows that this patient has grade 3 diastolic dysfunction with reduced tissue Doppler velocities in both mitral annulus. Then to further to further assess the diastolic function, we did the pulmonary venous Doppler. Here you can see that there is a reversal of the systolic and the diastolic flow pattern. Normally the systole is more than the diastole, but here the systole is much decreased, systolic velocity is much decreased than the diastolic velocity. And at the end we did also the IVRT, which we did by using the tissue Doppler and keeping the tissue Doppler in the mitral lateral annulus, which IVRT is in this patient is 62.8 millisecond, which is also reduced. So to summarize, this patient has both systolic and diastolic dysfunction with dilated cavity. So after assessing the LV systolic and diastolic function, we'll now assess the RV. So here you can see this is a typical RV view I have taken, where the RV free wall is properly visualized. You can see the opening of and closing of the tricuspid valve. And to assess the RV, we will have to do the take different measurements to see the RV systolic function. The first, the TAPSE, the RV strain, and also RV FSE, and also we will do the RVS1 to see the RV function. So to assess, first to assess, we will do this RV strain imaging, whereby we will get all the required data that we need. Here you can see the RV strain, global strain has come to -10.5%, with the free wall strain of -15.1% and TAPSE of 15, which shows that although the basal portion of the RV shows good strain, the mid and the apical portion and the free wall shows reduced strain, which means that this patient has reduced RV function as well. And here we have also checked this TAPSE by putting the separately, and we can also demonstrate the TAPSE by putting the cursor on the tricuspid lateral annulus, and then measure the TAPSE. And here we have also done the RVS1, which has come to 0.08 meter per second, the normal value being more than 0.09 meter per second. So to summarize, that this patient also, along with LV systolic dysfunction, diastolic dysfunction, the patient also has RV systolic dysfunction with reduced RV function in the form of reduced TAPSE, reduced global strain, and reduced RVS1 velocity. We also did the RV FSE, which came to be about, we did the RV FSE, I'm just going to show you that. For doing the RV FSE, we have to take the RV endocardial border. We will have to line the RV endocardial border in diastole and also in the systole. And then this machine, our machine has this auto EF package which gives us a RV FSE of 21.6%. The normal RV ejection FSE value is more than 35%, and this patient has 21%, which again shows that he has reduced RV function. So initially we have measured the left atrium from the parasternal long axis view, which was about 4.2 to 4.3 centimeters, and now we are going to measure the left atrial strain. And left atrial strain is measured in our machine, and it's auto-generated. So here we can see the biplane has given us this strain. The contractile strain is -1%. The LA reservoir strain is 4%, which clearly shows that this patient has reduced left atrial strain. Now I'm going to show you some valvular regurgitation. This patient has mild MR, and also he has mild TR. We calculated the tricuspid valve TR velocity. The TR was about 40, and so the IVC of this patient was collapsing normally, and it was 1.8 centimeters. So the PA pressure was around 46. So to summarize, this patient that I just concluded studying has dilated cardiomyopathy with increased LV and diastolic and systolic volume, with reduced LV systolic function, grade 3 diastolic dysfunction. He also has RV dysfunction with mild pulmonary arterial hypertension, and also his left atrial strain is grossly reduced. So at this moment we can say that the patient's systemic venous congestion is reduced, but he definitely has features of pulmonary venous congestion. So I'm going to quickly show you another case of dilated cardiomyopathy of different etiology. So this is a patient who just underwent a PTCA to LED, and you can clearly see from this parasternal long axis view that the septum is thin and kinetic. Here is the apical fourth chamber view, and here is the parasternal short axis view. I'm going to quickly show you the views of this patient. So you can clearly see that the apical segment is almost akinetic, and the RV looks normal. The LA is borderline enlarged, and we did the same way. We assessed the function and the global strain of this patient, again from the apical fourth chamber, apical two chamber, and apical long axis views. And here is the global strain. This is how it looks for this patient. This patient also had a reduced strain of -8.7%. And then I did assess the LV function from the apical fourth chamber view and also from the apical two chamber view, where you can see by this biplane method where the ejection fraction has come something to be around 34%. So this patient also has systolic dysfunction but has regional wall motion abnormality. Both are dilated cardiomyopathies, but one is of ischemic etiology and other is idiopathic. And here this patient, you can definitely, if you compare the those images, this patient has thin and akinetic anteroseptal apex, wall and apex. And now looking at the diastolic function of this patient, my last patient of DCM had a grade 3 diastolic dysfunction, whereas this patient has a grade 1 diastolic dysfunction. Here we can see The E velocity is less than the A velocity. E by A ratio is 0.53 with a normal deceleration time of 200. The E by E prime ratio of this patient and septal annulus, septal and the medial annulus was, and lateral annulus was almost within normal limits, and it was 8.2, and the IVRT was 112. So to say that this patient, although this is also a patient of dilated cardiomyopathy, he has a grade 1 diastolic dysfunction, whereas the last patient had a grade 3 diastolic dysfunction. Both has systolic dysfunction. One has regional wall motion abnormality and the other doesn't. To summarize, I have showed you two patients, one of dilated cardiomyopathy of idiopathic origin, another of ischemic origin, one with regional wall motion and one without regional wall motion abnormality.
Today I'm going to demonstrate a case of infective endocarditis of the mitral valve on this patient. He is a 61-year-old male patient with history of fever with easy fatigability for 1 month, and he has a positive blood culture for Streptococcus sanguinis, and he has come to our lab for echocardiography. Now, echocardiography plays a key role in the diagnosis and management of infective endocarditis. In the plaques view, we can see very clearly that there are echogenic masses attached to the both mitral leaflets, both the anterior and the posterior mitral leaflets. The one attached to the posterior mitral leaflet is larger than the one which is attached to the anterior mitral leaflet. And most importantly, the points in favor of vegetations is that the masses are attached to the atrial aspect of the mitral valve, that is mitral valve leaflets, the LA aspect of mitral valve leaflets. And the masses are very freely mobile, oscillating, and they are entering into LA in systole and prolapsing into LV in diastole. And this is, these are the features of the vegetations of mitral valve. And as we can see that these large mobile masses are resulting in a coaptation failure of the mitral leaflets, and as a result, there is significant, in fact, quite severe mitral regurgitation, as we see in the color flow imaging over here. As we see, the left atrial diameter is somewhat increased, is 4.58 centimeter, and that's, but then a point to note that with this severe mitral regurgitation, we are having a left atrial diameter of 4.6, which is not hugely distended. So the mitral regurgitation is probably of recent onset, relatively recent onset. The size of the masses we can see, this is the larger mass, this is 1.1 centimeter by 0.7 centimeter, and the smaller one attached to the AML is 0.8 centimeter by 0.5 centimeter. This is a short axis view where we can see the mass, the larger one, just peeping out. These are the Dopplers as we proceed, the transpulmonic, and this is we have taken this, he's having no systolic dysfunction. The LV systolic function is 69% with the LV IDD of 5.6 centimeter. So it's just a high normal LV cavity. In the epilex view, this is another good view where we can see the mitral valve vegetation very clearly, as we can see the highly oscillating echogenic vegetation, which is entering into left atrium and then in systole and LV in diastole. The significant mitral regurgitation. This is the PW across the mitral valve, which E by A ratio of 1.9. The tissue Doppler is of course showing raised LA pressure, that's obvious, with the E by E prime of 221. The dense mitral regurgitation jet. This is a transaortic flow. The tricuspid regurgitation shows significant pulmonary hypertension. The TR gradient is 60. And as we proceed, you can see the mitral regurgitation in the apical fourth chamber view also. and with IVC collapsibility of more than 50%. So he's having a infective endocarditis of the mitral valve with severe mitral regurgitation and the pulmonary hypertension with a PASP of around 65. Now, the point to note is that, as we have seen in this case, that why this mitral regurgitation is occurring. In fact, this is occurring because the masses are coming in the line of coaptation of the valve leaflets. And there are two mechanisms actually of mitral regurgitation in this setting of infective endocarditis of mitral valve, and that is either the leaflet perforation or coaptation failure of the leaflets. And these usually occur when the vegetations are attached near the middle of the leaflet or towards the apical part of the leaflet. But regurgitation in mitral valve endocarditis can be absent when the vegetation is placed more basally towards the base of the leaflets, so it doesn't interfere with the coaptation of the mitral valve leaflets. And as a result, these cases, are very difficult to discern clinically because there is no significant murmur. So they are usually detected by chance in the echo lab when there is when the vegetation is situated more basally. I'll just take this opportunity to show you a few similar cases. This is a case of a 39-year-old gentleman presenting with a history of fever for more than 3 months with increasing severity of shortness of breath on exertion. And here we can see that the the aortic valve is thickened with a mass attached to the aortic valve, which is prolapsing into the LVOT in the diastole, and we can see the thickened aortic valve. And here we can appreciate the mass which is attached to the aortic valve and which is entering into the LVOT in diastole. And this is again because vegetations are usually attached to the upstream side of the valve. That is, in case of atrioventricular valves, it's on the atrial aspect, and in case of semilunar valves, it's on the ventricular aspect. So here again, this is a thickened valve which has severe with severe aortic regurgitation, and here we are seeing that LV cavity is dilated. Actually, it was a previously diseased valve, and with superadded infection of infective endocarditis. So this again gives a good view where we can see in the apical 5-chamber view, we can appreciate the vegetation attached to the aortic valve, which is entering into the LVOT in diastole. And this is a severe AR with a p half time of 221 milliseconds. I'll show another case, just a clip of it. This is a case of tricuspid valve vegetation. As we can see, as I told before, that this vegetation is attached to the tricuspid leaflet on the atrial aspect of it. And this is a filamentous vegetation. This is in a case of a 22-year-old male patient with history of IV drug abuse. And similar, this is the same patient. This is a tricuspid valve vegetation in a CKD patient where we can see a thickened, not so mobile mass attached to the atrial aspect of the anterior tricuspid leaflet, giving rise to significant tricuspid regurgitation. And as now the intracardiac devices are very common nowadays, like pacemaker, so infection of pacemaker lids are also quite common. So this is again a case where we can see that a mobile echogenic mass which is oscillating and is attached to the pacemaker lid, and it's is attached to the pacemaker lid, and this is a case of this pacemaker lid vegetation. This has given rise to severe tricuspid regurgitation. So with that, I conclude the presentation of this case, and to briefly summarize what we essentially see in a case of infective endocarditis when a patient is referred to us for echocardiography. The most important point of infective endocarditis is, of course, the demonstration of valvular vegetation, And the vegetation is of course attached to the upstrip side of the valve, that is mostly to the atrial aspect of the atrioventricular valves and the ventricular aspect of the semilunar valves. That's the most important point. Of course, there are atypical presentations where we may get the vegetations on the other side, but those are rare, and we can also get some non-mobile vegetations, sessile vegetations, but these are rare instances. So finally, I conclude this session by re-emphasizing the importance of echocardiography in the diagnosis and management, follow-up management of infective endocarditis. So the main purpose of echocardiography in infective endocarditis is to identify the vegetations, define valvular destruction, and characterize invasive complications if present, like abscess or pseudoaneurysm. So there is a modified Duke criteria of 2023, which lists the following echocardiographic findings as major criteria for establishing the diagnosis of infective endocarditis, which are vegetation, of course, the most important, then intracardiac or paravalvular abscess, valvular or leaflet perforation, valvular or leaflet aneurysm, pseudoaneurysm, or intracardiac fistula. And then there, in case of prosthetic valve, one should look for whether there is any dehiscence of prosthetic valve, or in case of valvular regurgitation, whether the regurgitation is new or there is an aggravation of the regurgitation. While doing the echocardiography of a case of infective endocarditis, one must remember a few possibilities of the conditions which can mimic infective endocarditis. And these are papillary fibroelastoma. Then there can be a myxomatous mitral valve disease with a redundant valve leaflet, which is again, which may prolapse into the left atrium and mimicking a vegetation. Then there can be a non-bacterial thrombotic endocarditis. These are mainly of two varieties, where we get Liebman-Sachs endocarditis in the SLE patients, and in advanced malignancies we may get Marantic endocarditis. And then again, of course, with prosthetic heart valves, one can have thrombus, which may be mistaken for vegetation. And then, of course, there can be a beam width artifact, or again, there can be some normal valve variants such as Lambel excrescences or calcified nodule of Arantius. So these are the possibilities one should keep in mind while doing the echocardiography for a patient for infective endocarditis. One must remember few possibilities of conditions which may mimic infective endocarditis. So these are the conditions which can come in the differential diagnosis and the echo lab, and which are papillary fibroelastoma. Then there can be myxomatous mitral valve disease, which in which the valve leaflet is redundant and it's prolapsing into the left atrium and systole. And then there can be non-bacterial thrombotic endocarditis, like Liebman-Sachs endocarditis seen in SLE patients, and Marantic endocarditis seen in advanced malignancy patients. And there can be, of course, thrombus associated with prosthetic heart valves, which are very difficult to distinguish from vegetations. There can be beam width artifacts, and in certain cases, normal variants like Lambel excrescences or calcified nodules of Arantius can be mistaken for a vegetation. So these are the possibilities which one must keep in mind while giving the diagnosis of vegetation in case of infective endocarditis.
A recently concluded study of a 73-year-old gentleman who is a diabetic for last 2 decades. He presented in 2019 with breathlessness on exertion, which had progressively increased and had gone to NYHA class 3. On investigation, I'll be speaking about the relevant ones, of course. The echocardiogram showed a bicuspid aortic valve with severe aortic stenosis. Eventually, he was operated on and he received a bioprosthetic valve. Right now, he has come for a routine examination So this bioprosthetic valve dates to last 6 years. I'll be now starting with this is the parasternal long axis view showing the bioprosthetic valve in the aortic position. It is a stented valve and a glimpse of the stents can be seen. This is the color Doppler study where we can see a wisp of aortic regurgitation which is transvalvular. The aortic sinuses, STJ and the ascending aorta are of normal dimension. This patient has a very prominent mitral annular calcification with a blob of calcium on the PML. The LV function is fine. Wisp of TR with no significant pulmonary artery hypertension. These are the relevant findings that have to be assessed with a prosthetic valve. This is the Sachs view, aortic Sachs view of the valve. Again, we can see the prosthetic valve, again a glimpse of the stents, and the valve doesn't seem to have any mass in its vicinity as well in the sewing ring. The color study. This is the assessment of both the mitral flow and the aortic flow. Trivial mitral regurgitation with a lamellar flow through the mitral valve with no obstruction. Similarly, in the aortic valve. This is the mitral inflow with an increased E by E prime depicting, and we did have an enlarged LA, so this patient has evidence of increased LA pressure. This is the aortic valve, a zoom view. This is the Doppler study of the aortic valve, where we have the peak and the mean gradient being 15 and 9. So this is seems to be a normally functioning valve as shown by the gradients. The acceleration time is 97, which again is within a normal range. And after assessing the LVOT, tracing the LVOT PW Doppler, we got a DVI of 0.63, which implies that there is no obvious obstruction in the valve. This is the LV assessment, which is very important in these cases because a remnant LV dysfunction could persist even after the valve is replaced or could eventually occur. Incidentally, coronary angio was done at the same time and the patient did have a normal coronaries. We did a GLS, which is the average value is minus 13.1. So this was a patient who had a bioprosthetic valve which is functioning normally. So this is a patient who needs to be followed up regularly just to assess any further aging process in the valve. In addition, the mitral valve needs to be followed up because there is an associated mitral valve lesion too in this patient. A 65-year-old gentleman, his present admission was because of advanced AV block and syncope, for which he received a pacemaker implantation. But his history actually dates back to beyond 2017. In 2017, he presented with again increasing dyspnea, and that when evaluated was a mixed valvular disease, mitral valve disease, which required a mitral valve replacement. He received a mechanical prosthetic valve. In addition, at that very time, he had a aortic valve involvement, which on the table was assessed not to be intervened at that point of time. His coronaries were evaluated then and subsequently in 2023, which turned out to be normal. This patient has been followed up, and over time, this patient has developed a decreasing LV or an increasingly impaired LV systolic dysfunction, and although his symptoms are not very profound. What really needs to be said at this juncture is that we all should go through the reports that are available to us, especially the post-operative gradients of all prosthetic valves, if they are available, so that we can compare them over time. This really helps, although most of the time we do not get these reports, but an attempt should be made to get them. And similarly, all the valve particulars should be available. That is an essential part of the evaluation of the patient. Comparison with the previous reports is an essential part. So I'll be proceeding with, again, a recently concluded study of this gentleman. The synopsis, as I said before, this is the parasternal long axis view, which shows a poorly functioning left ventricle with aortic valve involvement. You can see sclerosis or calcium deposits in the aortic valve and a restricted motion of the aortic valve. In addition, we have a mechanical prosthesis in the mitral position. The essential part is that we get a lot of reverberations during the assessment of a mechanical prosthesis. This not only impedes in the assessment of the valve, but in particular if there is a regurgitation, be it the aortic valve or be it the mitral valve. So at times, as I'll be proceeding with the study, you have to keep changing and sweeping through the axis in order to get a view, especially when you assess mitral regurgitation. This is the view. If you see, in all compared to the other views, I have taken not a very absolutely conservative view, but a view which gave a good idea about the mitral regurgitation. The mitral regurgitation here is a lamellar flow and is transvalvular, central and transvalvular with no obvious paravalvular leak noted. Again, a repeat of the same with a tilt in the axis. You can see the leaflets clearly, and because you can even fiddle with the gain in order to decrease the shadows. This is the 4-chamber view. We have to see the valve in all available views possible in order to assess whether the leaflets are moving adequately, whether we have any mass in its vicinity, and then put color in each and every view so that we can assess any kind of paravalvular or transvalvular significant regurgitation. This is the short axis view. The LV systolic function is impaired. We'll be quantifying it later. This is the tricuspid regurgitation. The gradient is not significant. So we have this patient who doesn't have significant pulmonary artery hypertension. The RV function is fine, assessed by TAPSE. Now, as I had mentioned earlier, this patient had aortic valve involvement at that point that the surgery was done. over time, the aortic valve calcification has increased and the aortic regurgitation has also increased, although when we quantify, there is no significant stenosis in this CW Doppler study, but and the aortic regurgitation is, the ARPHT is 444 and the vena contracta is again 3 millimeters. But what I need to say here is that we have a patient who has a proximal prosthesis. All prosthetic valves are considered to be stenotic. So this, in addition to an impaired LV systolic function, can actually, any regurgitant lesion could be underestimated because of these two features. So a patient who has been developing a progressive LV dysfunction with a normal coronaries has to be assessed for a severe regurgitant lesion, whether we are missing out on it because of the other criteria is a very important finding in this patient. Similarly, what is very important in the assessment of mitral valve prosthesis is basically the rhythm. Here it is a pace rhythm and we have a specific rate of 60, but the diastolic phase is very important because that is the phase of the mitral flow. So if we have tachycardia, the assessment again could be a problem. To assess the left atrium, which is enlarged, here we can see the leaflets moving. This is a very beautiful view with obviously significant shadowing, but you can see the leaflets moving. So the functioning of the valve as per 2D echocardiography seems to be adequate. Now we have assessed it with Doppler, and as it corroborates with our 2D findings, the mean PG here is 5.64, which is again, although this is a very, very normal mean gradient, but it is a good habit or a helpful habit to compare it with the preceding studies as well as the post-operative study. You can see the leaflets with no obvious mass. We have a lot of artifacts. You can never be sure, as it is a transthoracic echocardiography. That is the reason that transesophageal echocardiography, when there is a point of suspicion, is really indicated. This is the LV-GLS, which obviously is very reduced, it's minus 5.9, and the ejection fraction according to the Simpson method is, biplane method is 33%. So you can imagine such a low ejection fraction in addition to a proximal stenotic prosthetic valve, it could have its own implications in the assessment of aortic regurgitation. So in total, this is a mechanical prosthetic valve in a patient who's recently received a pacemaker implantation. So we have a fixed rate, fortunately, in this patient, which is which has aided in our assessment, because this patient did have atrial fibrillation with a fast ventricular rate. Right now we have a rate which helped us in the assessment of the valve. This patient in addition has a poor LV systolic function, which could be explained by a progressive change in the aortic valve and an aortic regurgitation, which could be just severe, and this patient now needs to be assessed whether an intervention as far as the aortic valve is concerned would solve the problem of his deteriorating LV function. Today we've dealt with prosthetic valves, both in aortic position and in mitral position, one bioprosthetic, the other one metallic or mechanical valve. At the risk of repeating myself, I would again insist on asking all your patients to get all their reports so that we can compare it from the post-operative period on to the last study. Because as the valve ages, an early detection of the aging, of significant aging process really helps in intervening or medically or surgically eventually at the earliest time before we have catastrophic events. So, in addition, we need to assess the concomitant findings like LV function and other valves, because we may have a very good functioning prosthetic valve in whatever position we've implanted it in, but the patient may be symptomatic or the patient may have deteriorating hemodynamic features. In these patients, it could be another valve that is involved, as I have shown you, the aortic valve in this case. So, in each and every study, in addition to the prosthetic valve, we need to assess all the other valves. That completes the study and helps in treating our patients.
Hello and welcome to WBAE. So we will deal with a case today. And this patient was a 28-year-old male patient, but he was referred to us from the pulmonary department. This patient had a history of pneumonia in 4 months back, and the patient was having a progressive shortness of breath. They have done all possible investigations from the pulmonary side, and they are convinced that it was not a pulmonary case. And when the patient came to our OPD, this was my patient's neck vein. It was a pounding neck vein with engorged neck veins. And they have given us an X-ray, and this X-ray will clearly show us that this patient doesn't seem to have a very exaggerated pulmonary hypertension. Neither the patient has a cardiomegaly, which will show that this patient has pericardial effusion. So we have something else with this patient which has caused this neck veins, and we went straight away for the echo. And this was the first echo. You can see that the LA was dilated, the LV was not that dilated, it was rather chinked, and there was an unusual bouncy movement in the IVS which we saw. And this type of movement we also find in case of bundle branch blocks patterns. So we wanted to clarify whether we are dealing with something else or not. There was not much mitral regurgitation or not much aortic regurgitation or aortic stenosis in this patient. And if we see this view and we can see this M mode, we will see that the LA is just a bit dilated and nothing significant. When we were doing the ejection fraction by the TCOS method, we saw that the ejection fraction was 65 millimeter of mercury, but the typical bounce was seen here in the IVS in the diastolic phase. And in the early part of the diastole, if we compare this with the ECG, we can see, and of course, your eye impression will also tell you. So, this was the plaques view, and you can see that the diastolic bounce, the bouncing movement in the IVS, which was very classical. And if we have taken this movement along with the mitral valvular opening to show you that the bounce was classically in the early part of the diastole. So it was a diastolic bounce that this patient was having, and the RVOT was dilated, but side by side you can see that the pulmonary artery, they are not at all dilated, and here also if you see in this is a right ventricular type of a view in which there is a flattening of the IVS, so that showing that there is right ventricular overload pattern, and the typical bounce, diastolic bounce of the IVS is also very classical. This is the pulmonary artery to show you that there was no significant pulmonary regurgitation, and both the pulmonary branching are also very okay. And this is a very classical finding in the fourth chamber view, in which you can see that during the diastole there is a fluttering movement in the IVS, which is very classical. See, what is happening is during diastole, when the LV is trying to expand, after a stretch it cannot expand, and that it cannot expand, it starts fluttering like that, which is very classical, a finding in case of a constrictive pericarditis. So we have done a LA volume and RA volume, both are significantly raised, and this we have done an LA volume index, which shows 58, which is significantly on the higher side, more than 45. We look at the pulmonary color flow, it's more or less, it's the mitral color flow, it's almost normal. The mitral PW shows an E more than A, which is almost normal looking. And if you see this view in which the mitral excursion of the medial annulus is slightly more than the excursion of the lateral annulus. See, and I have taken both in the same frame. The left side is the lateral and the right side is the medial, and the lateral annulus excursion is less, which is annulus reversus, which is very classical of this constrictive pericarditis. Once we are heading towards the diagnosis of constrictive pericarditis, I tried and looked at the pericardium by pericardial thickness from the subcostal view, and see the distance was 5.4 millimeter, which is clearly in excess of 2 millimeter, which is the upper limit of the pericardial thickness. The TR gradient was not much raised, it was just 14 millimeter of mercury. And see, when we saw the IVC was collapsing, but less than 50% normal, but the collapsibility was there. So we did a LV strain pattern, and we saw that the LV strain pattern was almost normal and almost similar. And when we did a bullseye, the bullseye also showed that there is no significant strain pattern, only there's a little bit of a higher strain in the anteroseptal and the inferolateral part. This was that we had got from the pulmonary department. They had given us a film of a chest CT, and I have kept this film just to show you that the thickening of the pericardium was very evident in this film as well. This is of course another view. This is not of the same patient. This is another of our patients. I wanted to keep this photograph because to show you a clear case of concretio cordis, that is a severe calcification of the pericardium. Interesting case with this patient was, then when this patient came to us, it was very difficult for us to find a definite window through which we can see the apical fourth chamber view. We tried it out from the apex, we tried it out from the subxiphoid area, but what we saw was we could not really find out a good window so that we could prove that this was a case of pericardial disease. We had taken the patient then for a cardiac MRI. What happened is, since this patient was having a heart rate of more than 120, this cardiac MRI people, they also didn't want to do a positive reporting on this patient. Our junior colleague, he took the patient for a chest X-ray, and the chest X-ray, when it came out, it was so classical, we could find out that this was the calcified part of the pericardium which was hindering our views. So this was an interesting case, very much in corroboration with a constrictive pericarditis. I show you this. This is again the second patient. This was a lady around 58 years old. She was treated for multiple myeloma. She was a hypertensive for quite a long time and she was on antihypertensive treatment. So when we saw the echo of these patients, the patient did really have a concentric LVA, did really have a dilated LA, but something that struck us, which we saw that even the mitral leaflet and the aortic leaflet, they also looked to us a bit thick. So we went on for the further examination. See, there is a chink of pericardial effusion, not amounting to cardiac tamponade. There you have a definite aortic regurgitations, the aortic jet plunging on the anterior mitral leaflet. And this was the contraction. There is no regional wall motion abnormality. The concentric hypertrophy is definitely evident. And there is a chink of pericardial effusion as well. This was the 4-chamber view. You can show the dilated LA and the dilated RA. And we have done the RV strain. The RV strain was minus 9.2 to minus 12, which was definitely less. Then we did an this was the typical small MR and the small TR. The AR was significant, which I told you. And in this decoy method, when we wanted to do the LV ejection fraction, what we found was the LV and the IVS and the posterior wall was significantly dilated. And the EF was 54, which was not that bad. But the TAPSE showed that it's a blunting TAPSE in which the TAPSE was only 17. And this was the IVC. The IVC was dilated and we measured the IVC to be more than 20. It's 23. The mitral pulse wave Doppler, they showed that the E and the A ratio is more than 2. And there is a significant restrictive feature in the mitral pulse wave Doppler. We did the annular excursion and the medial annulus and the lateral annulus. Both showed that the excursion was really blunted. And if you want to find out, you can find out, this is the 5 and the 5 mark. All the values were between 5, the E prime, the A prime and the S prime, all were between 0 to 5. And this was the classical 5, 5, 5. Here also it was less than 10. This is the 5 mark. It was around 5 in the lateral annulus also. This is the classical 5, 5, 5 type of restrictive cardiomyopathy disease. The aortic valve and the pulmonary valve and this tricuspid valve showed definitely gradient of 37, which showed that the patient had pulmonary hypertension. The RA was dilated significantly. The LA volume was 64, which was also significant. And see, the LA strain pattern also showed less than 7 was the average strain. We did a LV strain pattern, and the classical cherry on top appearance of the LV strain bullseye view was found, which showed that this patient, we were dealing with a patient of restrictive cardiomyopathy. So we tried to show 2 cases side by side to you, one being a case of constrictive pericarditis and one case being restrictive cardiomyopathy. In the restrictive cardiomyopathy, you see a concentric LVH type of a picture right in the word go with a dilated LA and RA. And in constrictive pericarditis, you always have a dilated LA and RA, but the movement of the LV is much better. And there is a classical diastolic bounce in the LV. If we do a strain pattern, you can see that there is a classical strain pattern of restrictive cardiomyopathy, but the strain pattern of constrictive pericarditis is always normal. And if you want to further assess your patient, you can try and measure the pericardial thickness in case of constrictive pericarditis. That will give you a better picture. I'm happy to take your questions. Thank you.
So again, greetings from West Bengal Academy of Echocardiography. I hope that you have enjoyed viewing all the live in-box case presentations from West Bengal Academy of Echocardiography. My heartfelt thanks to all my colleagues at West Bengal Academy of Echocardiography for their earnest cooperation and the effort that they have put in. And I hope that you have enjoyed it and you are going to find it useful. Thank you very much.
Dr. Anil, they will speak on constrictive physiology and seen in constrictive pericarditis and restrictive cardiomyopathy.
Anyway, the topics is giving the constrictive physiology. I'm not going to speak about any physiology here. Rather, I'll try to give, just a minute. What I am trying to give you, what the Dr. Paramatha has said this time, is almost will be repetition. But from the life in box, I want to get some life in the hall. Here, what he has showed, also an extension of this thing with you. Think simple, and you will earn the smile. Today's caption is like that. So this is a case, you can say that there is a 4 beautiful pictures in this area. What is common in this case number 1, 2, 3, and 4? The common in all these 4 things is biatrial enlargement. So what our master blaster, Dr. Nitin, who was initially in the beginning was used to tell that echocardiography, you should go like a story. So whenever you put the probe in the 4th chamber view, you get this type of picture, this certain things comes to your mind. What are the most important things in echocardiography often encountered in where there is a biatrial enlargement in the 4th chamber view? So let's go one by one. I'll start from the reverse way. The first is the case number 4. See, in the case number 4, there is a definite biatrial enlargement. But what is the cause of the biatrial enlargement? See, LV is contracting well, RV is contracting well, there is no thickening, but there is a biatrial enlargement. So here, always look at the one thing. Very simple thing is the ECG. If you look at the ECG, what is that? It is atrial fibrillation. So commonest thing we encounter in case where is the biatrial enlargement are the atrial fibrillation. So this is why everybody tells the ECG gating is very, very important while doing the echocardiography. Not only atrial fibrillation. Look at this. Here is again the biatrial enlargement. And look at the ECG. What is that? This is nothing but atrial flutter. So whether it is the atrial flutter or is the atrial fibrillation, you will get the biatrial enlargement. Now come to the case number 3. Again the similar case with the biatrial enlargement. Again the one common thing you will find what is there is, in this case there is of course some moderate MR is there, moderate tear is there, and moderate pulmonary arterial hypertension. But look at this, that's nothing but the permanent pacemaker leads us in. So this is a case of permanent pacemaker having biatrial enlargement. So these first exclude these 2 common causes. Of course, these 2 cases, atrial flutter or fibrillation or pacemaker, can be associated with the other pathologies. But at least recognize these 2 are there in case of biatrial enlargement. And now I'll go to the case number 2. Case number 2 is a almost similar case showing by Dr. Paramartha in the last live in box presentation. Is a biatrial enlargement. There was some thickening of the LV and good contractility, small pericardial effusion, and you can same almost the similar picture you can see, but in all the two chamber, and there is a mild mitral regurgitation. Of course, what you see is that E by E prime ratio is more than 3 or 4 even. So that means there is a LV filling pressure is very, very high, and probably this is a restrictive type of diastolic fibrin. So we are dealing with some restrictive physiology in this patient, could be restrictive cardiomyopathy. Again, in the apical long axis view, a 3-chamber view, we did the same the GLS in these 3 views, apical 3 chambers, apical 2 chambers, and apical 4-chamber view, and what we'll get, same thing is the apical sparing of the LVGLS. But not necessarily apical sparing of the LVGLS is also majority time associated with the restrictive cardiomyopathy, but it is not specific. It can happen even in the hypertrophic cardiomyopathy. It can happen in some other diseases also. And of course, among the hypertrophic restrictive cardiomyopathy, amyloidosis is one of the commonest cause. Here he measured the LA volume is 43.88 indexed LA volume. And this is the patient with the MRI of this patient. You can see there is a lot of hypertrophy. And not only hypertrophy, you will get the other features of LV MRI. And Nitin is there. Dr. Nitin, he can explain the better. I am not a master of the MRI. So you can see there the 3 pictures were very suggestive of amyloidosis with late gadolinium enhancement. So if you summarize the MRI finding, what you will get is the markedly increased wall thickness, asymmetry increase the LV wall thickness, most markedly upping the septal segment, more so in the basal and the mid cavity, moderately dilated left atrium, small pericardial effusion, and when we consider about the LG, there is abnormal coincident nulling of the blood pool and the myocardium, diffuse transmural late gadolinium enhancement of the LV, RV, and the right atrium, and rapid clearance of the GAD from the blood pool. Of course, there are some differential diagnoses will come, like apical ACM. Almost these the apical ACM just to compare is that how is the apical ACM is look like that. And this is that you can see the lot of hypertrophy in the apex, particularly in the apical part. And there is a significant hypertrophy of the apical myocardium with the late enhancement, good contraction of the both ventricle, and there is no focal well abnormality. Not only that, even the EMF patient is look like same thing, but there is a different scenario in the MRI. What you will see in the MRI, there is a truncated apex of the both RV and LV, and what we call is a double V sign if you have a clot in this, otherwise there is a V sign is there. And sorry. So to summarize the findings of the MRI in case of EMF is the ventricular apical obliteration, atrial enlargement, delayed GAD, normal myocardium, thickened enhanced endocardium, late gadolinium is a key imaging technique EMF, typically showing the double V sign if there is a thrombus in the LV apex. And now coming in the last one is the case 1. And what is the case 1 is that you can send again the biatrial enlargement. There is a paradoxical motion of the ventricular septum, and you can see the bulging of this. So here is the story of the last case, because this is a very important case where you can smile. This is a 14-year-old boy from Bangladesh presented with the reduced appetite, presented with the cough and cold, dyspnea exertion for the class 2-3, pulse 100 per minute, BP 90/60. He has edema fit, abdominal distension, JBP raised, ECG reported normal, echo. In Bangladesh, they reported LV systolic dysfunction, mild PH. Diagnosed as a case of cirrhosis of liver with ascites by USG abdomen at Bangladesh and referred to a hepatologist at Calcutta for further treatment. Here in the Calcutta, examined by hepatologist at Calcutta, advised repeat USG abdomen with relevant liver function test, reported features suggestive of Budd-Chiari syndrome. And so he had somehow sought for some way some cardiological consultation. And the cardiologist referred this case to me for a repeat echocardiography. And this is the ECG. ECG is nothing remarkable, I think so. And this is the first parasternal view. While I'm doing the echo, the parasternal view is coming okay. There is a paradoxical motion of the ventricular septum, and there is color flow is showing nothing abnormal. You can see the paradoxical motion in the M mode. And while doing the fourth chamber view, I could not obtain the fourth chamber view properly, because wherever is that LV is, I'm not getting the apex properly somehow. Somehow I have to manage these amount of fourth chamber views there. What I could see is that LV is not contracting very well, even the RV is not contracting well. Some dysfunction, systolic dysfunction is there, both these cases. Here is also a modified fourth chamber view, whatever, 5 chamber view, where you can, LV is not contracting so well. Then RV is also not contracting so well. And then Sodax's view is almost similar thing. And then, of course, the diastolic function is almost normal, but what I get is their annulus reversus. You can see the medial annulus, and this is the lateral annulus. There is definite annulus reversus is there. RV, there is a mild tear, nothing is that, and mild pulmonary arterial hypertension in the T1 maybe 35 or 40. TAPS is less. In a young boy of 14, TAPS is something like 13, 14, is definitely RV dysfunction is there. And of course, the S prime is also less, near about 6 or something like 7. Dilated, the inferior vena cava was dilated, and the hepatic veins too, and there is a reversal of flow in the hepatic veins, and that you can compare in this another view. While doing the GLS in this particular patient, what I saw is this, because of the paradoxical motion of the ventricular septum, there is some discrepancies there, but still the overall GLS was very low. There is 12.1. So that is the thing I got it in the echocardiograph. I diagnosed this case of probably a case of constrictive pericarditis echocardiographically. Then the patient was sent for CT. And in the CT, you can see the whole of the movie I've seen, and if you just run it, you can see the absolutely encasing the calcification, totally encased by the heart, totally encased. And another view is also, you can see there is a total encasing of the, you can see the total encasing. When you go a little slower, because this one, when you can appreciate the whole thing, because you can see the total encasing of the. Of course, the 3D reconstruction shows the very beautiful. You can see there is a total gross constrictive pericarditis. So they reported this case of a CT, definitely reported a case of constrictive pericarditis. Then, before doing something, somebody did the MRI. Okay, I am not. I told you there is not an expert of the MRI, but these are the findings of the MRI I can enumerate. Ultimately, this is the images. I could not get the cine MRI, but these are the images. And what the findings I'll say you a little bit is see. There is a non-dilated LV with LVF of 50%. That is confronting to my echocardiography. Non-dilated RV with RV of 45%. Again, there is some RV dysfunction in a 14-year-old boy. IVC hepatic veins are dilated. Biatrial dilatation with moderate to severe tear. I got the mild tear, but somehow they directed the moderate to severe tear. Circumferential pericardial thickening with calcification with mild diffusion. No features of myocardial inflammation or infiltration or infarction. No outpouching, mild pleural effusion, and CMR appearance are those of constrictive pericarditis. With this, again, what I am important is that, see, all the things in both the areas, both cardiologists and everybody, hepatologists, gastroenterologists in Bangladesh and India done everything except one investigation. And what the Paramatma is telling, this is the chest X-ray. See, put up then the chest X-ray, again you can see the circumferential calcification even in the chest X-ray. So that's why my caption in this day is, think simple, diagnosis will glare at you. Then this patient was subjected to the post-operative operation. And the operation was done very well. These are the operative findings. I do not want to enumerate because of the lack of time, but I can show you the post-operative chest X-ray. I think almost all calcification has been done except in the basal part a little bit. That is sometimes difficult to remove. But you can see the post-operative echocardiogram is a good SVC flow, and the RVC is very good, normal size, good collapsing, nothing else. And you can see the good collapsing. Hepatic vein flow is normal. There is a normal hepatic vein flow. That is for comparison I have given. And you can see the very beautiful contractility of the LV, and everything is there. And you can see the very beautiful contractility of the LV. And here is again the contractility is same, but still the atrium a little bit larger. Of course, the diastolic function are normal. Annular reverses which was present was absolutely normal with this patient. You can see the lateral was again bigger, medial was less. And of course, there is a mild tear I could get even after operation, and hardly any pulmonary artery hypertension. And RV function is also good. And see the average GLS is gone to 21 from 12 to 13 to absolutely normal 21.4. So here I should have concluded is there, but fourth slide I must mention is a very old slides. So there are 4 slides are there. This is a 35-year-old lady, history of pain abdomen for the last 6 months, mild pedal edema with some, these are the clinical findings. This is a distant heart sound, no murmur, chest X-ray was not available, ECG was low voltage, diffuse STT changes. So here I got this time a very old one, 2006. This one, this is from archive. I took it, and that time my Sonos 4500 machine was working, and you can see there's a heart is absolutely compressed by some cystic lesions in the liver, and you can see this is the 4th chamber view. You can see the large masses, and you can see there's lot of cystic lesions in the throughout the precordium and all over the heart. And this is a case of basically a hydrated cyst, and this patient was being operated, and this patient after operation, this is the post-operative, as you can see, the absolutely beautiful 4th chamber you can see, and this is the pericardial hydrosis. So I don't want to give in. Thank you very much.
As written in our book, The Bible of Medicine, Harrison, that if a patient presents with features of cirrhosis with a distended neck vein, then it can be, the differential diagnosis can be constrictive pericarditis. So his case amply proves that. We'll
So these are the features of the basically acute pericarditis. Sometimes in the constrictive pericarditis, you may not get any ECG changes, it may be normal. In acute pericarditis, you can get all sorts of changes, or in the subacute pericarditis, but chronic, of course, in the constrictive pericarditis, you may not get even the normal ECG. In many patients, you will get the normal ECG.
Here the involvement of myocardium is also there.
That's a very important question. I'll tell you, I'll address this question. This question is a very important question. Initially, while doing the GLS, I thought it was there. But after seeing the MRI, they have shown that clearly there is no myocardial involvement. Then I thought these could be due to the paradoxical motion of the ventricular septum because of the the blue one is coming. But overall GLS, what you were telling it was low. So there may be some myocardial involvement is what they are, but the majority of the patient, if you do the good operation, good decortication, then this myocardium may recover and the contractility is good in this patient.
Now, only thing that we should expect some ECT changes might be there in view
but
of
here is not there. You can know there are a lot of constrictive pericarditis. We have seen these normal ECGs.
So we are the last end.
Excuse me. Can I make a comment here, on this side, your right side, here?
Our side.
I know, I was just trying to mention
Oh,
something
sorry.
about ECG in constrictive pericarditis. I think a lot of people, yeah, you had asked that question, and a lot of people are young, they may not have read. Dr. Upender Kaul actually wrote a paper on constrictive pericarditis, the clinical and ECG findings, in Indian Heart Journal in 1980. So the gist of the ECG finding are more than 50% patients have ECG abnormality in constrictive pericarditis. Yeah. Commonest thing is incomplete right ventral branch block, followed by left atrial overload, low voltage graph, non-specific ST changes, and AF in 5% of the cases. Those 5-6 things are, I think, sufficient to be remembered. You have incomplete RBB in nearly 50%. You have left atrial overload, low voltage graph, and non-specific ST changes. I thought it was that was the time when we used to read ECG because we had nothing else to do. We didn't have echocardiogram. And this, we are talking about PGI Chandigarh. They did not have an echocardiogram in 1980. Paper was published in 1980, so I'm sure that it was written somewhere in 78, 79. And they didn't have it. So they could spend a lot more time on this thing. But they had done an angiogram of a lot of these patients, and they said the left ventricle looks like a fist.
Yeah.
Left ventricle looks like a fist. And that is a classic finding of left ventricle angiogram. When you were showing the cases with ellipticalization of the left ventricle,
Agreed, sir.
I was remembering Dr. Kaul's paper 45 years back.
But sir, there are certain percentage of cases in ECG may be absolutely normal.
Yeah, I think I said 50%.
Yeah.
Kaul's paper said
That's
50%.
agreed, sir.
ECG
Can constriction, hello? Can constriction be have a transient constriction is possible with modern therapy? Transient constriction.
Yeah, that can happen. There's no problem. But here is the patient. You can see that the amount of calcium and the amount of constriction in this in the city.
Constrictive pericarditis earlier.
Yeah.
And give anti-inflammatory agents and steroid.
Yeah.
The thing disappears. You don't need surgery.
Agree, sir. In fact, this patient was initially given some anti-tubercular drug somewhere for the 2 months. And then this patient was subjected to ultimately into confinement.
Dr. Devika Chatterjee is speaking about the defining a HCM phenotype.
Good evening, everybody. I am going to speak on HCM phenotypes. Defining HCM phenotypes with the lens of echocardiography. So we know it's a disease of genetic mutation where there is hypertrophy of the myocardial fibers, and myocardial fiber disarray and interstitial fibrosis are the histological hallmark of this disease. But before we go for a genetic study or microscopic study, the patients come to us and we do the clinical evaluation, which is followed by the cardiac imaging. And what we find that there is a highly variable phenotypic expression in HCM. The variability even exists within the family members of a single HCM family. And so let us see how do we define it. Now, in the literature, from time to time, this disease has been defined in various ways. It started in 1964, where originally it was described as 2 phenotypes, more common obstructive and less common non-obstructive. Non-obstructive. Subsequently, Meron in the year of 1981 gave a classification based on the distribution of the hypertrophy. Type 1, only the basal septal hypertrophy. Type 2, entire septum. Type 3, septal and the anterior wall both. And type 4 is apical. Then it was followed by addition of another variety by Lewis and Meron in 1991, where they defined another group with unusual posterior wall thickening. This is an unusual subgroup where there is a marked thickening and often asymmetric LV posterior wall hypertrophy, resulting in small LV cavity, narrow LVOT, anterior displacement of the mitral valve along with SAM, leading to LVOT obstruction. And this group of patients, they'll end up with severe early symptoms, refractory to medical therapy, and they require a surgical approach. Then in the year 1995, Weigel and his colleagues came with another classification, HCM with subaortic obstruction, midventricular obstruction, and cavity obliteration. Then Syed, in the year 2008, gave a classification based on the septal contour, location and extent of the hypertrophy. Reverse curvature, these are the models. Reverse curvature, this is the most common genotype we find in 80% of the patients with dynamic LVOT obstruction and mitral SAM, sigmoid septum, and neutral curvature, and then apical HCM, and also the mid-ventricular HCM, where there is a hypertrophy of the mid-ventricle with apical aneurysm and obstruction at the papillary muscle level. Then in the year 2011, Hemi came with another classification where he described 4 patterns and he correlated the distribution of the hypertrophy along with the clinical features. He described the 4 varieties. As you can see, the clinical features are in this arm. So what we learn? We learn that all HCM do not look same. There is a diverse phenotypic expression and a variable natural progression, clinical progression ranging from dyspnea to syncope to sudden cardiac death, and all these are because of heterogeneity in the thickness and distribution of the myocardial hypertrophy, abnormalities of the mitral valve, papillary muscle, and resulting in clinical and functional manifestation. So now let us go one by one. To start with, heterogeneity in the thickness of myocardium, where we look at the magnitude of the thickness of the myocardium. It is a strong predictor of arrhythmogenic sudden cardiac death. Now, all of us know that HCM is defined as the greatest wall thickness at any site of the LV, more than or equal to 1.5 or 1.3 in the patients with confirmed family history of HCM. We always measure at end diastole, perpendicular to the ventricular septum, either in plaques or P-Sax view, and we need to avoid oblique modified imaging planes. Now, while measuring the thickness, we must remember any absolute LV wall thickness is compatible with HCM spectrum. In one end of the spectrum, there might be a massive hypertrophy. Look at these pictures. The thickness is more than 3 centimeters, and that is a risk marker. This extreme phenotype occurs in 10% of the HCM, and we have to consider for ICD therapy in these cases. A massive hypertrophy, if you see. On the other end of the spectrum, there may be mild or just localized LVH with no LVOT obstruction, both at rest and with provocation. And these patients have a mild symptom which can be controlled with drugs. Now, a very unique phenotype has been recognized with increasing frequency, where there is a minimal LVH. If you look here at the picture, the hypertrophy is minimal, or even you may get normal thickness, but you get a dynamic LVOT obstruction where it is due to highly flexible elongated AML along with abnormal caudal connection, and they land up in progressive drug refractory heart failure. These group of patients should be considered as a part of the broad HCM clinical profile, and we need to look for family history of HCM, do the genetic study, or do the histopathological study. Another variety has been described, which we say subclinical HCM phenotype. They are the carriers of HCM gene, or the genetic study is either ambiguous or negative. They have the normal thickness. They do not fulfill the diagnostic criteria of HCM, but they have some characteristics of HCM in the form of elongated mitral valve leaflets, myocardial crypts. We often get some cases, myocardial apical trabeculation, densely tabiculated apex, and mildly dilated LA. We should monitor this group of patients with frequent echocardiography to see further progression. Now, after looking at the magnitude of the thickness, let us see look at the heterogeneity in distribution and pattern of hypertrophy, which might be focal or diffuse, asymmetric or concentric, which might be again obstructive or non-obstructive. So all of us know we get this type of cases where there is asymmetrical septal hypertrophy, or most common phenotype with or without LVOT obstruction, where septal to posterior wall thickness ratio should be more than or equal to 1.3 or and more than 1.5 in case of hypertensive patients. Look here, there is a see this reverse curvature, and look at the strain values. It is reduced in the basal mid septum, including the apex. The entire septum and the anterior wall are showing low strain values. Another variety of asymmetrical septal hypertrophy we get where there is a neutral curvature. They usually they don't usually have the LVOT obstruction. Sometimes they may have if it is a massive, and it looks like that. See, there is no reverse curvature. Another is sigmoid septum, asymmetrical septal hypertrophy with sigmoid septum. Now, here you see this is the shape if you see carefully. But while commenting it as hypertrophic cardiomyopathy, we must remember that normally also we get sigmoid septum in around 6% patients who are undergoing echocardiography, especially in the elderly group of patients. And another variety, as I said, hypertrophy of the septum and the anterolateral wall, which was described by Meron as the type 3. So it looks like you see concentric hypertrophy, but you can see there is no other cause of hypertrophy like aortic stenosis. He's not hypertensive, but he's not a patient of CKD, and I'm getting a concentric variety. Now, again, another variety, as you can see, there is a mid-ventricular hypertrophy at the papillary muscle level and leading to obstruction. And if you do the Doppler, you will see the obstruction at the mid-cavity level, at the papillary muscle level. Now, a very, very unusual phenotype in this type of cases, where there is a mid-ventricular hypertrophy, is having an apical aneurysm. It is seen in 1 to 2% of the HCM patients. They are at a very high risk of ventricular tachyarrhythmias, thromboembolic event, and sudden cardiac death. So these are the cases where you you have to go for ICD therapy or anticoagulation prophylaxis and anticoagulation prophylaxis. If you look, this is the aneurysm. But why there is an aneurysm? So let us look at the mechanism of formation of the apical aneurysm. The mid-cavity obstruction, it is dividing the LV into a proximal chamber and a distal chamber. Now, the persistent high diastolic pressure in the distal chamber results in reduced subendocardial perfusion, resulting in chronic ischemia, ultimately necrosis and aneurysm formation. Now remember, this apical aneurysm is frequently missed by echocardiography. We miss it in 57% of the cases. If you give contrast, then only it increases to 80%. So what we do, we please use the modified view or off-axis view. See here, I'm not seeing the aneurysm, but as I went towards the, I went down and out, and I could see the aneurysm. Now with CMR, it's always 100%. However, in echo, you may have some clue in the Doppler pattern, which indicate that there might be an apical aneurysm. Like you may get either of these two patterns. One is the mid-systolic void of the signal, and then you see E wave is there, and there is early diastolic paradoxical jet flow. Why is it is happening? If you see, during systole, the blood gets trapped in the distal chamber, and during early diastole, when the LV and LV pressure is low, the blood with high velocity moves towards the proximal chamber. So it is stopped, the flow is stopped in systole, mid-systole. Then in early diastole, there is a flow. Or you may see this pattern where there is a mid-systolic drop in velocity. This we call lobster abnormality. This doesn't spill over the diastole, early diastole. It remains mostly in the systole. Isolated apical HCM, equivalent to Hemi's pattern 4, a rare variant in non-Japanese population, occurring in 1 to 2%, where there is hypertrophy. Hypertrophy is confined only to the apex. You see, it is confined only to the apex, and it is very nicely seen in the bullseye. Only the apex is having low strain values. The rest of the LV is showing very good strain value with bright red color. Another variety of apical HCM has been defined, where there is, other than the apex, there is also hypertrophy of other LV segments. You see, and it is nicely seen in the bullseye. Along with the apex, the basal and the mid-septums are also involved. A very unique variety is a focal hypertrophy, and there is a sharp transition of myocardial thickness from the hypertrophy to the normal. So it looks like a tumor though, but it is a hypertrophic cardiomyopathy having the ECG changes. We get different phenotypes of mitral valve abnormality, where mitral valve may be normal, of course, elongated AML, elongated PML, or both AML and PML are elongated. So they extend beyond the, if they are elongated, they extend beyond the coaptation point in systole, and then moves towards the LV OT to contact the IVS, resulting in SAM. A spectrum of papillary muscle abnormalities also have been defined, where papillary muscle may be anteriorly placed, bifid, direct insertion of the papillary muscle to the mitral valve leaflet, or abnormal caudal tenting into the LVOT, resulting in SAM. So now let us look at the variability in the LVOT obstruction in HCM patients. You see, this is asymmetrical septal hypertrophy. Okay, you see there is a turbulent flow in the LVOT with the posteriorly directed jet of MR, and resulting in SAM also, and we get a gradient which is very high, around 60.
Please
now, almost 3/4 slides. So resting gradient is present only in 25 to 30%. And, but remember, around 70% of the patients have significant gradient, either at rest or provocation. So we can classify HCM depending on the obstruction and the pressure gradient also. Resting gradient more than 30 is one variety, and less than 30, but more than 30, less than 30 at rest, more than 30 with provocation, and no gradient, I mean less than 30 both at rest and provocation, and we see severe obstruction when it is more than 50 millimeter of mercury. Level of obstruction also varies. Alcohol septal ablation is an option for isolated LVOT obstruction, not in multi-level, and mavacamten is approved for LVOT obstruction. And when it is multi-level obstruction, there is no role of mavacamten or alcohol ablation. We have to go for medical management. So we conclude with this, that there is no single definition of HCM phenotype. Each type has to be defined separately with detailed morphologic and functional description to establish the diagnosis. So thank you.
Thank you, Dr. Chatterjee. So we are running late, almost 50 minutes, so we'll conclude the two sessions. We have in the last two sessions almost, we have 10 speakers and 10 different subjects, but there was one similarities. All the speakers are the most dedicated, sincere and most competent echocardiographer of the city. So we should give a big hand to all of them.
Thank you so much, chairpersons and all our speakers. We move on to the next session, focused sessions. I would like to invite our chairpersons on the dais, Dr. Soumitra Kumar, Dr. B.P. Pandey, Dr. Deepankar Dutta. Big round of applause for our chairpersons, everybody, please. Thank you.
Manish, you are the first batsman. So while slide is getting loaded, our first speaker is Dr. Manish Bansal from Delhi. He'll be talking about the role of echo in acute cardiac care, and time allotted is 20 minutes. Over to you, Manish.
Yeah, good afternoon, everyone. And first of all, I thank Dr. Soumitra Kumar and the organizing committee of Ezecho 2025 for the opportunity to participate in this meeting and speak on some important topics like this one. Now, echo, as we know, is one of the very important modalities in the evaluation of patients who present with some suspected or known acute cardiac illness. The reasons are many. Echo is the only imaging modality which can provide a comprehensive assessment of cardiac structure and function in one go at the patient's bedside. It's almost always feasible to do echo. There are virtually no contraindications. Very safe, non-invasive, no radiation exposure, no contrast requirement, and it can be repeated at will. And for these reasons, echo becomes very useful modality. And any situation in which we could be suspecting any cardiac disease, echo has a role. So whether it is hemodynamic compromise, respiratory distress, chest pain, unexplained fever where endocarditis is being suspected, arrhythmias, embolic complications, in all these settings, echo is needed. So echo helps in two ways, two different ways. One is that in most of the cases, it will show us the pathology directly. It will give us the diagnosis almost immediately. And second is that beyond this anatomic assessment, it also allows us to do hemodynamic assessment in many patients where hemodynamic abnormalities are the primary cause of presentation. So I'll show some examples to just illustrate this point because it's a very, very vast topic. So the first example is a 60-year-old gentleman, known case of hypertension and COPD. He presents with acute respiratory distress. He is admitted under pulmonologic care because of history of COPD and severe bronchospasm and breathing difficulty. His troponin is elevated, echo is done, and echo shows this. This is actually TE image which was performed subsequently, but the initial transthoracic echo done at the bedside had already shown the problem. So this patient had acute papillary muscle rupture leading to severe mitral regurgitation. He had myocardial infarction. So immediately the patient was transferred under cardiology care, IABP was inserted. After stabilization, angiogram was done, showed double vessel disease, and then he underwent CABG with mitral valve replacement. Another example, a 23-year-old lady, she was a known case of ulcerative colitis, was on azathioprine. She was admitted in the ICU with history of right hemipharesis and aphasia. CT brain was done, it showed left MC territory infarct. So she was thrombolized with TPA, improved, but again developed right-sided weakness and aphasia. CT brain was done again, it showed another infarct. CT angio showed partially occluded left MCA, inferior division. So now because this was a young lady, cardioembolic stroke was a strong possibility. Echo was done and echo showed a mobile pedunculated mass at LV apex. The LV contractility was normal, so it was not an old or recent acute myocardial infarction and then clot formation. It was a normal LV. We can see the same thing in other views also and with contrast also. So she underwent further evaluation. A lot of blood investigations were done, but most the key findings were that the TLC was high, ESR and CRP were high, calcitonin was elevated. So basically these investigations showed that she was having active phase of her ulcerative colitis, and probably because of this inflammatory disease she developed this mass. We were still not clear what it was, and it was also very difficult to decide about the further line of management. She had already had 2 episodes of stroke, and she had an LV mass with high embolic potential. So after a lot of discussion, she underwent surgical removal of the mass, even though there was a risk of causing intracranial bleed. The post-operative period was uneventful, and the histopathologist showed that it was just a thrombus. So then after that we read about it, we realized that thrombi can form in any systemic inflammatory disease, even if the LV is normal, although such thrombi is more common on the right side, but there are many case reports of thrombi on the left side as well. Another example, a 29-year-old lab technician presented in the morning in the ER with chest pain for 1 hour. He did not have any significant past medical history, he was not a smoker. His ECG was almost normal. We did a bedside echo, and in this bedside echo, we could make out that distal part of the septum was not contracting well. So that raised a suspicion of CAD. Although he was young, did not have any major cardiovascular risk factors, but we proceeded with angiogram in this patient, and the angiogram very surprisingly showed huge thrombus in the LAD. So he was having anterior wall MI, ECG was normal, but echo showed us that subtle wall motion abnormalities which led to this diagnosis. So he underwent PTC for that, and subsequent ECGs showed evolving changes of acute myocardial infarction. This was a 62-year-old lady, long-standing history of diabetes and hypertension, no past cardiac history. She had a fall resulting in knee joint injury, took some painkillers, then started having atypical chest pain, dyspnea, same evening, and then presented to ER in acute pulmonary edema. So when she presented, she was in frank pulmonary edema with sinus tachycardia, blood pressure was low, 80 millimeters systolic. She was immediately intubated, put on ventilator, and started on inotropic support. ECG only showed sinus tachy, cardiac enzymes, myoglobin slightly increased, others were normal, and these are her echo images. So as we can see here, there is severe hypokinesia or almost akinesia of LV apex. Other segments seem to be contracting Well, uh, then further investigation showed rising serum creatinine, TLC borderline elevated, IABP was put in. She improved hemodynamically over the course of next 2 to 3 days. Immediate angiogram was deferred because of rising creatinine, but her kidney function improved. She stabilized. Angiogram was done 3 days later, showed normal coronaries. So this was basically a case of Takotsubo cardiomyopathy. And day 4 we repeated her echo, and echo was absolutely normal. One more example, 48 years old gentleman, chronic smoker, known case of COPD. He presented with atypical chest pain with rapidly progressive dyspnea over a past few days, and he was very dyspneic in the upright position, was feeling better in supine position for some reason. So his angiogram was done, angio was normal, and it was not clear why he was having such dyspnea. So we did echo, and when we did echo, we found that there was something around the right atrium. Whether there was a mass in the RA or it was a pericardial mass compressing the RA, it was not clear from these images. But the subcostal images showed very clearly that there was a large mass in the right, in the pericardial space, almost entirely compressing the RA and extending along the RB also. Since we were not clear about the etiology of this mass, CT was done. CT showed that this was a hematoma. And it was very surprising why this hematoma was there. So we looked at the angiogram images again, and we found that there was actually a perforation in the one of the branches of the basically PD of the right coronary artery, and because of this he had developed this large hematoma. Why he developed this it was not clear, but this finding was missed during the initial angiogram because someone who did angio did not look at the entire video loop and just looked at the initial images and moved to the next video. So now this was a 52-year-old lady. She developed CA breast in 2010, underwent localized resection at that time. She had recurrence in 2016. At that time she presented with breathing difficulty, chest pain, tachycardia and hypotension. Because of these presentations she underwent echo, and echo immediately showed large pericardial effusion with tamponade. So no further investigation was needed to find the cause for her presentation. Now here we have this 46-year-old gentleman. He was a smoker. He developed febrile illness, took some antibiotics for that. 1 week later he presented with sudden suffocation feeling and shortness of breath. On examination he had sinus tachycardia with borderline blood pressure. Rest of the examination was normal. Chest X-ray was normal. ECG showed sinus tachycardia with some STT changes in anterior leads. So this was his echo, and the parasternal long axis view, we can see that RV appears dilated and there is something moving in the right ventricle. On turning the probe we could see it better. There was a huge long cast of a venous thrombus floating in the right ventricle. So basically he had a pulmonary embolism due to deep vein thrombosis. Now this was a 68-year-old gentleman, hypertension, diabetes, hypothyroidism. He had CKD, renal transplant was done in 2010. He had graft dysfunction, again on dialysis. So he presented with 3 weeks history of fever, shifted to ICU because of respiratory distress. We did echo and we found that there was some tube-like structure stuck between the RA and RV across the tricuspid valve. Most likely a part of the broken thrombus, broken catheter, and attached to that was a large mobile mass, likely to be a vegetation. Some more images, or could be thrombus, but he was having fever, so this part seemed to be most likely a vegetation. This could have been thrombus. But before something could be done, he had embolism of this and died suddenly. Now, this was a 43-year-old lady, apparently healthy, no known medical illness, and she presented with right hemiparesis and aphasia. She was diagnosed as had left MC infarct. She was started on antiplatelets and anticoagulants, and then she came to Medanta for further management. So the ECG which was done in the ER showed ST elevation in 2,3 AVF, but the patient was not able to speak because she had developed aphasia. We did her echo. Echo showed akinesia of the lateral wall, mid-distal lateral wall, and some and akinesia of the distal inferior wall. So maybe OM or diagonal artery territory. But at the same time, we also saw something moving in the left atrium, probably coming out of the pulmonary vein or LA appendage. So there was suspicion of LA appendage clot. She had mild TR with TR gradient 47. So we did further evaluation. These are her TE images. As you can see, there was a cystic mass coming out of the left superior pulmonary vein here. Some more images. So we're not sure what it was, whether it was thrombus or some tumor. So she was started on anticoagulation carefully because she had already had stroke, and ECG had suggested myocardial infarction as well. Then initial investigations were unremarkable except for anemia. CT chest was done. Now, CT chest did not show any thrombus, any tumor, but it showed that she had already had bilateral extensive pulmonary embolism also. So then the next question was, why pulmonary embolism? We did lower limb venous duplex scan. There was no DVT. Ultrasound abdomen, CT abdomen showed fibroid uterus, but no evidence of any malignancy. Her thrombophilia workup was also unremarkable. So she was managed with anticoagulants. On day 5, when we did echo, we found a clot in the LV, and this LA clot had disappeared. So for some reason she was having very high thrombogenic tendency, and because of which she was having thrombi repeatedly, different vascular territories. So she was continued on medical management, gradually improved. A few months back she came back after it's been almost 10 years since her initial presentation. At this time she again had a large thrombus in the LV. So why she is having these thrombi, it's not clear, but she has been on anticoagulation. Now another example, 52-year-old lady, 3 weeks history of fever. She was admitted for further evaluation and management, but had to be shifted to ICU because of respiratory distress. When we did echo, we found that she had a PDA. Unfortunately, I don't have the color image stored here, so just 2D image. And then there was this mass in the MPA just proximal to the opening of the PDA. So basically, she was having PDA, and because of that, she had developed a vegetation in the MPA. Now, blood cultures grew MSSA. CTPA showed evidence of pulmonary embolism. She was treated with appropriate antibiotics and heparin, and once she improved, she underwent PDA device closure. This lady, elderly lady, presented with anterior wall MI, had acute breathlessness on day 4. We did echo. Initial echo was did not show much, but a careful inspection of the septum showed a VSR, and we can see in this 3D image also this circular defect. She underwent VSR closure, device closure, and she recovered. So these are some of the examples which show how echo can give us instant diagnosis in these patients who present with acute decompensation of wide variety. Now besides this, echo can also be very helpful in assessing hemodynamics. I'll just give one example here. Although hemodynamic calculations with echo have their fallacies, they are based on various mathematical assumptions, and we need to be very accurate. We cannot be very dogmatic about our findings, but still echo can give us important clues. So like in hypotension, it can be because of hypovolemia, it could be because of cardiogenic reasons, or it could be sepsis. So here we have an example. A patient, just 2 minutes. Patient admitted in ICU with history of fever and loose stools for 1 week and profound weakness, altered sensorium for 1 day, diagnosed as having a case of acute gastroenteritis with sepsis. He is put on antibiotics, IV fluids. He is having sinus tachycardia, blood pressure is low. So what is the cause of hypotension? Is it myocarditis, hypovolemia, peripheral vasodilatation, or a combination of the above? Now in view of hypotension, echo is done, which shows normal LV systolic dysfunction. So acute myocarditis causing such hypotension is ruled out instantly. What other possibilities are there? So in this case, a calculation of systemic vascular resistance could be very helpful. This is what we did. For SVR, the formula is mean aortic pressure minus mean RA pressure divided by cardiac output. So mean aortic pressure in this patient was 67, IVC was normal, so RA pressure was normal. Normal IVC in this patient suggests hypovolemia. And the cardiac output we calculated from LVOT, that showed 5.4 liter per minute. So that gave us a SVR of 11 Wood units, almost 1000 dynes second divided by centimeter raised to 5. So this is a very low SVR for a patient who is having hypotension and sinus tachycardia, which means that this patient had hypovolemia because his IVC was collapsed and peripheral vasodilatation. So then he was treated accordingly, vasopressors, IV fluids, with that improved. So thank you so much.
Thanks, Dr. Bansal, for huge spectrum of acute care cases. We'll take the questions at the end of the sessions. Now I invite Dr. Nitin Burkule, who is perhaps the best person in this hall to talk about multimodality imaging. He will be talking on multimodality imaging assessment of native valvular regurgitation.
Thank you, respected chairperson and my dear friends. I will talk about the multimodality imaging for the native valvular regurgitation, though it is applicable even for the prosthetic wall. Now, why we should be thinking multimodality? Because if you see, even in 2017, the AAC is already thinking about multimodality imaging. And if you see the authors, okay, half of the authors are from AAC and half of the authors are from SCMR, that is the Society of Cardiovascular MRI. So almost an equal distribution. So if you see even in this 2017 guidelines, every regurgitation valve after the qualitative and quantitative estimation, there is one paragraph or almost sometimes there are 3-4 paragraphs describing the CMR way of measuring the regurgitation volume. Why is it so? So if we look at the mitral wall anatomy, and that too in 3 dimension, you really do not have any modality that can match echocardiography. You cannot have that kind of a real-time 3-dimensional view of the mitral leaflets and know the mechanism of MR and to guide the transcatheter treatment or even the surgical repairs. Nothing can beat this, okay? This temporal and spatial resolution is unheard of in any other modality. So then what is the point? The problem is quantification, okay? Because if we see the MR and AR quantification, the mild and moderate and severe depend upon RV, that is regurgitation volume, and RF, that is the regurgitation fraction. Now I'll be always using RV and RF for this particular regurgitation volume and fraction. So you need a very good quantification where there should be less inter-observer variability and inter-study variability, and that too when you are at grade 3 and you are deciding about the surgical intervention. So that is a very crucial period. When you have got some trivial regurgitation, you really don't need any multimodality. When you have got a completely flail mitral leaflet, you don't need multimodality imaging. You know that they are severe or they are mild. What is the problem? Crux is this particular area, 45 to 60, 40% to 50%. And this becomes more acute, especially when you are talking about secondary mitral regurgitation. So what we really depend upon in the echo, I think most of the parameters are qualitative or semi-quantitative. The quantitative depend only on 2 things. One, that you look at the PISA method, whether you are using MR or AR and utilizing it, and despite all the limitations that it is not a hemisphere, still it has got a very good correlation with CMR. That is very, very interesting. And second comes is the is that you look at the Doppler volumetric method, that is you take the Doppler flows across the outflows, and then you take the Doppler flows across the annulus. And in the annulus, though actually the mitral annulus is never circular, you should be taking 3.1 a square b square, but the guidelines say that it is actually correlates very well even with only one diameter in only one 4-chamber view, it still gives you a good values. So anyway, if you look at both these quantitative methods, whether it is PISA or Doppler volumetric one, you have serious limitations there. Thirdly, 3D LV stroke volume, if you really real life you start using it, it really doesn't work that well. So that means the question is quantification and quantification. So let us look at the AAC algorithm, that these are some of those factors which are definitely severe MR, okay, and we'll come back to this. Flail leaflet, very large VC, very large PISA, very large jet, pulmonary systolic reversal and enlarged LV with normal function. So we know that these are definitely severe, okay. But we'll come to that, we'll revisit it. Now let us look how the MRI does the quantification. It uses different technique. First what it does is that it uses a volumetric method in which it takes the LV end diastolic volume by a good planimetry of all the slices from base to apex. Each slice is kept at 6 millimeter without any intervening distance, and since you are getting an area into the height, you get the centimeter cube, you get the volume at end diastole and end systole, you add all these slices and you get end diastolic and systolic volume. Now this contrast between the cavity and the myocardium is without using any contrast, I mean gadolinium contrast. This just comes because of a particular sequence, so you don't need any contrast here to get this kind of images. So the endocardial delineation is extremely good here. So there is a reproducible stroke volume that you get. But the problem with CMR is that now to get a regurgitation volume, it uses another sequence. It doesn't now use a volumetric method, which is a cine MRI. What it does is it uses actual flow quantification across the sinotubular junction. Now why does it do that? They should have been using, if you can calculate this flow across this particular image plane, why not put it at mitral wall and just get the forward backward flow in one go? But you can't do that because the annulus just moves out of the plane of imaging, and MRI cannot keep on adjusting the plane because it's not a real time imaging. It cannot adjust it. So the only way the MRI can go is that it can keep at a cross section which is stable throughout the systole, and that is sinotubular junction, both at aorta and at the pulmonary artery. So that means you are losing that 8% of blood flow which is going into the coronaries, but it really doesn't matter much, okay. And then what it also has got the same problems with Nyquist limit and wraparound, everything it has the same problems, adjusting the baseline and you get a forward flow. But look carefully, you can look in the RR interval how many data points it has measured. If you see during systole it has measured very few data points, okay. This is okay when the flow is laminar, that means from one data point to another data point there is no rapid change. But this will go haywire if you have rapidly changing gradients like aortic stenosis, dynamic LVOT obstruction. You can't use this because this is a very low temporal resolution, okay. So unless you have got a very nice laminar flow, you can't use it, okay. So you have got, so when there is a very gradual rise, you know that you will be able to get the entire, and at every data point you are getting the velocity, and not only you are getting a mean velocity, unlike Doppler which takes only the central maximal velocity. Here it takes the mean velocity of slow flowing pixels at the periphery and also the fast moving pixels in the center. So it gives you a mean velocity, and for every data point it also measures the cross section, which even it changes during systole, it accounts for that, okay. And then multiplying this with this, you get centimeter cube, you get the flow for every time point, and then you take a velocity time integral or the flow time integral to get the stroke volume, okay. And that is how you get the forward flow across the aorta. So in your previous view, you got by volumetric method, you got the stroke volume of the LV, which will constitute the forward flow and the regurgitation volume, okay. So now if you subtract only the forward flow here, you get the mitral regurgitation volume. So that is how you get MRRV. And how will you get MRRF? Regurgitation fraction. For any regurgitation fraction, the basic principle is that across that wall, the numerator should be your regurgitation volume and denominator should be your forward flow. Okay. So here, if you take the regurgitation volume as numerator and take the entire stroke volume as your denominator, you get MRRF, regurgitation fraction. And this is very, very reproducible unless the quality of MRI is not good. Another benefit with the MRI is that you can independently measure MRRV, the RVs and RFs of the valves. Those do not interfere with each other. Why? Because the aorta is a cakewalk. For the simple reason that you are getting a forward flow and you are getting a rigid flow by just one image, okay, of the flow quantification. By keeping your imaging plane at the sinotubular junction, you are getting forward flow, you are getting rigid flow, okay. And the area under the curve gives you total stroke volume, and this gives you the aortic regurgitation volume, okay. So it gets in only one plane, okay. Now let me tell you, as you were looking at cine MRIs for the volumetric stroke volume, this particular quantification of the flow volume has a term and it is called as phase contrast imaging. So it is like you can say it is like a Doppler equivalent of CMR, though it has nothing to do with Doppler, but the way from grayscale we go to Doppler for our flow measurements, the MRI shifts from the cine MRI to phase contrast imaging, and this phase contrast imaging is available in all the MRIs, okay. It is not at all something out of the box sequence, okay. So here it is so simple that if I just take the regurgitation, the planimeter in the diastole, if I take the area under the curve, I get ARRV in one go. And if I just divide this ARRV by the forward flow, I get ARRF, I get refraction, okay. And I have nothing to do whether I have got MR, I got MS, I have got MSMR, it doesn't matter at all. Or whether I got any right-sided disease also, it doesn't matter. This works exactly the same for the right-sided lesions. The same thing for the TR and same thing for the PR, okay. You get the same thing as you are using it for MR and AR. Secondly, there is an advantage for the right-sided, because as you know in echo we are very poor in the regurgitation volume and regurgitation fraction measurement for TR and PR, okay. Now comes the question, I showed you the first slide of the severity of MR and AR by the quantification. Can we use the same for CMR? No, it is a completely different modality, and that is why their cutoffs for the outcomes would be different, okay. So most of the experts, though there are not multicentric data for the outcome analysis unlike echo, most of the experts and especially the single center studies like from Houston and other places, the cutoffs have been brought down from the echo, okay. So for the regurgitation fraction severity for AR, instead of 50% in the echo, it has brought down to 35, and for MR more than 50%, it has been brought down to 40%, because the single center study shows that above that your the outcome data is very similar to the echo related 50% RF data, regurgitation fraction data. But always remember, the regurgitation fraction for MR is 10% less than the echo and the AR is 15% less than the echo, okay. But the problem comes, how good is this correlation, okay. This correlation, unfortunately, though it is the only single center study, and I think it is too much of a biased study, but the correlation is not very good. If we use the AAC algorithm for definite severe that I showed you, those 6 points, actually only the half are calculated as severe by the MRI, and this doesn't even change whether it is eccentric jet or central jet, it is the same, okay. Rather, the central jet, the correlation is very poor, and it is also very poor for each of those 6 AAC algorithms for definite severe ones, okay. The non-severe are the green ones, okay. So the correlation is bad, but all this data comes only from Dr. Uretsky. Somehow I think is little too biased in this to prove the superiority of CMR. I think in real life it really doesn't, it may not be that way. So what I will do is that instead of now going for the, I think how much time I have? I got only 1 minute. 1 minute, okay. then instead of going for MR and AR, I'll directly go for a case of TR and PR, so that we discuss the same things with the, so we'll look at a case, and we are going to use the same methods that we use for the left for the right. Okay, 21-year-old male, DORV VSD PS, intracardiac VSD tunneling to the aorta, RVOT transgranular patch, and now he has got severe PR. And this is his ECG showing you the RBBB and the intraventricular, it is a full RBBB, obviously because of the RV free wall cut and the patch. And here is the echo showing you the right ventricular dilatation, and we have got this PR which is severe. And generally what we do is we look at the right pulmonary artery, especially for the reversal, and we say it is severe. So our quantification is very poor for the PR. So also our quantification for the RV volumes is also very poor. So he also has got TR, which is obviously related to the RV dilatation and is the secondary TR. And we have got this TR here, and our again quantification is most of the time is semi-quantitative. Okay, and here we go for the 3D RV. Most of the time you may not get a very good 3D RV volumes in these post-operative patients. But here we have the EF which is 42, and we have got the volumes here which are 200 and 135. Now remember, for any transcatheter pulmonary valve implantation, you really need a good cutoff of the RV end diastolic volume more than 120 ml per meter square, and you need an RV EF falling to 40 or less on the RV free wall strain, obviously, which is the only thing that the echo gives you more consistently. And you have got the hepatic veins to look for the reversal of the TR here. And what are we going to do with the echo? We are going to take the RV stroke volume, and we are going to subtract the pulmonary forward flow to get the TR regurgitation volume. But at the same time, how are we going to get the PR? A simple phase contrast across the pulmonary artery, which is going to give you both forward and backward. Okay, and quickly we'll go through the MRI of this patient and see how easy it becomes. Okay, so we'll go for the images here. These are images to show you the RV enlargement, and we really get the RV free wall, we get the stroke volume, you get the RV slices from base to apex, you get the pulmonary aorta flow here, you get the pulmonary flow, pulmonary aorta flow, and then you get the MPA flow. Unlike the Doppler, where you want to be parallel to the flow, in MRI you have to be perpendicular to the flow. Okay, so now here you are perpendicular to the pulmonary artery, and in one go you have got a forward flow and a reverse flow, and you get the forward flow of 109, regurgitation volume of 54 ml, and the fraction in only one image of 49%. But the beauty is you can actually look at the RPA and LPA separately also. You can look at the RPA, and you can look at the RPA forward and reverse flow, and you can also look at the LPA, and you can get the LPA forward and reverse flow also. So you have got an internal quality control also, that both the hyali are also regurgitating like the way you saw on the Doppler, that the RPA was showing you a reverse flow. So also we go for a proper RV volumes, and we see the RV EF, and we get the end diastolic volume which is 200 ml per meter square. We get a stroke volume of 158 ml by the RV stroke volume. That RV stroke volume is going to have three components. One is the systemic stroke volume, one which the TR regurgitation volume, and one the PR regurgitation volume. So there will be three components in the total RV stroke volume. But it doesn't matter, because the moment I subtract from the RV stroke volume forward MPA flow, which is going to be the systemic flow also, and the PR regurgitation volume, I am directly getting the TR regurgitation volume. Okay, so it is so simple. But to get a TR regurgitation fraction, I have to do little juggling, because TR regurgitation volume is my numerator. The denominator should be the forward flow across tricuspid wall. So that will be the total RV stroke volume, and I have to just subtract the PR regurgitation volume from that, because that volume is not going to come back across the tricuspid wall. So I just subtract that from 150/54, and you get a regurgitation fraction of 47%. Okay, thank you. So especially for the right heart quantification, I think CMR is much superior than the echo. Especially when you want to get the perfect volumes. For the left, it really doesn't matter, except for those thresholds at which you are, whether you are deciding for or against interventions, I think the CMR can act as one of the referee. Okay, but you really don't need it again and again. But I think for the right-sided lesions, CMR is far, far superior than what we do in our regular echo study. Thank you.
Thank you, Dr. Nitin. We'll have question answers at the end. So it's my pleasure to call upon the next speaker, Professor J.C. Mohan. He's going to speak on echocardiography and the cardiomyopathy spectrum.
Organizers of the Ezecho 2025 for inviting me here. I'm here since afternoon, and I think a large part of that echocardiography spectrum of cardiomyopathy has already been discussed. I saw Devika presenting a lot about hypertrophic cardiomyopathy, Anuruddh presenting restrictive cardiomyopathy, the idiopathic variety as well as the amyloid. So, and of course in live in box we did see dilated cardiomyopathy being presented. So I think I will just walk you through the echocardiography and cardiomyopathy spectrum. So cardiomyopathy is heart muscle disease unrelated to ischemic congenital valvular hypertensive or pericardial pathology. It's actually is a biologically active dynamic process. It starts with a genotype positive or phenotype negative, wherever it is there. Then there is a preclinical phase, then there is a clinical phase, preclinical phase, clinical phase, and the other part where there is either improvement, deterioration, remission, demise. Those are ones where echo plays a role both in diagnosis, follow-up, prognosis, and of course in case some devices or implants have been used to see their efficacy. The European Society of Cardiology 2023 proposed these phenotypes of cardiomyopathies: dilated cardiomyopathy, hypertrophic cardiomyopathy, restrictive cardiomyopathy, arrhythmogenic right ventricle cardiomyopathy. I think it should be called arrhythmogenic ventricular cardiomyopathy rather than ARVC. Non-dilated hypokinetic left ventricle cardiomyopathy, and a mixed variety. Overall, it is not an uncommon, the cardiomyopathy is not an uncommon thing. Both dilated cardiomyopathy and hypertrophic cardiomyopathy may be occurring in up to 1 in 200 to 1 in 500 population, the other varieties being relatively uncommon. And largely cardiomyopathies can be genetic or non-genetic. Nearly 35% are genetic. Actually this number is rising as we are doing more and more genomic studies. Non-genetics could be because of alcohol, drugs, toxin, myocarditis, and of course other endocrinopathies. Post-inflammatory cardiomyopathy accounts for a substantial number. It could be viral, parasitic, even bacterial, especially when you think of tubercular cardiomyopathy and Chagas disease, sarcoidosis, giant cell myocarditis, lupus, Soren syndrome, psoriasis, dermatomyositis, rheumatoid arthritis. And the genetic variety, as said, accounts for 35% all cardiomyopathies. And those could be, the mutations could be nuclear envelope proteins, sarcomeric proteins, cytoskeleton proteins, and of course mitochondriopathies. The endocrinal cardiomyopathies are quite often ignored by us, barring diabetic cardiomyopathy. We need to realize that thyroid disorders, pheochromocytoma, acromegaly, Cushing, they all actually can lead to cardiomyopathy, both non-dilated and dilated variety with variable left ventricle function. Micronutrient deficiency is another thing more often seen in children, more often actually more dramatic when the patients are on diuretics, but nevertheless, this is something which we need to keep in mind. We typically would talk about genetic, inflammatory, infiltrating, metabolic, and nutritional cardiomyopathy. Anyhow, the cardiomyopathies present typically either with heart failure or with AV blocks, bundle branch block, arrhythmias, syncope, sudden cardiac death. But there are other features like extracardiac features which could be skeletal features, thromboembolic complications, and family history. So when do we do an echocardiogram? When you have symptoms and signs, abnormal ECG, extracardiac syndrome, family history, you suspect cardiomyopathy, you want to know the morphophenotype, and you also want to characterize the tissue. So in morphophenotype, you use echo, CMR, and CT. For tissue characterization, CMR is number 1, CT, echo comes at number 3, and then of course positive emission tomography. So how do we go about? In every patient who has cardiomyopathy, after clinical evaluation, ECG, you go through biochemistry, the entire biochemistry, and of course sometimes specific in case you get red flags, imaging, hemodynamic assessment, and genetic assessment. Imaging and hemodynamic assessment, as I said, needs, there is a role of echo. So echo in cardiomyopathy provides morphological characterization, functional characterization, hemodynamic characterization, and to a small extent tissue characterization. We cannot ignore the role of echo in tissue characterization, and I will show you some examples of that. But keep in mind that echo gets us in right ballpark, and each cardiomyopathy needs tissue characterization in genetic studies. So you have to have the two more important, besides the genetic studies, two more important imaging modalities, CMR and PET-CT or SPECT, almost in a large number of patients of cardiomyopathy, and we need to keep that thing in mind. And the elements which participate in cardiomyopathy are myocyte, capillaries, and extracellular matrix. And to some extent, actually, if you want to see the blood flow, the contrast myocardial imaging also plays a role. What is the minimal information you want to get from echo in a cardiomyopathy? Left ventricle ejection fraction, volumes, mass, geometry, especially sphericity, scars, aneurysm, thrombus, segmental valve motion abnormality, LA volume, degree of functional mitral regurgitation, PA pressure, TR, RV function, E2E prime, global launcher strain, RV free wall, and LA reservoir strain. So let us quickly go through the various morphological phenotypes. Here is, of course, a typical dilated cardiomyopathy in a 46-year-old male person. This actually can be, again, a typical feature which can be there in post-viral, it can be alcoholic, it can be diabetic, and it can be genetic. So just by looking at it, you can't say that this is all idiopathic dilated cardiomyopathy. The other variety which we are now recognizing more and more in literature says only 5%, and that is non-dilated hypokinetic left ventricle cardiomyopathy, where the ejection fraction is low, but the left ventricle is not dilated, and there is global hypokinesis getting more and more being recognized. The literature says 5%. Our feeling is probably it is more than that. And of course, these are the individuals who have the same reasons or the same etiologies as dilated cardiomyopathy. Restrictive cardiomyopathy can be familial or non-familial. Here is a 26-year female with a restrictive cardiomyopathy. This is genetic variety. You have actually a lot of genes which can account for restrictive cardiomyopathy. So in every patient with restrictive cardiomyopathy, you need to do a genetic studies. Here the atria are dilated, ventricles are small, contracting normal, and of course these individuals can be of two types, largely atrial variety where the atrial reservoir strain is markedly reduced, but the left ventricle strain is by and large preserved, like the case I'm showing you here. Here you can see the left ventricle longitudinal strain is minus 21 something actually, although there is a typical restrictive pattern. So this is a primary atrial cardiomyopathy restrictive variety. You can get ventricular variety of restrictive cardiomyopathy, and you can get the combination of two, and we just have to keep in mind that this is one area where we need to expand our horizon. Of course, Devika took you through the hypertrophic cardiomyopathy, all varieties. I won't take you through that. You already know the typical variety, and of course, this classification by Marin, which she talked in detail. And of course, she did show you classic examples of aneurysm with mid-cavity obstruction with the lobster claw Doppler pattern. I wouldn't take you through that, except low down you can see a huge aneurysm, bigger than the LV cavity. With regard to a mid-cavity obstruction. I thought that the lower down picture that, you look at the balloon, it looks more like a parachute. That is a huge, big aneurysm, and she rightly said that these are the individuals who probably could be candidate for mavacamten. They would also require an ICD and anticoagulation. She did talk about measuring wall thickness. One word, of course, wall thickness needs to be measured. There will be a lot of errors if you measure without contrast. And if you want to really bring it, the thickness levels to the accuracy of MRI, you would have to use contrast. That is one particular way. And she did talk about that the obstructive variety provoked or rest is 70% and 30% are non-obstructive varieties. She did talk about all the features of hypertrophic cardiomyopathy with difference from other varieties, and SAM and S, of course, we have known dynamic left ventricular outflow obstruction. She did talk about the mitral leaflets and other stuff, and I would try to skip it. Unfavorable prognosis, she did talk about the wall thickness exceeding 30, apical aneurysm, resting gradient more than 30, left atrial enlargement more than 48, and we just have to keep that thing in mind. Other variety like ARVC, this case has been loaned to me by Dr. Nitin Burkle. A subtle variety where there is a regional dyskinesis and of course dilatation of the RVOT in a person who presented with LBV type of ventricular tachycardia, and always consider ARVC. That can present any time between the age of 20 to 60 years of age, although the rare varieties patient can present very late as well. The last I saw long back a case or ARVC who presented typically with dilated heart failure. Actually was this individual who had markedly dilated right ventricle, right atrium, and of course markedly dilated RVOT presenting with heart failure with a strong family history, and this boy died. There are other varieties of cardiomyopathies, like this individual has sawtooth cardiomyopathy, which is a congenital myocardial dysplasia where there are muscular projections arising from septum and lateral wall. They can crisscross each other to give you tiger stripes, and these individuals usually don't have actually CMR positivity for late gadolinium enhancement, can present with heart failure, can present with bundle branch blocks, or rarely with AV blocks, and sometimes with ventricular tachycardia, like here in this 48 years gentleman who has apical aneurysm, lot of sawtooth appearance, and of course ventricular tachycardia. Another variety of arrhythmogenic cardiomyopathy, not that commonly described, is this variety where there are multiple aneurysms of the left ventricle and unrelated to any ischemic heart disease with normal coronary angiogram, and people presenting with multiple types of bundle branch blocks and these are individuals who have to be differentiated from Chagas disease in South America, tuberculosis, and to some extent sarcoidosis in India. Of course, there are other secondary varieties, like the amyloidosis, which has been talked a lot. That was AL amyloidosis, and this is ATTR, where you have biventricular thickness and thickening of the interatrial septum and RV free wall. Sarcoidosis variety actually is, we are recognizing more and more in this country now that we have become aware of it. The PET plays a big role in diagnosing the active phase, but the echo actually gives you a lot of clue, not necessarily with regard to diagnosis, but certain signs are more specific. And this is a patient of ventricular tachycardia who has this typical bowstring appearance of the interventricular septum, which is a classic sign of sarcoidosis not seen in any other condition, and the arrow would point towards that bowstring sign. The other variety of course sarcoidosis are these basal anterior septum thinness when it is thinner than 4 millimeter, or the ratio between this and adjacent is less than 0.6. It usually is suggestive of sarcoidosis. Low sensitivity relatively, about 39%, but high specificity, 99% for diagnosing actually cardiac sarcoidosis. Devika did talk about this genotype-phenotype correlation with regard to curvature of the septum. I will skip it, but we also actually can identify potential sources of complications in cardiomyopathy using echo, like of course the thrombi, which many of these cases were shown by Dr. Manish Bansal. Genetic evaluation of the cardiomyopathy, actually you can identify the affected person family, the proband. You can collect the family history, so far and pre-test counseling. Genetic testing actually helps you in deciding which variety and what kind of counseling you should be doing. This is a recent family which I have been following actually for last 15 years. The grandmother had problem, then we recognized the young 19-year-old girl with some interesting hypertrophy looking cardiomyopathy, and then we scanned 45-year-old father, and the patient, the individual also has something resembling a combination where there is marked hypertrabeculation and hypertrophy of the interventricular septum. And I think this case Dr. Madhu will describe in great detail when she talks about infiltrative cardiomyopathies. So the evaluation of cardiomyopathy requires clinical profile, ECG biomarker, enzyme. Echo plays a big role, but remember this is just gets you in right ballpark. You still need much more important information from MRI, PET, and SPECT. So ladies and gentlemen, to summarize, echo and cardiomyopathy in clinical practice provides you diagnosis, etiology to some extent, prognosis, treatment. You can follow up these patients. Device management can be done better with the help of echo. You can test viability. Actually, viability may be important even in cardiomyopathy. There's another subject to be discussed. And of course, you can study reverse remodeling, which is a favorable sign when the patients are on foundational pillar therapy. Thank you very much.
Thanks, Professor Mohan. A brilliant presentation as usual. Now it's my pleasure to invite Professor Alagason to speak on recommendations for evaluation of prosthetic valves or percutaneous valve repair or replacement. Audiovisual.
I don't want this. I'll take off this one. Can you take off this? It's okay. It's okay. So, Dr. JC went like an express, going through the spectrum of cardiomyopathies. So I'll show you some cases about how to assess prosthetic valves, mitral, aortic. The recommendation for the assessment of prosthetic valves dates back from 2009. Then there was another review from the European Society of Cardiovascular Imaging. And 2019, there is American Society of Cardiography in collaboration with other societies came out with guidelines. And the latest one is in 2024, the guidelines for prosthetic valve imaging. This time, the cardiovascular imaging, magnetic resonance imaging, computer tomography, and PET scan, PET imaging have been included. That is the difference between the older ones and the newer ones, recognizing the importance of multimodality imaging in prosthetic valve assessment. You all know the types of prosthetic valves, biological valves, mechanical valves. I will not go into the details. And these are the valves, mechanical valves which are available, and these are the tissue valves which are available. And now we have the TAVR valves also. There are a number of companies which come out with the TAVR valve. The two are the most important one, the Medtronic and the Sapien valve 3. So whenever you want to assess the prosthetic valve, as we do in other valvular heart diseases, you have to go through the clinical information first. And especially if you have an implantation date and if you have a early echocardiographic findings after implantation as the patient is getting discharged, that will be useful in the serial evaluation of the prosthetic valves. Nowhere it is important than in a patient with prosthetic valves. Echocardiographically, you can use the transthoracic echocardiogram. Transesophageal echocardiogram is very much useful for certain cases, and three-dimensional echocardiography gives additional information. Of course, CT scan, MRI, and PET scan are also useful. What do you see in the echocardiogram? You have to look at the sewing ring, the valve occluder, valve leaflets are the occluder, the surrounding areas, and the ventricular functions. So whenever you do an echocardiogram, don't put on the color immediately, especially in a prosthetic valve. Look at the sewing ring, valve occluder, surrounding areas, ventricular function, etc. separately. Then put on the color and see for any stenosis or regurgitation. What we have to calculate, we have to measure the pressure gradients, the peak and the mean gradients, the Doppler velocity index, the acceleration time and the pressure half time, and we have to calculate the effective orifice area, and if there is any regurgitation, you have to see whether it is physiological or pathological, whether it is valvular, paravalvular or both. Those things we have to assess whenever we see a patient with prosthetic valve. So I will show you certain examples of patients with prosthetic valves. This is our own Chitra valve, a single disc mobile valve. Only thing it's not radio opaque. So, but we can clearly see the movement by using echocardiography. And then go to the four-chamber view, get the peak and the mean velocities, and then do the LVOT measurement and the LVOT VTI and the prosthetic valve gradient, prosthetic valve continuous velocity VTI, and then you can calculate the effective orifice area of the valve. So this we have to do it in each and every case. So you have to measure the peak velocity, peak gradient, mean gradient. We have to measure the LVOT VTI. We have to measure accurately the LVOT diameter, and then calculate the effective orifice area. So here there are some guidelines for you to assess whether there is any prosthetic valve stenosis. This is from the 2024 guidelines. When the velocity is below 2 meters, when the pressure half time is more than 130 milliseconds, and the Doppler DVI index is less than 2.2, most probably the valve is normal. So if the velocity is more than 2 or more, 1.9 to 2.5, pressure half time is increased and the Doppler velocity index is decreased, then there is most probably some pathology in the valve. So when it's moderate elevated, it can be due to prosthetic valve mismatch, prosthesis-patient mismatch. A prosthesis-patient mismatch is uncommon in the mitral position, whereas it's a little more common in the aortic position, but still it occurs. If there is a high gradient, then you think of stenosis, the moderate stenosis or a severe stenosis, depending upon the gradients. The gradients are almost similar to what we apply in mitral stenosis. Below 5, it is normal. 5 to 10, likely to be moderate stenosis. More than 10, mean pressure gradient is more likely to be severe. One of the other things which you have to remember is the high flow state. If there is a high flow state, the gradients will be increased. One of the common high flow state which we miss in prosthetic valve is valvular regurgitation. A paravalvular regurgitation which we don't see will increase the gradient across the prosthetic valves. So whenever you see a little high gradient, always look for a paravalvular regurgitation apart from the other causes of high flow state. So assessment of the mitral regurgitation, we have to go through the same set of findings which we do for the native mitral valve regurgitation, and then decide whether it is mild, moderate or severe. The criteria are almost similar to that of the native valve regurgitation. The only problem is it is much more difficult to visualize the regurgitation, measure the vena contracta, or get a PISA, or etc. will be much more difficult in prosthetic mitral valve regurgitation, and you might have to use your entire skill to get the mitral regurgitation assessment correctly. So this is there in the 2024 guidelines, and you can all go through it. I am not going to discuss it separately. So these are a few examples. This is a patient with double disc valve, St. Jude double disc valve with a normal gradient. There is no mitral regurgitation, etc. This is another patient with bioprosthetic valve. You can see again, it is a bioprosthetic valve is functioning normally. The gradients are completely normal. And this is a patient with disc valve. Here you can see regurgitation, a small regurgitation all around the valve. This is commonly found in normally functioning valve. These are sometimes called as washing jets, specifically designed to prevent any clot formation around the occluder. So this should not be taken as abnormal mitral regurgitation. In the assessment of mitral valves, the prosthetic valves especially, there is acoustic shadowing which will interfere. But in the case of mitral valve, if you are doing the transthoracic echocardiogram, you can look at the ventricular side of the valve. If you do a transesophageal echocardiogram, you can look at the left atrial side of the valve. So by doing a transthoracic and transesophageal, we can get rid of this image, this problem. Here you can see a lot of shadowing. We were not sure whether it is a normally functioning valve. This is a Medtronic valve, Medtronic Hall single disc valve. You can clearly see the shadowing, acoustic shadowing. There was no mobile echoes, and this patient did not have any thrombus or vegetation. And the gradients are almost normal. Mean gradient is about 4. And this is again not a common one, which we don't look for it often. So this is a patient with a small clot immediately following mitral valve replacement. Before the optimal INR reach, there is a small clot formation. The gradients are still normal. It is about mean gradient is 5. But still there is a clot. These clots sometimes can embolize and produce stroke, etc. And this is the same patient, non-obstructive thrombus. After, say, proper INR was reached, the clot got dissolved and it disappeared. These are patients with obstructive thrombus. Here you can see a St. Jude valve. The medial disc is not opening at all, whereas the lateral disc is opening, and the gradient is moderately elevated. So this patient again underwent thrombolytic therapy. You can see therapy, and you can see both the valves discs are moving nicely now after the thrombolytic therapy. This is another case of St. Jude double disc valve, where one of the discs is not opening at all. This is most probably due to a pannus. You can see the suture ring almost is completely obliterated. You can't see the pledget-like sutures, which is usually seen in the transesophageal echocardiogram, 3D echocardiogram. And this is most probably a pannus which is producing an obstruction. This is another patient with pannus. You can see the dense echoes on the atrial surface of the atrial side of the St. Jude valve. This is it's not moving at all, and this is producing a high gradient and restriction in the mobility of the disc. Lastly, this case, there is a large thrombus over the St. Jude valve. Here, the lateral disc is not moving at all. The medial disc is partially moving, and there is a severe regurgitation. This is the transesophageal echocardiogram, which confirms the findings. And after thrombolytic therapy, you can see both the discs are opening and closing completely normally. So thrombolytic therapy sometimes is very life-saving, but only thing is on the left side, it has got the risk of thromboembolism of up to 10%, especially if the thrombus is a large one. And this is a patient with, say, increased gradient across the disc valve. And the echo is a old one, may not be so good, but you can see the gradient is about 23 and 11. We did an transesophageal echocardiogram which showed vegetation which is protruding into the left atrium. So this was the one which was producing the large gradient. And this case we'll skip. It's a long clip, we'll skip. This is a patient with paravalvular regurgitation. It's a star Edward valve. You can clearly see the paravalvular regurgitation between the interatrial septum, intervertebral septal junction, and the prosthetic valve ring. And this is a patient with prosthetic valve, bioprosthetic valve with degeneration, and there is a high gradient and also regurgitation. Going to the aortic valve, you have to follow the same pattern. Say, look at the aortic valve first, then get the gradients and the effective orifice area. And similarly, any value below 3 meters is usually likely to be normal. The peak gradient of up to over 36 and the mean gradient of up to 20 is likely to be normal. When it is between 3 to 4 and the mean gradient is 20 to 34, we have to think in terms of obstruction or a patient processes mismatch. And if it is more than 4 meters, then it is likely to be significant stenosis. And also there is an algorithm, say when the velocity is increased from 3 to 4 or even up to 4, after 4, if the acceleration time is less than 100 milliseconds, that the acceleration is acute, then it is likely to be a patient process mismatch. Whereas if it is triangular or parabolic like this, then it is likely to be due to prosthetic valve stenosis. And for assessment of aortic valve regurgitation, prosthetic valve regurgitation, again, we use the same criteria. And one of the most important one is the descending aortic flow. See, always look at the descending aortic flow because that is not affected by any of the, say, artifacts, etc. And it is very handy when we are classifying the aortic regurgitation as mild, moderate, or severe. So this is a patient with a disc aortic valve and a disc mitral valve. You can measure the gradients, it is normal. This is a normal person. This is a bioprosthetic valve. Again, there is a trivial regurgitation, probably paravalvular. And this is a patient which we have been following. For, say, 2008, the gradient was 41 and 22. In 2009, it increased to 64 and 31. And the patient came in 2015. The gradient was 80 and 44. When there is a gradual increase in the gradient of the aortic valve, it especially suggests that the patient is likely to have a pannus. This is a patient with vegetations over the aortic valve, which has produced a paravalvular abscess. And this is a patient with valvular and paravalvular regurgitation. You can see in the short axis there is a valvular, and here there is a paravalvular regurgitation. And this clip doesn't run. There's a dehiscence of the valve, and you can see the bioprosthetic valve appears as an end-on view. You can see the 3 cusps of the bicuspid aortic valve because of the dehiscence.
Sir, you have to conclude.
Yes. And this is again a valvular and a paravalvular regurgitation, which is severe. As I told you, descending aortic flow and descending abdominal aortic flow, you can see that indicates that it is severe. So the other thing is, say, the usefulness of CT and MRI has been dealt with by Dr. Nitin. One of the things which I want to tell is in TAVR valve, there is a hypoattenuated thickening of the leaflet thickening, which is an indicative of thrombus formation over the bioprosthetic valve, which can be nicely picked up by CT imaging, whereas it is very difficult to do it by echocardiogram. So echocardiography is extremely useful, and it should be done as a routine in patients with prosthetic valve. Thank you.
Thank you, sir. We'll take the questions after the presentation. May I now invite our dynamic structural heart specialist, Dr. Sumanto? Okay, yeah. So Sumanto Mukhopadhyay will be talking regarding the procedural assessment of TEER, mitral TEER procedure. Sumanto Mukhopadhyay.
Thank you, the organizers and the chairpersons for inviting me to speak on this topic, and I'm delighted to be in front of you today. So I've been given a talk to talk about pre-procedural echo assessment for mitral transcatheter edge-to-edge therapy. These are my disclosures. So first and foremost, what is, maybe most of you are knowing, but just a quick grasp of what MitraClip is or what edge-to-edge therapy is. So the idea behind this was the famous or Alfieri stitch, whereby the surgeon puts a stitch centrally to convert a single orifice mitral valve into double orifice area, which in turn helps to approximate the two leaflets so that they close better. There is a zone of coaptation, and thus it reduces the mitral regurgitation. So in transcatheter edge-to-edge therapy, this was the basis for it, whereby a clip-like device is implanted on the anterior and posterior mitral leaflet to convert it into a double orifice mitral valve. There are similarities between Alfieri stitch and MitraClip is that it facilitates effective leaflet coaptation. It creates a tissue bridge which in turn limits the annular dilatation and thus the LV dilatation. It has got a better durability, and it exerts a rain effect and thus helps in LV remodeling. This is how the MitraClip or the Alfieri stitch works. The advantage of MitraClip, whereas Alfieri stitch did not become initially so popular, but why is edge-to-edge so popular or so, into the guidelines? That because this is done with the heart in the beating condition, so it avoids any kind of valvular distortion. The leaflets are grasped from below, from the ventricular side, rather than the surgeon stitching it from an atrial side. That it ensures smooth coaptation and better results. And as it is all throughout done under, continuous TE, it gives a real-time evaluation of how the MR is being changed. So what does the guidelines have to say about mitral edge-to-edge repair? So in primary, I don't know, it's playing up. So in primary mitral regurgitation, mitral edge-to-edge repair is indicated as a class 2A indication in patients who are high risk for surgical mitral valve repair. Whereas for secondary mitral regurgitation, if they have severe MR, if they do not need a CABG or a coronary artery bypass surgery, then transcatheter edge-to-edge repair has got class 2A recommendation as compared to surgery, which has got class 2B recommendation. So for secondary or functional MRs, MitraClip is probably better than surgery, but for primary MR or a degenerative MR, MitraClip should be considered only in patients who are at high risk for surgery. Now just to quickly go through a case, this is a gentleman with a 77-year-old mitral regurgitation with progressive shortness of breath, had a primary MR with severe flail leaflet, but due to his advanced age and various other comorbidities, he was deemed high risk, and a MitraClip was planned. Why I'm going through this steps once, because this will give us a prelude what we need to assess for a successful procedure. So what is important is that right femoral venous access is taken, we get into the RA, and from RA we need to go into LA, and with a proper transeptal which has to be somewhat posterior and superior. So there we can see on a bicaval view it is tenting, which is superior, and on a short axis view it is posterior. In order to gain a height of 4 centimeters plus of our transeptal while we get into the left atrium, because that gives us enough space to deliver and to do this kind of maneuvering. Next, once we are inside, what we want to do is we want to approach the valve perpendicular to the area which is problematic or where the maximum regurgitation is. Once we have done that, then in a degenerative MR where we see exactly the flail is what we want to clip or repair. So it is important for us to get where that flail is on the echocardiogram. And then finally, once we open the clip, what we want is that we need to be perpendicular to the line of coaptation. So that we get best on a TE. See here it is not perpendicular, it looks more like a parallel. So we rotate it and get a perpendicular axis. And then we go dive into the LV without getting caught into any of the papillary muscles or calcification in the area where we want to clip it. Following this, this is a pre-clip echo that you can see. This is our degenerative flail part, which is our target zone. And then we see what the regurgitant jet is like, quantify the jet previously and how it is going. And once we have done that, then what we do is we apply our clip right exactly where that flail was. And you can see both the leaflets are well held. There's no significant color regurgitation on various views. And this is another good marker, that is, we should always look pre-operative pulmonary venous flow and post the clip. Because if a patient has got reversal, that means he's got severe MR, and then you are able to abolish that reversal in the pulmonary venous flow, that patient definitely have got good results and is going to have clinical benefit. So these are the various steps that we do while we are doing an H2H repair. So when we evaluate a patient pre-procedurally, we have to keep the same things in mind, that when we want to give the interventionalist an idea that this can be clipped or not, or whether this MR is significant, what is the etiology. So these various information should be there in our reports or in our pictures. So moving from there, so the echo assessment, first and foremost, you need to ascertain that this is a significant or a severe MR. Next, we need to definitely tell what is the etiology of MR, because just writing giving a severe MR report without saying whether it is a degenerative MR or functional, if it's functional, whether it's a ventricular functional, atrial functional, if those things are not there, whether it's a rheumatic valve, you just, like the cardiologist or none of us can, even our colleagues cannot make out what we want to say. So we have to have a language to make this clear, and that should be same across states or across different hospitals or whatever it is. And finally is to assess it whether it is suitable for an H2H repair. So with regards to severity of MR, you would know better than me that we need to look at all these various things. We need to first look at qualitative. If that is not enough, semi-quantitative. And if there are problems, then we definitely go for properly quantitative. So these are various pictures of MR where you can see more of the times what we look at is how big the jet is, how much of LA area it is taking, whether it is a pansystolic jet or not, how dense is the jet, and then you get to know what the vena contracta is, and then you can do. So this is from the guidelines of Journal of American Society of Echocardiography. You have definitely 4 or more mild, then it's a mild, 4 or more criteria of definitely severe, whereby vena contracta is big, or you have large central jet, pulmonary vein flow reversal, enlarged LA, then you can conclude saying, okay, this is severe, this is mild. But what if it does not satisfy 4 or more? Then is where we use all those quantitative methods, and where a detailed, calculating PISA, ERO, and all that is definitely required. So once you have done that, based on different things, we can classify severe MR like an ERA of more than 4, or for functional, right now significant is taken as more than 3 centimeters square, and rest is same. So you have to give criteria for which we are basing that this is a severe MR, at least 3 or 4 points, so that we know that it is severe, and then we go on to the next step. Next step would be etiology of the regurgitation. Again, either it's a primary or secondary, what kind of primary, and it is very important for H2H repair, or even for surgeons also, some kinds of surgical procedures, to know whether the leaflet motion is restricted or not. That is only the closing restricted, or even if the opening is restricted. Because in mitral clip or Alfieri stitch, what we are reducing a single orifice into double orifice. So if we are starting with a restricted leaflet motion, then we'll end up having mitral stenosis, and that we do not want. So Carpentier classification has to be given if possible, or at least, if not, you don't write type 1, 2 and confuse people. You just can write leaflet motion is normal or restricted in opening or closing, and probable etiology is this. Finally, there Once we move on that it is a secondary MR, it is important nowadays also if we can mention whether it's an atrial functional or ventricular functional. Basic difference between the two would be that the ventricle is normal in a atrial functional, and in atrial functional the major reason for the MR would be dilatation of the atria, and that atrial dilatation is causing the annular dilatation, reducing the zone of coaptation and causing the MR. Now, coming to per se, when we look at the suitability, these are the basic things that we need to look at. One is, because this is a transeptal procedure, you need to see that there is a good site of puncture. There's no, lipomatous hypertrophy, extremely floppy septum. If those are there, it is important to know, because then you can do extra maneuvers like use electrocautery or RF to do a proper puncture, and giving the height of the fossa ovalis and fossa length is important for us to know that this puncture can be done safely, or do we need to do anything more. Once we look at the mitral valve, this is the most important view to assess on a TEE, that is the BICOM view or the intercommissural view, whereby you should get both medial and lateral commissures. You should have the apex of the ventricle, and then look at the MR. Also look at how the papillary muscles are and what is the chordae, and is there any papillary muscle or caudal calcification. Because when we are dipping with the clip into the ventricle, if there's a lot of calcification, lot of chordae, lot of disease, there is a chance that you might get entangled and have problems. So this is something we should be having the information when you are looking at. And finally then what we do in the BICOM view is, if you have a 3D machine, you can do an X-plane, either from medial to lateral sweep or lateral to medial, with and without color. Without color will give you how the leaflet looks at various positions, what is the length of the posterior and anterior mitral leaflet, is there any calcium, because it is important to decide on whether and how to put the clip. And it with color shows you exactly where the maximum jet is, because that is going to be our area of target. And at that point, is the leaflet healthy? Because supposedly you have calcium on the lateral end of the leaflet, A1, P1, but your zone of leak is somewhere between A2, P2 and A3, P3. So, and their leaflet is normal, still you can go ahead, do a clip and get a brilliant result. And supposedly if you do not have a 3D machine, then what you do is you have to separately go for an LVOT view and then assess again from medial to lateral to get the information that we get from doing biplane imaging. And these are the additional views which can, if is there, is very good, is like how on 3D it looks like, what is the exact pathology. We should always take the gradient across the valve, because if the gradient to start with is around 5, there's no point that you're trying to do a mitral clip into that patient. And similarly, you can get a short axis view to look at the mitral valve area or a 3D mitral valve area, because again, less than 3 is a contraindication, more than 4 is something that is desirable. So these are presently the guidelines. The optimal pathology would be if it's an A2P2, no calcification, there's a good cord-free zone, valve area more than 4 centimeters square, posterior leaflet length more than 10 millimeters, no leaflet mobility issues or no thickness, like abnormal thickness. And for secondary MR, if the tenting height is less than 11, and primary MR, if the flail width is less than 15 millimeters or a flail gap less than 10 millimeters, these are taken as the most or the best patients who will benefit from mitral clip, particularly if the operator who's doing it does not have a very extensive experience. And once that should not be attempted, or if there is like no, then only they should be thought about is if you have a cleft that is causing a regurgitation, or there is extensive mitral annular or calcification in your grasping zone. If the posterior leaflet is very small, if your mean gradient is more than 5, area less than 3, or a rheumatic valve disease, these are the valves that are not for clipping and should not be done. So if you see something like this, has got a severe MR, mention that, not suitable for clipping, so that, with the interventionist or other person is clear. Okay, am I off? Just 30 more seconds. So this is now, I would move to a small case of a functional MR. So again, in functional MR, also mitral clip has got a very good and it's a best indication. So functional sometimes can be a combination of functional with a bit of primary degenerative. These are good cases for a mitral clipping because they usually have a disproportionate MR. And again here, you see we place the clip right exactly where the maximum jet is. So we try and bisect the jet, place the clip there, sometimes if required two, and then reduce this without reducing the mitral orifice area, get a good tissue bridge, and we can get good results. Overall, to summarize, I would just ask you to have a look on this slide for 10 seconds, and this is what will give you which patients for clipping, which for not, and what we need to get is all this information. That is the leaflets pliable or not? Is it thickened? What is the leaflet length? Is there any area that could be specifically targeted? And is the mitral orifice big enough for us to convert it into double orifice at least, and that there's no significant mitral annular calcification or caudal calcification? Thank you.
Thank you, Dr. Shumanto. Excellent presentation. We'll have maybe question answer at the end. The last speaker, it's a pleasure to call Dr. Madhu Shukla to present her topic, infiltrative cardiomyopathies, eyes will see only if the mind knows.
So I will be speaking about infiltrative cardiomyopathies. All the other cardiomyopathies have already been dealt, and this is interesting to end with this. So I see what mind knows. When your mind knows is primed with some things, only then I will recognize this. This is very much common in the life also. And there are cardiomyopathies which look alike, but they are very different. Let's see in these cases. Infiltrative cardiomyopathies, what are they? They are a group of diseases characterized by the deposition of different substances either in the cell or in the extracellular space of the myocardium. This leads to what? Initially, when the wall becomes thick because of the increased size of myocytes and the extracellular deposits, when the wall thickness increases, there is decrease in the diastolic function. There is diastolic dysfunction because the wall becomes thick and stiff. But later on, there is overt systolic dysfunction also, later on in these patients. Infiltrative cardiomyopathy can be phenotypes of HCM and HOCM. They can present like HCM or HOCM. That means 5% of all clinical echo hypertrophic cardiomyopathies are actually infiltrative cardiomyopathies. What happens in these patients, how they present in infiltrative cardiomyopathies? They can present as heart failure, AV blocks, arrhythmias. They can have extra cardiac features specific to the cause, and they can have family history also positive. What are the substances basically deposited in these patients? They can be abnormal proteins, glycogen, lipids, iron, glycosphingolipids, and ceramides. They can be deposited in multiple organs, and the clinical presentation of the patient is according to the organs involved. Because again the same thing, there is diffuse cellular and extracellular volume expansion causing thick walls like in heart, and in the other organs whichever involved, they cause organ dysfunction and organ stiffness. The organs which are involved, they cause the systemic features. So this is just a cartoon to show how the LV on the right side is normal, and then after the deposition of the substance, the wall becomes thick and the morphology changes and it becomes stiff. Infiltrative cardiomyopathies can have extracellular deposits like in amyloidosis and intracellular depositions like in glycogen storage diseases. What are the common infiltrative cardiomyopathies? Commonly, which we see, not very commonly I will say, except amyloidosis. In my life, in my practice only, other living amyloidosis, I have seen other cases only 1 or 2. So, but I am presenting those cases here. So it can present as amyloidosis, ATTR, AL amyloidosis, or LEC2, or Fabry's disease, where there is glycosphingolipid accumulation, There can be lysosomal storage diseases, Danon syndrome and Pompey's disease. There can be mucopolysaccharidosis and PRKG2 deficiency. And there can be other also like hemochromatosis, Friedreich's ataxia, primary cardiac lymphoma, hereditary oxalosis, and hypereosinophilic cardiomyopathies. So whenever you see in echo a thick-walled LV ventricle, just don't ignore. It is just not LVH, it is just not hypertensive heart disease. Think beyond it also. Correlate clinically and then make the final diagnosis. So this is a patient, 90 years old male, whom we diagnose ATTR. Why? Because this is subepigastric view because window was not good. You can see thick-walled LV. RV free wall is also very thick. Interatrial septum is thick. Even the atrial walls are also very thick. And this patient had grade 3 pyrophosphate scan positive. So one thing to be noted in mind is the age at the presentation is very important. That will help you in differentiating the cause of the infiltrative cardiomyopathy. So there are some genetic cardiomyopathies which can have nuclear envelope protein involvement, cytoskeletal proteins, and sarcomeric protein involvement. And they present as dilated cardiomyopathy. But some of the sarcomeric proteins and mitochondriopathies, they present as SCM and HCM alikes. Then there are endocrinal hypertrophic cardiomyopathy as a differential diagnosis of infiltrative cardiomyopathy, like you see in diabetes, thyroid disorders, pheochromocytoma, and acromegaly, Cushing. And how do you evaluate such patients? First, you have to see clinically, see the clinical flags. What are the abnormalities in the patient presentation clinically? Then you do imaging. What you do? First you do ECG, then you do echo. And if by echo it's not clear, you go to further CMR and other modalities also. And you do biochemical tests. You do genetic studies and histology in such patients. So this is Danon's disease which involves a genetic defect in the gene called LAMP2. Danon syndrome, X-linked dominant lysosomal and glycogen storage disease. Here the presentation of disease is in less than 20 years. Presentation is with heart failure, skeletal myopathy, mental retardation. Patient's ECG shows usually short PR, normal QRS, and echo can show marked LVH. And in MRI you can see subendocardial LGE. This is less severe in females compared to males, and there is a strong family history to support the Danon's disease. It is found in other first degree relatives also. And this is mucopolysaccharidosis. It is found between 1 to 24 years of age when the patient present in this age with all this thick wall LV. You can think about these also. Patient can present as heart failure, skeletal myopathy, mental retardation, skeletal deformities, and coarse features. There can be history of malignant ventricular arrhythmia, and echo can show asymmetrical hypertrophy, septal hypertrophy, and there can be mitral valve and aortic valve involvement, and typical CT finding. So this is what do you see in echo? You see the you do the morphological assessment and disease-specific functional assessment. Echo is the first tool to screen out such patients. So this is the patient. You can see that patient's echo shows thick-walled ventricles, atria are dilated, there is pericardial effusion, severely reduced longitudinal function, and there is cherry on top, and there is hardly any atrial reservoir function. This was typical amyloidosis presented by a 53-year-old male with AL amyloidosis. After we did light chain analysis of this patient, we diagnosed this. So this is another 61-year-old dermatologist who came to us for echo, and we did the echo and saw. You see, initially it looks like only HCM or LVH with asymmetrical hypertrophy. But when you see in the middle, when you see the short axis, the echo texture is not uniform in the myometrium. In the this muscle of the heart, you see this uniform echo texture is not present. That creates the suspicion something is abnormal about this. So we thought we will do this contrast imaging of this patient. And you can easily see on the anterolateral wall, the wall is thick and there is hypervascularization. So that created a suspicion in our brain. Can patient have some malignancy? So again, this CMR picture shows Molly sequence shows T1 value, which is very high in this. If I have a pointer. And chalo. In the upper part, this septum, here you can see what I will say. This one, can I touch it? This part, you see, this is as the blood. T1 value of the blood is much high as compared to muscle, and as here both have same, so you cannot distinguish between them. So that made our diagnosis clear. So this is 61-year-old dermatologist with B-cell primary lymphoma. And this is next case, 59-year male. Latest, he had a last visit in BL Kapoor Hospital in Delhi. And here the echo was done and he was diagnosed to have hypertrophic obstructive cardiomyopathy, and clearance was given for cholecystectomy. It was done. But later patient had NSVT or some arrhythmia, so they did Holter, and ICD was implanted. And that patient came for follow-up and for the second opinion for us. This is the echo of this patient. You can see patient has marked left ventricular hypertrophy, and asymmetrical septal hypertrophy is also present. And there is mid-cavity gradient, which is around 36 millimeter of mercury. Patient has diastolic dysfunction. Patient doesn't have cherry on top. So there is no echo feature of amyloid. It looks like hypertrophic cardiomyopathy only. But when we did the cardiac MRI, we see the native T1 value, which was very much increased, 1236 millisecond, and ECV was 50%, and T2 was 52 millisecond. And when we did the light chain analysis of this patient, you can see lambda light chain was 123 milligram percent, and kappa was 19.2 milligram percent. So this patient was diagnosed to have amyloidosis, and patient was put on Cyborg protocol, and patient is improving. This is another patient, 22-year-old boy, who presented with painful burning sensation in the hands and feet. And he complained of reddish papular lesions on the palms and mid-back, and with atypical chest pain. His younger brother had similar lesions. Hemodynamically he was stable, and urine showed proteinuria, and cardiovascular examination was normal. ECG showed here short PR interval, and delta waves you can see in the ECG. And eye examination was done, which showed vortex keratosis. And this patient was, you can see the echo of this patient, thick-walled LV, and even the RV free wall is thick, RA wall is thick, and LA wall is also thick. He was diagnosed to have X-linked Fabry. This was the alpha galactosidase level was done, which was 0.11 nanomol per R per ml, and normal is 3 to 20. This level was very much low. So patient has neuropathy, skin rash, LVH, severe alpha galactosidase deficiency, family history in the brother, and genetic test is positive, and was diagnosed to have Anderson Fabry disease. Patient was sent to AIMS. They started on enzyme replacement, and here you can see the LV wall, which has significantly improved. but this inferolateral fibrosis is still visible. So 1% of all HCM is Fabry disease. Prevalence of, this is a study published by Kabayashi in some Japanese journal. 1% of all HCM is Fabry disease. Prevalence of GLS pathogenic variant of 0.93% in males and 0.9% in females with suspected HCM. ASH in 8% of all Fabries occur, and apical variety of HCM in 1% of all Fabries. So if you find a child with LVH, you must screen alpha galactosidase level. So another is Pompe's disease. Here also you find mobility problems. There is one infantile onset and there is one late onset. So usually there is muscular problem, so these children, they do not grow too much. And in the late onset, they present with the generalized skeletal muscle involvement, and this is autosomal recessive disease. So Pompe's disease is also known as glycogen storage disease type 2. It's a rare genetic disorder caused by a deficiency of enzyme alpha glucosidase. This enzyme breaks down the glycogen in the lysosomes of the cells, and when it is not present, this glycogen level in the lysosome increases, and that causes the disruption of the function of the cell, and that is responsible for the disease. And this harmful level occurs particularly in muscles including heart, skeletal muscles, and respiratory muscles. This is 13-year-old boy with easy fatigability and dyspnea since early childhood, having waddling gait, slow in school, average build, no specific phases, no cutaneous manifestations, but patient presented in heart failure with hypotension. This BP is almost normal in for 90/70 for the child, but patient presented with heart failure. I will show you. The ECG showed short PR and interval, LVH, and strain pattern. And serum creatinine was normal, liver enzymes were normal, but CPK was 302 units per ml. This was the echo of this patient. You can see the LV is hugely, markedly thickened. Even LA walls are thickened. And you can see here RV walls are also thickened, RA walls are also thickened. So, and patient has dilated IVC, suggesting patient is in heart failure. So Pompe's disease was confirmed in this patient after we sent to the dedicated specialized center. A pathogenic variant in the gene encoding lysosomal acid alpha-1,4 glycosidase was reported. This is 18 years old, underweight girl, family history of heart failure. Grandfather had EMF-like picture, sick sinus syndrome, and was on pacemaker. Grandfather died of cirrhosis due to hepatic cell carcinoma, and mother and father were okay. She presented with fever and sore throat for 2 days, had weakness, fatigue, and some dyspnea, atypical chest pain. Hemodynamically, she was stable. Heart rate was 52 beats per minute. And there was no evidence of heart failure. And ECG showed sinus bradycardia with 2:1 AV block. This was captured while I was doing the echo. And HSCRP was 4.3 milligram per liter. Troponin I was 26 nanogram per liter, and LDL cholesterol was 232, and triglyceride was 53. And this is the grandmother's echo. Sir had shown last time, just now in his presentation, this patient. Grandmother's echo was this. This is dated April 3, 2012, and she had paroxysmal atrial fibrillation and TIA in 2008, and then she was diagnosed tachybrady syndrome, and in 2014 she was given DDDR pacemaker. This was her father's echo, LVH. This was done on July 20, 2025. Patient had sinus bradycardia, PR interval was 142 millisecond, and there was T-wave inversion in V1 to V6. You see the atrial strain is 20 only. And this was this child's ECG. Short PR, LVH, and generalized T-wave changes, RVH and right axis deviation, and X-ray showed cardiomegaly. So what are these short intervals? They can be found in Fabry's disease, Dannon's disease, glycogen storage disease, PRKG2 mutation, and mitochondrial disorders. I have to run fast because of time. So this was the echo of this girl. LVID 35 millimeter only, but markedly thickened LV. And there was global LV hypokinesis, 45% EF, and global strain was minus 11.2%. And some diastolic dysfunction, though we don't consider this in children. And in the MRI, we saw non-compacted apex and free wall. These are more views. And so the summary of CMR in this free wall and apical segments are hypertrabeculated with non-compacted to compacted ratio of 3.2, EF 55%. There was asymmetrical septal hypertrophy, no LGE, and normal T1, T2, and ECV. So when we didn't find anything, we did genetic testing, and it demonstrated patient to be heterozygous in PRKG2 gene coding for emiscence mutation. Mutation in this gene for AMP activated protein kinase delta 2 cause an accumulation of cardiac glycogen and left ventricular hypertrophy that mimics hypertrophic cardiomyopathy. So in nutshell, HCM phenotype in young can be non-sarcomeric in 35% patients. It can be sarcomeric in 60% of patients. It can be caused by endocrinopathies or acromegaly, or it can be syndromic HCM like in Noonan syndrome, cardiovascular cutaneous syndrome, and Leopard syndrome. And if you see an elderly with HCM phenotype, you should think of non-sarcomeric causes in 5 to 10% patient like in amyloidosis and endocrinopathies and hypertensive heart disease, and sarcomeric HCM in 80% cases. Thank you.
Thank you, Dr. Madhu. That was a really fascinating collection. Thank you. Congratulations, and we really enjoyed it. So we are running late, but we'll allow, since this was such an important session, just about 2-3 questions can be allowed. Any questions from the floor? Professor JC, you had mentioned about the non-dilated hypokinetic. Have you really followed up these patients, what's happening to them?
I have a significant number of such patients, and surprisingly, these are the people who don't show reverse remodeling. They may have very little of LGE positivity, but for some surprise reason, they don't show much change. There may be an ejection fraction moving a little bit, but they are more like non-progressive. Non-progressive, they continue to have something like class 2 dyspnea. I have one patient whom now we have nearly 9 years of follow-up. That is the longest follow-up we have. This was a patient who had a T1, T2 value, both were increased, ECV was increased, and I thought it was more like post-myocarditis because there was subepicardial enhancement. Patient remained like this for last 9 years. There is actually, we also have a diabetic individual who had diabetes at the age of 25 years. 38 years now, he has same features. Nothing has happened. It has not dilated and it has not resolved also. So my personal impression is these are the people about whom we have to learn more. So far, I have not seen resolution this way or that way in majority of these patients.
Thank you. Any other questions? So on behalf of my co-chair, thank you all the speakers. A big round of applause for all of them. And with that, we conclude the session.
Can we have some applause for our chairpersons, please, as we end this session over here? Right after this, we'll be having the inaugural session, the inauguration. So requesting all of you to please come inside the banquet hall and take down the seats.
We will be starting with the inauguration. I request all of you to kindly take down the seats and those who are outside the banquet hall to kindly come inside. Inauguration of Ezecho 2025. I humbly request President WBAE and Organizing Chairperson of Ezecho 2025, Dr. Shubhro Banerjee, to please join on the dais. Can we have some applause? Chief Advisor Dr. Soumitra Kumar sir, to please join on the dais. Vice President WBAE, Dr. Pranita Nondi ma'am, please join on the dais. Also Dr. Arunangshu Ganguly, sir is not here right now. Honorary Secretary WBAE and Organizing Secretary of Ezecho 2025, Dr. Shulagna Banerjee ma'am, please join on the dais. Can we have some applause, please? Treasurer WBAE as well as Scientific Chairperson Dr. Paramartha Bhattacharya sir, please join on the dais. I request past President Dr. Shankar Mitra sir to please join on the dais. Dr. Arup Das Biswas sir to please join on the dais. And Dr. Achyut Sarkar sir to please join on the dais. I request Scientific Chairperson of Committee Ezecho, Dr. Devadatta Mukherjee to please join on the dais. Dr. Dipankar Datta to please join on the dais. Dr. Rajat Shubhro sir to please join on the dais. I request Joint Organizing Secretary of Ezecho 2025, Dr. Hirak Jyoti Charnal to please join on the dais. Chairperson of the Reception Committee, Dr. Aniruddha De, to please join on the dais. Can we have the music, please? Can we have some big round of applause as we witness this auspicious moment of the official inauguration of Ezecho 2025.
Ya Brahmachyut Shankara Prabhrutibhi Devai Sada Vandita Sama Patu Saraswati Bhagavati Nishesha Jadyapaha.
Kindly join on the stage, sir. Indeed, a very precious moment. Can we have some beautiful applause together once again? Yes, definitely a group photo. Buddhi Pradam Sharadam. Thank you so much, all of you. Thank you so much. We directly move on to the next session, oration by the President WBAE, Dr. Shubhro Banerjee. As chairpersons, I would like to invite on the dais Dr. Shankar Mitra sir and Dr. R.S. Ghosh. Thank you.
It's really proud privilege for me to introduce Dr. Saurabh Banerjee, who has been a close colleague of mine for last 30 years. I call him a bridge between intervention cardiology and non-intervention cardiology, which probably includes the echocardiography, the foremost thing. And he has joined the clinical cardiology as well with that. His leadership, teaching contribution, professional leadership, and research involvement has a long list, and I think I cannot exhaust it by doing few slides only. His contribution to the community, his contribution to the next community, especially during the COVID era when we were locked down, his broadcasts were really live and live. Cheers to a lot of cardiologists and made them inquisitive about learning how COVID acts with the cardiovascular system. His publications for general public is enormous, and everybody has been reading this, and it has reached to the millions in the state and out of the state as well. So his contributions, I'm proud to be having him a president to the West Bengal Society. I will invite next Dr. Shubhra Banerjee. Dais is yours.
Thank you, Dr. Mitra, for the very kind words. And good evening, everyone. I'm going to talk on cardiomyopathy, the imaging insights. I find already the timer is running. Anyway, doesn't matter. And but this topic has been touched many a times, I think, in today's program. But let's move on. Now, 2023 ESC has adopted a phenotypic approach for classification of cardiomyopathies. And it has categorized cardiomyopathy into 5 distinct phenotypes. And these are hypertrophic cardiomyopathy, dilated cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, restrictive cardiomyopathy, and non-dilated left ventricular cardiomyopathy. They have also emphasized that these categories are not mutually exclusive, as one phenotype with time may evolve into another, and therefore the diagnosis should be based on the predominant phenotype at presentation. There's also another important point that besides establishing the phenotype, it's also important to establish the etiology. To this end, there are multiple imaging modalities which are available, such as echocardiography, including not only transthoracic and TE, but also 3D strain imaging, stress echo, myocardial contrast echo, CMR, cardiac CT, myocardial scintigraphy, cardiac PET, and so on. And with this, it's not only diagnosis and establishing the etiology, but also risk stratification, prognosis, guiding treatment, and monitoring for disease progression are also achievable. Now let's first move on to the most talked about variety, which is the hypertrophic cardiomyopathy. Now transthoracic echo remains the first line imaging modality. It helps in estimating the wall thickness and localize the hypertrophy, on the basis of which we can subdivide or maybe categorize hypertrophic cardiomyopathy into different phenotypes such as septal, apical, diffuse, reverse, and many such other phenotypes. And also it helps us to establish the presence of SAM, the LVOT gradient on Doppler, and stress echocardiography, that's exercise stress echocardiography, I would say, would also help to unmask the latent LVOT gradient, and 3D echo morphology. 3D echo could help in establishing the morphology of the LV outflow tract. Then why do we need CMR? Well, CMR still remains the gold standard because echo views may be poor and some segments may be missed during examination. It's not possible to elaborately see all the segments, and the hypertrophy, may be localized at one point. So you must see all the segments, and measurements sometimes may be inaccurate, like if you may be having an oblique view, or the crista supraventriculis may be actually included in the septum during measurement. And some ancillary structural abnormalities, for example, elongated mitral valve leaflet, presence of myocardial crypts, anomalous insertion of papillary muscles, apical aneurysms, all these things may not be well visualized on echocardiography. Besides the structure, localization of LGE, that is left gadolinium enhancement, is also important, and in hypertrophic cardiomyopathy we know it is localized mostly in the hypertrophic segment and more often in septal and free wall junction. T1 parametric imaging may be very helpful in tissue characterization and helping in differential diagnosis of the HCM phenocopies. Now, what about risk of sudden cardiac arrest? Yes, imaging is also helpful. Left ventricular hypertrophy more than 30 millimeter, EF less than 50%, apical aneurysm, LA size, LVOT gradient, LG more than 15%, all increase the risk of sudden cardiac arrest. Worsening ejection fraction, worsening GLS on spectral tracking echo, progression of LG during follow-up, progression of ECV on T1 mapping. These are all indicative of risk of disease progression. It also helps in decision-making and guiding therapy. For example, stress echo, if it shows a dynamic LVOT gradient more than 50 in a symptomatic patient, they may actually be indicative of the need for septal reduction therapy. Myocardial contrast echo may be used to identify the area of the target of the septum prior to alcohol septal ablation. Intraoperative TE may be very helpful during surgical myectomy. And very interestingly, in genotype positive and LG negative family members, if you have morphological abnormalities, like, which I've mentioned, like problems with the LV mitral valve apparatus, in that case, these are the people who actually can develop phenotypic hypertrophy sooner. So they need closer surveillance. Coming to dilated cardiomyopathy, echo again remains the first imaging modality. It can actually assess the chamber sizes, ejection fraction, even RV function, functional MR, and indices of LV diastolic functions like left atrial volume index, E by prime ratio, TF velocity, all could be studied. Strain imaging can show the GLS, which is reduced. 3D echo may be more accurate and more it's more closely aligns with the CMR values. But CMR could be more useful in assessment of biventricular system function and the volumes. Now, an etiological workup again is necessary, and by definition, to establish dilated cardiomyopathy, you need to exclude valve disease and coronary artery disease, which could be done by echo and by coronary angiography, which could be again be CT coronary angiography. Now, we know that DCM phenotypes identifies a diverse group of patients with different pathologies. So it could be genetic cardiomyopathies, as we have just heard. It could be infiltrative and inflammatory cardiomyopathies. They can also present in a dilated form. And late dilated stages of hypertrophic cardiomyopathy and ARVCs are not uncommon. If there is increased relative LV wall thickness in a patient of dilated cardiomyopathy, then we must consider about the burnout HCM or the late stages of infiltrative cardiomyopathies. And CMR would be helpful in establishing the specific etiology. For example, in non-ischemic dilated cardiomyopathy, 1/3 of such cases may have septal midwall LG, which are localized to the septal midwall. Ischemic cardiomyopathy, we know it starts from subendocardium and spreads more to the transmural. And in sarcoidosis, it's mostly in the subepicardial and the mid segments in the basal mid-septum and the lateral wall. Now, tissue characterization also is helpful. For example, in myocarditis, you would have elevated T2 values, whereas in iron overload cardiomyopathies, the T2 star values would be reduced. And additional imaging modalities, for example, in sarcoid, PDG PET may be useful. We'll come to that later. Now, also it's helpful in determining prognosis. For example, GLS gives incremental prognosis value over and above ejection fraction. And if you do a DAC and if you find there's an increase in at least 5% increase in ejection fraction at peak exercise, then it's indicative in the presence of contractile reserve and reverse remodeling and improved outcomes. If there's a higher burden of LG, we know higher chances of arrhythmia and heart failure and mortality. Higher T1 and ECV values indicate worse prognosis, and mechanical dispersion is also a useful parameter which indicates higher arrhythmic outcomes. It also helps in guiding therapies. For example, echo may help in optimizing CRT parameters post-implantation, or as we have just heard our previous speakers saying, like about appropriateness of patients for mitral TR, and CMR may also help in acute rejection detection in heart transplantation patients, and also into guide lead in CRT, and also coronary venous anatomy may be displayed well on CT or CMR in patients with who have been planned for CRT. Now, arrhythmogenic right ventricular cardiomyopathy diagnosis doesn't depend on a single gold standard test, but on a scoring system, which apart from other parameters, which are clinical and ECG, also involves imaging, which are both echocardiography and cardiac MRI. And presence of dilated RV, RV dyskinetic segment, presence of microaneurysm, these things would be indicative of right ventricular cardiomyopathy. RV fractional area change, this is also important in assessing the prognosis and in diagnosis of ARVC. And at times we know that LV could be affected, that could be detected by imaging as well. There's some imaging parameters like RV basal diameter, RV TAPSE, RV GLS, RV mechanical dysfunction. These all actually help in prognostication, and LV ejection fraction and GLS are also provide incremental prognosis value over that we get by echocardiography. Now coming to restrictive cardiomyopathy, we know it's a diverse group of myocardial disease with a wide range of etiologies, but they share a functional characterization, and this actually differentiates it from the morphological characterization of the other type of cardiomyopathies which we have said. RCM is defined by the restrictive ventricular physiology in the presence of normal or reduced diastolic volume, normal or near normal LV systolic function, and normal or near normal wall thickness. And we know they could be familial genetic or even non-familial non-genetic, but for the diagnostic workup, first we have to differentiate it from constrictive pericarditis, and I think we had a lecture on this, and also we have to then identify the specific disease etiology. You have seen this sort of slides. Restrictive myopathy due to infiltrative disease, non-infiltrative storage disease, endomyocardial disease. Many diseases can cause restrictive cardiomyopathy, and for cardiac amyloid, which could be either ETTR or AL variety, here in both of them you'd get left ventricular wall thickness at least more than 12. There could be speckling of the myocardium, increased valvular thickness, increased thickness of the septum, and apical septal sparing is something everyone knows that you get on when you do a GLS. So there could be a 5 by 5, 5, 5 sign. That's all the values are less than 5. So all these things are characteristics of cardiac amyloidosis on echocardiography. On CMR, I think the very important thing is, of course, you get LV thickness and all, but if it's difficulty to null the myocardial signal in CMR is one of the very characteristic of cardiac amyloid. And the LG uptake is usually diffuse. There's marked increase in native T1 values and ECVs. Now, cardiac amyloidosis diagnosis, if they're looking at ATTR cardiomyopathy, of course, is done by scintigraphy, that is technetium PYP scan, and it would show at least a grade 2 or 3 uptake in the Periguni scale, and a cardiac and contralateral lung uptake, at least 1.5 or more. Now, cardiac sarcoidosis usually presents as a dilated phenotype, but it may present as a restrictive phenotype. We have just heard also in the preceding talk. And there could be thinning or thickening of the ventricular septum. Wall motion abnormalities may be present, regional in a non-coronary distribution. Aneurysmal dilatation of the left ventricle could be present. So you see, this can actually mimic many other conditions, even ARVC as well. And the longitudinal strain is reduced, and pericardial effusion could be present. If you do a CMR, you will get patchy LG uptake in the subepicardium and the mid wall, usually in the septum of the lateral wall, And this is associated with increased risk of VT. And if you do a FDG PET, you would find there is increased uptake of FDG in those sarcoid lesions which are active. And if you combine an MPI with FDG PET, then it can show you perfusion metabolism mismatch at those areas where the sarcoid is active. Now coming to Anderson-Fabry's disease, echocardiography would show left ventricular hypertrophy, which is usually concentric, but sometimes could be asymmetric as well. And it actually becomes a phenocopy or phenomenic of hypertrophic cardiomyopathy. And to make matters worse, it could be associated with LVOT and or mid-cavitary obstruction. But in these cases, you would find the GLC is reduced, there's preserved biventricular systolic function, valve leaflets may be thickened, papillary muscles may be thickened, and another characteristic thing is a binary septum, the hyperechoic endocardium just adjacent to the hypoechoic subendocardium. I think it's very difficult to make out from here, but yes. So CMR is also useful. CMR would show LGE at the basal segments of the infralateral wall of left ventricle in a mid-myocardial distribution, and may progressively this could become transmural with time, and then later stages they could actually be thinning of the involved myocardial segments, and this is associated with increased risk of sudden cardiac arrest. If you go for parametric mapping, they will find the native T1 is reduced. Although later stages, as the deposition gets worse, there could be pseudo-normalization. That is, the T1 value may go up again. And T2 value is usually high, and the ECV is normal in early stages. In case of iron overload cardiomyopathy, well, again, majority present as dilated phenotype is a dilated LV with reduced ejection fraction. Sometimes restrictive phenotype may also be seen, but again, characteristic would be T2 star value is low and T1 value may be low as well. Now, if you look at the endomyocardial fibrosis, EMF, again, this presents as a restrictive cardiomyopathy, and it predominantly affects the right or left. I mean, it could be either type, but right is more common. Small ventricular cavity is seen, and the endocardial thickening may cause apical obliteration, and that's one of the characteristics of the disease. There's mass restrictive diastolic pattern, and apical thrombus is common. Now, LG would also localize and quantify the fibrous tissues, and this correlates with motility. These are the different criteria, just given major and minor criteria for the diagnosis of endomyocardial fibrosis. And a definite diagnosis of EMF is made in the presence of two major criteria, or one major criteria associated with two minor criteria, giving a total score of at least more than 8. Is less than 8 is mild, 8 to 15 is moderate, and more than 15 it is considered a severe disease. So in conclusion, imaging modalities are necessary for identifying the cardiomyopathy phenotypes and determining the disease etiology. They also help in risk stratification, monitoring disease progression, and guiding treatment. Overall, they provide valuable imaging insights to cardiomyopathy. These are the acknowledgements. Thank you.
Since there is no question-answer session, we would not put Dr. Shubhra Banerjee to any position of answering questions, but as a chairman of this presidential oration, I would like to point out a few things to my audience, especially when 5 presidents, ex-presidents are sitting in the front row, and there are about 50 heads behind you, eager faces, who think that they will learn from this conference. As Dr. Shubhra Banerjee told us that the pre-CRT evaluation of TE is important, coronary sinus, the eustachian valve, how long is the coronary sinus? He's doing probably every day 1 or 2 CRT implants. So those questions, who will answer them? Yes, we know that we have given up stethoscope, and the transducer has taken place of it. And the machines are rising in number like anything. Small villages are having machines. So this forum, especially our presidents and students behind small eager faces with black hair and dressed up for the conference, please raise your hands. Please raise your hands to hold this stethoscope. Unless we build a big manpower, we are not going to gain anywhere, and multimodality will take up this, and we will be left behind while others will think that it is only work of CT and MR. No, you make the diagnosis, then only CT MR comes. So there will be 3 tier of things. So we have to really think at this time that we should have more hands raised, especially sitting on the back bench. I know they are eager to learn. Dr. Shubho, thank you very much for your oration, and we will definitely take few lessons from you. And with that, I would like to conclude it unless somebody else wants to speak something.
Thank you so much. A big round of applause for our chairpersons. We move on to the last session, potpourri of guest presentations. I would like to invite the chairpersons on the dais, Dr. Kanak Kumar Mitro, Dr. Pronita Nondi, Dr. Shulagna Banerjee, Dr. Obhijit Biswas. Can we have some applause for our chairpersons, please?
Good evening. So we are beginning to start our last session, and I think this is one of the very important session for all of us. There are several case presentations. So without wasting time, I will request Dr. Madhu Shukla for your presentation.
Presenting 2 cases of deadly side of Minuka. Very interesting cases. This first case is not our case. This is somebody else's case. 48 years old, obese female, who had a history of rheumatoid arthritis and stage 3 hypertension, presented with acute chest discomfort on February 3rd, 2025. And she was diagnosed as a case of ACS. She had tachycardia, hypotension after 1 hour of admission, and BP was 90/50, heart rate 100. This was the troponin I of this patient, 0.18 nanogram per ml. And this was the ECG showing acute inferior-posterior lateral MI. This was the second ECG repeated. And the patient was taken to cath lab, and the preliminary echo was done by the operator himself, so I don't have the pictures. So this was the angio. You can see the angio was normal, absolutely normal. Seeing that the angio was normal, the operator did aortogram also to see the cause of severe chest pain, and there was no aortic dissection. And PA pressure was also taken, which was 50/32 millimeter of mercury. And but suddenly after the angiography, the patient crashed. And the patient was immediately shifted into the CCU, and repeat echo was ordered when I was called to do the echo. So this is the echo. You can see some pericardial effusion. I will show you one more here. The arrow which I have put here, there is some collection here, blood here. Patient has normal angiography and normal everything except for the PA pressure increase, but patient has something here, collection, blood collection here. From where it has come? Might have been some rupture somewhere from where it has come. So you see, when I was doing the echo, patient went into cardiac tamponade. You can see the RA collapse with this hematoma. More pictures and some more pictures. And this was the lateral wall. Somehow I suspected there is some rent here. I'm not sure, but I thought there is some rent here. And this is pulsus alternans. And so this is Minoka with cardiac rupture. Patient had acute inferolateral MI, cardiac rupture and tamponade, significant pH, normal coronary angio, and the rupture site is not well identified. This patient did not give us any time and she died immediately after CPR and all, after coronary angiography. So lesson is every pericardial effusion following acute myocardial infarction is cardiac rupture unless proved otherwise. This I will skip. This is second case. This is a 74-year-old female, a known case of hypertension, had a history of CA ovary in 2019, had a history of cholecystectomy done in past. She had acute chest pain on 15th June 2024 and was diagnosed to have inferolateral STEMI with heart failure and atrial fibrillation. Coronary angiography was done, which is normal. It was done outside in some hospital. I'm just telling you the history because the patient joined us on 17 September 2024. She was treated there, angiography was done, which was normal, and she was treated conservatively. She, meanwhile, continued to have recurrent heart failure, and she came in last admission on September 17, 2024 with us. She had BP 110/70, but she was in frank failure, and she had troponin I 20.9 nanogram per liter, and anti-proBNP was 4050 picogram per ml. This was the ECG showing evolved inferoposterolateral MI on September 17, 2024 when she was admitted with us. And this is the X-ray. You can see acute pulmonary edema, classical picture. And then we called for the CD, and we took the old CD from that patient, and we re-examined it. We found that it was normal except for myocardial bridge in the middle eddy. Here, this narrow, narrowing is against atherosclerosis. Right side, it was normal. So this is the echo done by us. Patient has large LALV, and there is localized pericardial effusion in the basal inferolateral wall. And there is severe eccentric MR. LV function somehow looks very good, but there is localized pericardial collection. So this is the 4-chamber view. Definitely you see there is something fishy about this lateral wall, the mid part. Its movement is abnormal. And patient has severe eccentric MR. So taking the modified views, we try to look this lateral wall, and here is some echo-free space here. What is there? There must be something. So we move the probe still posteriorly. You can see. This I did from the other machine. So you can see there is large the posterior aneurysm which has gone to the apex and looks like apical aneurysm. There is pericardial fluid here, definitely blood, it is present here. And then we did 3D, and here we suspected there is some thrombus also. These are more pictures. You can see the narrow neck of pseudoaneurysm on 3D. Some more pictures. So this CT chest was carrying by patient already. So we reviewed it. It showed bilateral pleural effusion, cardiomegaly, mild pericardial effusion, small mediastinal lymph nodes, and a few atelectatic bands in the lower segments. So the summary of this patient is having Minoca. She had Minoca when she had chest pain and MI with inferolateral MI, severe MR and heart failure. Pseudoaneurysm was defined better by 3D and in regard to neck and thrombus. And this was a contained rupture with pericardial hematoma. Plan was to do the aneurysectomy and mitral valve repair or replacement, what was the surgeon's choice. She was operated on September 24, 2024. And this was the operating picture. You see this large aneurysm which was dissected out and dose procedure was done. And this is the post-op picture of this patient. Surgeon did a MVR with bioprosthesis and aneurysectomy was done, repair was done. You can see there is some amount of collection here left, but otherwise there is no MR. I'll show you. There is no MR and patient is much better. So a recent retrospective analysis of patients with from equity study involving 13,800 patients with moderate to high risk cases who underwent coronary angiography within 72 hours showed that compared to non-STEMI and CAD patient, Minoca patient had higher risk of 1-year mortality associated with an increase in non-cardiac deaths. In Virgo study conducted on 2,690 patients focused on young presentations less than 55 years, Minoca had a comparable prognosis at 12 months compared to patients with MI with CAD and was more prevalent in women. This is Swedish Swedheart registry study conducted on 1,99,163 patients with first MI presentation, which showed that 23.9% of the Minoca patient developed major adverse cardiac events over 4 years of follow-up and a total mortality rate of 14%. Thank you. These were 2 short cases I wanted to present.
Thank you.
Yes, yes. This.
Disease. Can you go back?
Just now.
I think that was missed by everybody. Yeah.
This was your first case, second case?
No, second case.
Second
Can
case.
you connect? It's not connected.
I'll just reach there.
Go back actually, just keep going back.
Yes.
Yes,
Now?
we have also observed that.
You show?
No, just go back.
Go back?
Yeah,
Okay.
go back on this. Slides. Go
Slide.
back on the slides.
Okay. Which one you want to say?
No, you are not showing the slides to us.
No, I am showing slides to you.
See there. Then nothing
It's
is
not
showing.
coming there. No, I did not see there, sorry, but I was showing.
I have a definite feeling we shouldn't be labeling it Minoca. It is a small OM which is causing this
नहीं,
huge
second वाला
problem.
case है. Second
This
case
huge
दिखाना है ना.
problem being caused by
नीचे
the-
आ जाओ.
I'm not too sure actually that that is the
And practically one of the cause of Minoca is a spontaneous opening of the thrombus.
Yeah.
So
that could be SCAD also, but although SCAD is more described in right
number
coronary
one
artery.
and number two, there might be some
This one?
spasm.
You wanted it?
No, where is the picture here?
Slide
Show
में
us
है
the
ना उधर.
picture. Yeah. Now this one. Oh no. Yeah. No. Yeah. This one. The left one. Left one. Look at the terminal OM. Terminal but one OM. See that? Where it is bending. Where it is bending. There is some obstruction. Maybe it is not. It's not occlusive. We agree it is not occlusive. Looks hazy. Part of the reason it could be hazy is because it is bending because of systole. It's bending because of systole. My feeling is that such lesions are usually missed actually, and they are labeled as.
regarding the first case, I would like to comment that when you are suspecting perforations, it is not very important when the perforation occurs in the atrium due to pressure, but it is definitely important when it involves the LV or more or less commonly the RV. So I would like to prefer, as the patient is dying, so why we have not put the dye in the LV to see the perforation. That will be the very
it took fractions of second and she died. I was called at that time. I put dye, but
so
it was
that
there was
could
no
have
any
been
time.
detected the perforation and go for emergency surgery for repair.
But this patient didn't give any time.
And this case also is the second case is also very interesting. It is not very apparent that a small vein branch can
sir,
cause such a catastrophic until it is perforated. Some guide wire has gone it and it has perforated, and it is not very obvious, but it is not very apparent that this small branch occlusion has got. But one of the cause of Minoka is small branch obstruction, which is many times missed in the routine coronary angiography. So with this, should we go to our next presentation? Thank you, Dr. Madhu.
Okay, sir. Thank you.
Dr. Anil Singhi. Welcome, Dr. Anil Singhi.
Pleasure to be here in Ezecho, very close to my heart, and thank you everybody. I wish to show a rare complication of something unexpected. 41-year-old lady had a history of abnormal uterine bleeding, and she was scheduled for uterine surgery, hysterectomy, and during pre-anesthetic checkup, large AHD was diagnosed with significant left to right shunt. So because AHD was there, she was sent to me, and I evaluated, found a very large secondum AHD with thin floppy posterior inferior margin. Total thick to thick dimension was 44 millimeter. So I gave them choice that we can attempt transcatheter closure. If it's not successful, then can go for surgery. So during cardiac catheterization, pulmonary artery pressure, LVDP and CAG all were normal. A 48 millimeter AHD device was implanted in a newly described technique, a device-assisted device closure technique, where another device was helping to allow the intended device to fall in place. The assisting device was a 24 millimeter additional occluder. And the device looked good, no residual flow, though there was some bulkiness which we noted after the release, but device was very stable. We released it. And in 1 and 3 month follow-up, she was on dual antiplatelet. The device was good, no residual, and symptomatically she was anyway asymptomatic from cardiac standpoint. And we are very happy to get that our innovative technique published in Cardiology in Young, where device-assisted device closure of a 20% series. But the story is not end. 3 months after the procedure, she had worsening of the uterine bleeding. Clopidogrel was discontinued by the local physician, and she came to us. We explained that she should undergo hysterectomy with periprocedural low molecular weight heparin, but family was not very keen. The reason, there was a major cardiac surgery done, so another one will happen after 6 months. That was the notion of the family. So 5 months after the AHD closure, she developed fever with chills. Patient was admitted in another hospital. She had leukocytosis, elevated CRP, or she was given empiric antibiotic, fever persistent. Initial blood cultures were negative. And at that point, because there was a cardiac evaluation, cardiac intervention done earlier, echocardiography done, and it showed echogenic mobile tissue attached on the inferior aspect of the device. So the initial diagnosis from the referring hospital was whether it is vegetation or thrombus. So she was also put on low molecular weight heparin, anticipating it can be thrombus. So she was referred to us. The bystanders were very apprehensive that it is possibly device related. A patient was toxic, febrile, but peripheral sign of infective endocarditis was not there. She had, we confirmed, having leukocytosis, CRP, procal, ESR, all were sky high. So in the echocardiogram, we were surprised. I never saw. I never heard also. ASD is a lesion. Usually we do not get vegetation, but she had multiple vegetations like structures attached to the inferior aspect of the ASD device and tricuspid annulus. They were frightening, but all were restricted to the right side. We have not found anything on the left side. So heparin was discontinued because it looked like it is a case of infective endocarditis, and she had bleeding also. We were unsure why this has happened because it's extremely rare. So multiple blood cultures were negative. She was put on an empiric therapy for culture negative endocarditis. Persistent fever, ongoing vaginal bleeding. So the concentration went to evaluating the uterine segment, and that was our surprise. Abdominal MRI showed multiloculated complex bilateral cystic lesion in the adnexa. There was tubo-ovarian abscess. Both sides, left was large. So the red arrow is pointing towards a left-sided adnexa lesion having fluid level. In addition, there was endometriosis and multiple fibroid. So combined meeting, urgently she was sent for hysterectomy with bilateral salpingo-oophorectomy. I went inside theater and was surprised to see 150 ml of pus was drained from the abscess, and it was so large left side lesion, surgeon could not take out directly. He had to chop out in piece and the whole uterus removed. There was multiple fibroids and histopathology was consistent with this diagnosis. Still, all the levels came down of anti-inflammatory. She was little better, but still persistent. The vegetations were there. So we again discussed, and this is the first case I saw where surgical explantation of the device was done 5 months after the procedure, something which is unrelated to the basic procedure. The surgeons showing the vegetation which was attached to the inferior surface and also to the device. So 8-week IV antibiotic, she recovered completely, and now 6-month follow-up, she is doing extremely well. No symptom from both the component got treated. And now this is exceptionally rare. Endocarditis following ASD device. It can be immediate due to procedural contamination, which is not the case. But hematogenous late seeding, foreign body is one of the risk factor, which can be nidus, but report says the incidence is extremely low, 0.001%. So while endothelialization is expected in 6 months, but it can be delayed. And this delay endothelialization may increase the risk for this infection. In fully endothelized patients also it has been reported. So incomplete endothelization per se will not explain the whole issue. Additionally, it is thought that polyethylene membrane may promote fibrin platelet adhesion. Nickel in the nitinol may induce some allergy, some sensitivity, and intimal formation may get delayed. Some residual shunt, some bulkiness, which was our in case, the device bulkiness, may produce, these are all hypotheses. And septicemia and abscess formation anywhere. So it is a very challenging case, very important for clinician to suspect and do a detailed evaluation. She had not allowed us any TE because she was very sick. In transthoracic it was so good, so we have opted out. Prolonged antibiotics, serial monitoring, and inflammatory marker blood culture. So surgical removal is required in perforation, dehiscence, fistula formation. Patch repair from the homograft is the best, and alternative is bovine pericardium. And 70% of the patients require such explantation. It requires high index of suspicion, multimodality approach, and rethinking our strategy, how long we should give dual antiplatelet therapy. Long-term follow-up and vigilant monitoring is essential. Thank you.
Thank you, Dr. Singhi, for excellent presentation of this very, very rare case. I think all of us agree that infective endocarditis on a ASD device is extremely rare. The only thing I just want whether there is any pathology correlation between this pelvic abscess or pelvic infection with this ASD
Yes, yes.
device infected.
This
Only
is
things because this is the message that if there is any infection in the body,
we should not do
we
any
should,
procedure.
not defer, but as this is not a very emergency procedure, so we should defer until the infection anywhere in the body is properly controlled.
Two things, sir, very excellent point that came to my mind also. So while reviewing the literature, she had no sign of infection at any point. Till 5 months, she was fine. Endometriosis is a notorious lesion known for. So she, in spite of our repeated request, actually she came to us for PSC. So after device closure 1 month, I told, please go ahead. So if it was done in timely manner, possibly it could have been avoided. So it was the endometriosis which got infected, which got abscess and then spread. And that's what, and we are happy to tell, I wrote and it is accepted and possibly in couple of weeks time will come in circulation.
So this should be our message that
very alertness, sir. This is a frightening, sir.
So,
treating.
We should search for any focus of infection anywhere in the body before we go for an elective device closure. And any comment from
may I ask a question?
Yes, sir.
Yeah. Anil, nice case for us, but very bad case for the patient. Yeah, 2 major surgeries.
No, for us also, sir, it was very difficult for me to treat.
Any culture material obtained from the pus, not from the blood?
All were negative, sir.
All
were negative. The problem was, whatever culture sent from whichever site, it was maybe initially itself in the treating time, wide spectrum antibiotic was started. So we were, say it was bad, but...
My hypothesis is that multiple device was a hindrance towards the proper endothelialization. You may be
see, multiple thing was possibly, but at the end of the day, it's a challenge and that's why the patient is here.
Thank you.
I got one question.
Yes,
endometriosis is not infection.
No.
So if it is a nidus or a soil for infection to grow, then you have to completely treat that endometriosis part and then go for a device closure.
No, so very nice question, sir. We given that option. The PSC clearance, they wanted ASD to be sorted out. So which should be done first? At that time, she was not infected. So we told immediately after the device closure, she is absolutely fine to go for endometriosis surgery in the next week itself under this cover of heparin. The bystander were not ready, and here we got enough time to do our hysterectomy. 5 months, sir. So this is something extremely rare. Everything were not in our favor. But good that she is doing extremely well. That is the only thing we should be cautious.
If the ASD is asymptomatic, if there is no gross pulmonary hypertension, then as per our SEC or AHA guidelines for preoperative fitness for non-cardiac surgery. So I think there is no contraindication.
No, there is no. They were not keen. They were not keen.
It is the problem of the anesthetists and surgeons. They do not open.
No. Everybody had the bystander were not very keen to get. After knowing heart disease, they were not very keen to get it done. So I will not say one group. It is that collective decision making which led to first do the ASD and then...
Maybe so. You remember, you did a TE on my patient. We did a...
RSOV.
RSOV.
Yes.
The patient present with failure, with fibroid. And after we diagnosed the RSOV and treated the failure by device closure, the patient refused to get the uterus operated.
That is that mindset, sir. Once a big cardiac surgery is done, mindset of the people that will get the second deferred. Anyway, thank you.
Thank you. Dr. Devdatta.
Good evening, respected chairpersons, the dignitaries in the audience, and the august gathering. Whenever I see or suspect a case of Kawasaki disease, I feel that I'm one of those 6 blind men trying to decipher the elephant. So our first case was a 9-month-old male baby who had only fever for the last 11 days. The other systemic examination was completely normal, and there was a non-specific red lips and rash from day 5 to day 7 of illness, and then it disappeared. On suspicion of KD with high platelets and CRP, we had done the echo, and it showed giant aneurysms in the LMCA, LAD, RCA, as well as a moderate aneurysm in the LAD. And what was very worrisome was this large bit of thrombus sitting at the LMCA, just at the bifurcation. So we had started the IVIG, infliximab, and also the anticoagulants. But we were also surprised to see, even after that, on day 3, there was progression of the thrombus with a lot of sludge lying on the bed of the LAD as well. So we did a bit of literature search, worrying that whether we were giving adequate anticoagulation, but we found that unfavorable flow mechanics and decreased wall shear stress may cause the thrombus to progress in an aneurysm despite adequate anticoagulant and antiplatelet therapy. There was also a fusiform aneurysm in the RCA, proximal RCA, and this is a brief recap of how we classify the aneurysms, 3 to 5 being around small aneurysms, 3 to 5 Z-scores, absolute values also 3 to 5, 5 to 10 Z-scores, absolute values 5 to 8 being medium, and large aneurysms will be more than 10 Z-scores with an absolute value maybe of 8. So we had started the primary intensification with this horde of medications, biologics, etc., according to the last 2024 AHA guidelines on KD. We did the ECG echo, the enzymes to monitor the baby, but unfortunately we couldn't monitor for the low molecular weight heparin. But fortunately for us, the thrombus decreased, and finally the child was thrombus free after a few weeks, but we had to continue the low molecular weight heparin till then, till we got a CT angio done. The CT angio was done in collaboration with PGI Chandigarh, and they showed that that it was around 9 weeks after therapy that the child had a bulbous LMCA, but it was totally free of thrombus. So these are the signs and symptoms of KD. And nowadays, fever more than 5 days, that is sort of a warning to us that we should do an echocardiography to rule out any aneurysms. The bulbar conjunctivitis, the strawberry tongue, the red lips, maybe non-specific signs, cervical lymphadenopathy, extremity changes like periungual desquamation is very, very specific when it appears on the 2nd week of the illness. Dr. Tomisaku Kawasaki, who first described the disease, and his legacy is carried on by Professor Shurjit Singh sir from PGI Chandigarh, who has inspired us all to delve deeper into the disease. And this was another very frightening giant aneurysm in a 2-month-old boy who had just fever for 15 days. Huge bulbous aneurysms in the LMCA and the LAD as well. And absolute values 13 and around 10. The RCA was also having a huge aneurysm of 5.4. At that time, the primary intensification was not there. This was 6 years back, so the giant aneurysms are still there and they maybe have come down to moderate. And the child is still on anticoagulants and aspirin. Just in this case, suppose we shift in the apical 4-chamber view, in the 5-chamber view, if we shift anteriorly, this is where the LAD may be seen sometimes normally. And in this child, we were very surprised and shocked to see this huge structure that was coming down, just parallel to the aorta. And this was actually the LAD, which was aneurysmal along its entire course. This was another very scary case of a 7-month-old boy presenting with shock and severe dysfunction. The child had severe MR, and nowadays it has become a dictum in pediatric ICU. Whenever I do the scans, I always look at the coronaries to rule out any KD shock syndrome or HLHS. So this was a right coronary artery, and there was a fair bit of flow acceleration over here. And when I took the velocity across it, the mean velocity was quite high. It was around 6, suggestive of a stenosis. Unfortunately, the child was too sick to go for the CT scan, and we lost the child on day 3 of admission. And here we can see, later on I showed Dr. Sudha this case, who has done a lot of research on long-term follow-up of KD in Japan. And she said that Kawasaki disease does involve the endocardium as well, in addition to myocardium and pericardium. So some red flag signs for imaging the coronaries, that is, we should not take the pericardial sinuses, we should identify the myocardial bridges or an anomalous origin of the coronary arteries. And two other interesting, just touching base on two other interesting cases. 11-year-old boy who had been treated with most of the features of KD came to me on a follow-up. But on that first week follow-up, I found this huge thrombus sitting on the septal wall of the RV and this ectatic LAD. So the child had to be readmitted and we had to start the anticoagulants. This was another case of a 9-year-old boy with pus aspirated due to septic arthritis. And this was the ST segment elevation present in the ECG throughout because of the pericardial effusion, which also had thick strands from it. But the consultant was actually not believing me, but I had to show him the echo that this was the state of the coronaries, huge giant aneurysms of LMC and LAD. And on follow-up, they took a sort of a serpiginous course. So a few words about CT angio, because CT angio has become compulsory in the new guidelines of American Heart Association, that at least once it should be done in the course, preferably after 1 year. But if it is a giant aneurysm, may be done earlier, around 2 months after the disease. And this was we were suspecting a stenosis over here and this ectatic LAD, and these are the CT angio pictures. Here also we were suspecting an ectatic stenosis at the origin, but actually there was no stenosis. So essentially we need to complete this with the CT angio, which helps in identifying the distal aneurysms, multiple aneurysms, stenotic lesions, thrombus, as well as left circumflex lesions are very well seen in CT angio. And these are landmark papers from PGI group, mainly Dr. Singh and Dr. Singhal, who had proved that CT coronary angio is an essential to delineate the coronaries in Kawasaki disease. So my understanding was that KD involves all parts of the heart, not only coronaries, myocardium, pericardium, as well as endocardium. And these papers have proved that with or without coronary aneurysms, KD involves the myocardium in the form of a decreased global longitudinal strain. Circumferential strain is not that involved. So we evolve into the landscape of cardiovascular imaging in the long-term follow-up of KD, involving the MRI and SPECT as well. And just to end with this, that exercise stress test in these children, even 6 years, 10 years, 14 years after the original disease, this study picked up these patients, and then they found that there was stenosis and aneurysms in those who tested positive in the exercise stress test. So points to ponder: we should identify children at risk, that is those with coronary aneurysms more than 2.5 Z-scores at 6 weeks of age. And this has been proved by extensive studies in USA, multiracial as well as through all ethnic groups. And symptoms of MI are very non-specific in children. They can emulate or simulate any other infection. So we need to we were in the last meeting in the Indian Society of Kawasaki Disease, it was actually a thought that we should give them a card saying that this child had got Kawasaki disease sometime, and hence when they come to the emergency with these symptoms, we should do further tests in the point of care tests, cardiac enzyme stress tests, etc. So I leave you with this thought, because these children will grow up one day, and there is no definite way to hand over these children in the adult clinic. So these are my fangirl moments with none other than Professor Singh, Dr. Surjit Singh sir from PGI Chandigarh. And this is Ms. Suburo Kawasaki, the daughter of Dr. Kawasaki. Thank you.
Thank you, Devdatta, for your excellent presentation. Majority of adult cardiologists are not very acquainted with the Kawasaki disease, with their cardiac and coronary involvement. Only thing I request you to share with us, have you any long-term study with this Kawasaki disease, as special reference to their coronaries, so that when it is landed into the adulthood, we can take up these are the coronary from Kawasaki or from other. As we know that in our country, Takayashu may have some coronary involvement and with some aneurysm as well as stenosis. Here we also get, but when we get an adult patient with aneurysm and stenosis, it's very difficult to assess which group this one. So we request you to share any long-term study of this Kawasaki coronary involvement.
Sir, extensive studies have been done in Japan by Dr. Sudha, primarily by Dr. Sudha. She has done extensive studies and she has done angios in extensive on all these patients in long-term follow-up of Kawasaki disease. And it was her studies which also brought into light that many of these children have required coronary bypass surgeries as well, in addition to coronary and invasive procedures, coronary angios and balloon angioplasties. And it was these extensive studies done abroad, especially from Japan, which actually prompted them to bring into focus the point of care tests for long-term follow-up of Kawasaki disease. There was a GIAN, that was a global initiative in academic networks in PGI Chandigarh. It was held for the second time in PGI Chandigarh this year in March. And Dr. Sudha came and discussed these studies with us. And as far as I am aware, long-term studies are not there in the Indian scenario, but they're working on it.
Any from the floor? Any question from
Could patients with Kawasaki's disease be untreated or undiagnosed and present in the adult life? Or do they develop complication at a younger age and it's not possible that they would present to us at the age of, say, 20, 22 years with chest pain?
Sir, as far as I know, 25% of them without any treatment will, classically we know that if we don't give IVIG, then 25% of them will develop aneurysms. But that one more thing is that we have found that they are more dangerous in the infants. Most of the cases I showed here were infants and they developed aneurysms it's very common in them and very commonly overlooked as well. They have their whole life in front of them. So that's why the cause of long-term follow-up was there.
The reason why I'm asking this question is we seldom think about Kawasaki when we come across a patient with chest pain and has perhaps some coronary artery disease. We think about Takayasu or we think of other conditions, we just probably ignored them. But is it possible that
no,
a patient...
sir, in the long term it will be difficult unless you have a definite history. The initial acute phase, the inflammatory markers will be high, etc., and they will come down. But what will happen in the microvasculature in the long-term follow-up, we do not know. We are seeing the outside of the coronaries. We are not doing OCT in every children. So we do not know what is going on in the inside of the coronaries. It is quite impossible to delineate that way.
We have seen a lot of young myocardial infarction between the age group of 25 to 35 inches. Is this group of myocardial infarction could be we are always telling this LDL is high and everything is high. Could it be due to the previous coronary artery disease? Because many of the time you may not get the history of the coronary artery disease being treated or not treated.
Absolutely, sir. Actually, they are thinking that these are probably due to KD.
We can find it.
No, not that I am aware of, sir. Probably, but that's why we need a proper follow-up kind of thing.
Excellent presentation and so many questions I wish to add on. 10 years ago from Chennai MMM, we published a case of 58-year-old gentleman who presented with some symptom of coronary and we found giant aneurysm, narrowing and inside thrombus. It was published, the case. The Kawasaki disease in picture possibly for 40 years, but that gentleman was 10 years ago, 58 years. So before Kawasaki coined the term Kawasaki, the disease was still there. He discovered. It is not that Kawasaki disease started from the day he told first disease. So there are multiple patients in the cohort, in the large population, where these diseases in different form present, and quite possible they are presenting with stenosis, aneurysm in combination. Stenosis is more common than aneurysm and thrombus. So as sirs were telling, very vigilant look for getting Kawasaki still can be present. We don't know the history. It was undiagnosed but presenting late. So alertness, sir. And that study what I am telling was published in Annals in Pediatric Cardiology 10 years ago.
So,
yes, that exactly. That's the point.
So thank you. So take-home message should be every Kawasaki disease we want handover from pediatric cardiologists, which one is a significant coronary artery involvement, even the myocardial or endocardial involvement, so that it could be well dealt with in the adult life, including any coronary events. Thank you.
Thank you, sir.
So we should call our next speaker, Dr. Kaustav Biswas.
Good evening, respected chairpersons and members of the audience. Well, I present this unusual case, a patient presenting with second-degree AV block with an history of syncope, repeated syncopes. It's a 61-year-old male patient and known hypertensive and diabetic, presented with history of syncope. ECG showed, and subsequent Holter monitoring showed second-degree 2:1 AV block. Electrophysiology study showed significantly impaired his Purkinje conduction with baseline 2:1 AV block. We are going straight away to the echo clips. In the aorta, just anteriorly, we can see the hint of a tubular structure. More apparent in this, over here. Here also, we can appreciate it. Good LV systolic function. The septum is well contracting, but slightly echogenic. And you can see the echogenic cordia and the papillary muscle. We can see the dilated left coronary artery, and there is a turbulent flow in the pulmonary artery. Similar clip. You can see the right coronary artery, the pulmonary flow, mitral flow, tissue Doppler showing raised LAP with 16 EY prime, ejection fraction around 60%. This is what we see is the RAC sign. We see the retroaortic coronary. And here we can also see the echogenic papillary muscle and the more close view of the RAC sign. So this gives an impression of anomalous origin of coronary artery. And here, if we look closely, within the septum, we can see tiny color flows indicative of the collaterals. Here it's So echocardiography showed concentric LVH, absence of RWMA, normal biventricular systolic function, grade 2 LVDD with E by E prime of 16.1, echogenic papillary muscles, turbulent flow in the pulmonary artery suggestive of retrograde flow from the left coronary artery. But then left coronary artery that appeared to be arising from the left coronary sinus. That is the unusual part. Then there is dilated RCA, which is actually the tubular structure I was showing in the plaques view in the anterior part. Then prominent collaterals in the IVS and RAC signs suggestive of anomalous origin of coronary artery. Coronary angiography revealed anomalous origin of left coronary artery from pulmonary artery and dilated right coronary system, right coronary artery supplying the left coronary system through multiple collaterals. Patient underwent permanent pacemaker implantation and was discharged in hemodynamically stable condition. So this is adult Alcapa is extremely rare. Alcapa is occurs, as you all know, it's 1 in 3 lakh live births, and usually the prognosis is significantly better in this adult patients than in those who present in childhood or early adulthood. And that is because of the well-developed collaterals, of course. And RCA is usually dilated and supply the left coronary system through collaterals. So the main point is that no detection of coronary ostium in the appropriate sinus, while the echogenic opening of coronary artery and blood stealing phenomena at the pulmonary artery can be observed by the echo imaging and the color flow imaging. But here, something else, actually the left coronary artery in Alcapa patients usually originates from the left posterior sinus of the pulmonary artery. And only a small number of them, it may originate from the right posterior sinus. And when the coronary artery ectopically originates from the right posterior sinus of the pulmonary artery, a 2D transthoracic echo will give the illusion of the presence of the left coronary artery at the left coronary sinus. However, a reverse blood flow signal through the pulmonary artery in the left coronary artery will be detected by the color flow imaging. So that is what occurred in this particular case, and which is why this is so. This is an unusual case of adult Alcapa, and the finding that it showed it gave the illusion of it's coming out from the left coronary artery, left coronary sinus. That's because of this origin from the right posterior sinus of the pulmonary artery. Thank you.
Thank you, Kaustubh. You are very old, known person. Thank you for your good presentation. The adult Alcapa.
Adult Alcapa.
That is your uniqueness of the case. But one thing, you know, Alcapa usually presents with myocardial ischemia, even in the childhood, rather than heart block. So in that case, revascularization is the treatment of choice for Alcapa rather than putting pacemaker. So your job is to detect the Alcapa echocardiographically. That is very nice. And it is corroborated by angiography, which you have corroborated that there is some other anomaly, unusual anomaly. So that part is very okay, but unusual thing is that he should not present with 2:1 AV block, rather without myocardial ischemia. So that is the thing.
Yes, sir.
I like to have your comment.
Sir, I believe that, though the right system is feeding the, the right coronary artery is feeding the left system through multiple collaterals, but even then we are seeing that, that the septum is echogenic, and as we saw in the electrophysiological study, there was gross suppression of the His-Purkinje system. So perhaps there were multiple ischemic insults which resulted in the fibrotic change in the conduction system as well. And
basically, it is the left to right shunt.
Yes.
In Alcapa, it is the basically left to right shunt.
Yes, sir.
So we have to, anyway, even we put the pacemaker, we have to close the primary.
Yes, sir, but the patient refused. True, sir.
Yes, that is.
Actually, the same thing I was going to ask, because
yes, sir.
we have seen in the children, even 6 months old baby often dying of MI. Takeuchi's operation is one of the operations that was suggested at that time. But in an adult presenting with, we don't know whether what is the age of the patient?
61-year-old, sir.
So whether it was a degenerative or ischemic process of the conduct system, it is a conjecture one, whether it is ischemic
Could
or
be, sir.
degenerative. Because you are trying to say the hyperechogenicity of a few regions is due to ischemia. We could have other modalities to show that these regions were really infarcted region or ischemic regions or not. But finally, something about the coronary artery anomaly should have been done besides pacing. But as you said, they were not ready.
No, because he said he's living a perfectly productive life. He refused any intervention.
It's fortunate that he didn't have major ischemic assault.
Very true, sir.
One question in my mind. Actually, is this patient in this age, does it require really the correction of the L kappa? Because of the collaterals, he is living without any myocardial, there may be some myocardial ischemia that can be done only in the CMR. But so far in the echocardiography, there is no gross abnormality I could have seen in this particular patient.
That is true for all left to right shunt. Be it ASD. If you detect a ASD at the age of 60 or 65 years without any hemodynamic compromise and with a functional class 2, so probably it does not require any correction. So it is applicable to all left to right shunt which has tolerated 60 or 65 years. So that is not the issue. What the issue is, I think the echocardiography has, the take-home message I should say,
yes, sir.
that echocardiography can pick up the coronary anomalies. That is number one message. And number two message is, yes, L kappa or coronary anomaly may present even in the adult age group.
Yes, sir.
So we should leave aside the management part or other thing.
No, actually, it brings on the only doubt that whether the LV was still ischemic or not. Because fortunately, here it was bradyarrhythmia corrected with the pacemaker. But if there is ischemia, there are chances of sudden ischemic death due to tachyarrhythmia. That's a major issue. If this patient is non-ischemic, documented, yes, you can leave it alone.
You can contemplate doing a cardiac CMR. That will tell you the extent
True, sir.
of
Absolutely.
infarcts, yeah.
Yes, sir.
Okay, any other question?
Okay, thank you.
Thank you.
Dr. Vignesh Rajendran.
Good evening, everyone. Today I am going to present my case. It's a case of giant right atrium. A 39-year-old male, non-hypertensive, non-diabetic, and non-smoker. His only complaints was dyspnea on exertion for 6 months. An atypical chest pain for 6 months. No family history of sudden death. Examination is normal. Body surface area is important. We will come to know why. 1.64 centimeter square. ECG was normal. Non-specific fragmented QRS in lead 2 and AVF. Chest X-ray revealed cardiomegaly. Echocardiography, it showed a giant dilated right atrium. Left atrium was compressed. So left ventricle was normal. Aortic wall, Doppler, mitral color Doppler, left PSAX view, and everything showed a left ventricle. There was no regional wall motion abnormalities. Diastolic function was normal. So the left ventricle EF was 62% around. Left atrium volume was 19 ml. Index to body surface area, it is 11 ml per meter square. The normal value is around 16 to 34. The left atrial volume was reduced because of the dilated right atrium. So we'll come to the right heart. So I would like to mention here this paper. This is the very recent paper on guidelines for the echocardiographic assessment of right heart in adults. It was published in 2025. So the difference between LA volume assessment and RA volume assessment is that in RA volume, we can't take a apical two-chamber view for RA. So they say that we can use either the disc of planes method or single plane area length method. As the right atrium is enlarges asymmetrically, the single plane method is not so accurate, but still we can use it. Cardiac MRI and 3D echo is accurate for the volumetric assessment of right atrium. So this is the thing which they have told in the paper. Since a standard orthogonal plane for RA is not available, to enable biplane volumetric assessments, volumes derived using single plane method can be used. So we used the same thing. Right atrial volume index in our patient was 0.85 into area square divided by length. So which turned around 98 ml per meter square. So our patient's RA volume is 98 ml. The normal the RAV index is less than 33. More than 44 is considered severe. RA major and minor dimensions, both were elevated. RA area is enlarged. RA area in our patient is 37.8. So the normal RA area is less than 19. Right ventricle was normal. So right ventricle function was also normal. We measured the TAPC, tissue Doppler S prime and a fractional assessment. The fractional area change. Fractional area change was around 42%. Tricuspid wall, the anterior leaflet was bit sail-like and there was mild tear. Pulmonary wall assessment was normal. Pulmonary wall was normal. So our echo findings showed the normal sized left atrium and left ventricle with normal LV systolic diastolic function. The only abnormality was right atrium was enlarged with mild tricuspid regurgitation. So the evaluation of right atrial enlargement, we need to rule out ASD, PAPVC, TAPVC, abstains, pulmonary arterial hypertension, pulmonary stenosis, and rarely tricuspid stenosis. So we were ruling out. T revealed no evidence of ASD. IAS was intact. No evidence of abstains anomaly. The insertion of tricuspid septal leaflet, mitral leaflet were 3.65 mm per meter square in our patient. So CT pulmonary, we did CT pulmonary angiography which ruled out PAPVC and TAPVC. No evidence of PH, PASP was only 24. No tricuspid or pulmonary wall stenosis. Cardiac MRI revealed no fibrosis with only right atrial dilatation. So this gives us an entity. This is a very rare entity. This is called idiopathic right atrial dilatation. So other investigation, Holter monitoring yet to be done. He has one daughter and one son. Family screening is yet to be done. So idiopathic dilatation of right atrium, from the literature, the diagnosis is based on two essential criteria. The number one is disproportionate enlargement of right atrium, and the second one is exclusion of all cardiovascular lesions. So the rarity of diagnosis, the case was first reported in 1955 by Bailey himself. So he saw a 29-year-old woman with cardiomegaly, mild effort dyspnea and paroxysmal arrhythmia. At thoracotomy, enormous dilatation of right atrium was found. He excised the lesion and the the symptoms were relieved. Bailey suggested that this is a congenital enlargement. So till now in 2020, only 153 to 160 cases were reported. Etiology it's an issue, whether it's congenital or acquired. But mostly they say it's congenital because the age of diagnosis is young in adult age and mostly juvenile cases are seen. So this is the paper published in 2020 from China. It is the analysis based on, meta-analysis based on 153 reported cases. So they say the least age they saw was 18th week of gestation by fetal echocardiography. The oldest case reported was 77. Mean age was 4 years. Slight male predominance. About 1/5 of the patients presented because of finding during antenatal diagnosis. Nearly half presented due to development of symptoms. The most common symptoms are arrhythmia, dyspnea, and palpitation. ECG data, only half had abnormal findings. Supraventricular arrhythmia, including supraventricular tachycardia, AFib, and atrial flutter were more common. Complications: arrhythmia, embolism, and right heart failure. Sudden cardiac death was reported in 6 patients, primarily due to refractory arrhythmia, right heart failure. Only 1/4 were accompanied with other anomalies like patent foramen and atrial septum defect. Treatment, so far no consensus has been established over the treatment. So the options are watchful waiting, medical management, thromboprophylaxis, antiarrhythmics, ablation for refractory arrhythmias, diuretics in right heart failure. Surgical management, it varies from atrial resection to atrial reduction plasty. To prevent post-resection dilatation, the external reinforcement of lateral wall of right atrium with autologous pericardium might be done. So at present, the patient was put on antiplatelets and is awaiting Holter, and his genetic screen, he refused genetic screening, and his family needs to be screened. Thank you.
Thank you. You have presented a very rare case. Yes, you go.
You have searched the literature extensively. So is there in NTD on the isolated right atrial cardiomyopathy? Because there are a lot of patients with the left atrial cardiomyopathy there we now entering. And second question is that, is there any role of the right atrial strain in the literature in this particular type
no,
of
sir.
patients?
Right atrial strain, they have not given anything in the literature. Atrial cardiomyopathy, they have released a paper from, it's a consensus of ACC EHRA paper. That is a paper to define about atrial cardiomyopathy. But they have focused fully on left atrium and atrial fibrillation. This is the condition.
Jignesh, right atrial cardiomyopathy is a known entity, rare though.
Rare.
But whether did you try to tissue characterized by MR or similar imaging technique? Because echo is good enough for dimensions. But tissue characterization is not that much sensitive specific by echo. So whether you thought of any
in
other...
MRI there was no fibrosis was reported. In the literature, they have sent the patients who underwent surgical excision, they sent for sampling. They reveal only non-specific fibrosis, but no specific...
No, actually muscle loss is there.
Yes.
Muscle tissue is less than fibrous tissue replacement is there. But in this it was not documented. Okay, let us see. Thank you.
No, sir, in our case it was not there. We did LGE.
Okay, you did it.
Doctor, we actually, if you have such case, and if there is a torrential TR, because you are telling that cell-like anterior mitral leaflet, actually we have done such case, we must also look for a RSOV into RA and a Jarbot defect. Actually, though this does not apply to your case because you have worked it on extensively, but the worst thing, you must think about two things. Yes, sir.
I looked at the pictures you had shown. I have a feeling that there is a slight hypoplasia of tricuspid annulus as well. It's not bigger than the mitral annulus. So despite RA being so big, the tricuspid annulus is smaller than the left atrial annulus.
Yes, sir, the literature which they have shown, all the cases they had mostly the anterior leaflet is like in Epstein, but the apical displacement is not seen.
No, I'm saying the tricuspid annulus is smaller, that's what I'm saying. Incidentally, not about the right atrium, about a year back, Dr. Parashar asked me to have a look at one of the patients he had sent. This patient actually had a single disc mitral valve prosthesis some 30 years back. Patient was in sinus rhythm, and we did a free CT on him. I just want to tell you that the size of the left atrium was 19 centimeters width-wise, and the anteroposterior it was about 10 centimeters. I thought this was giant left atrium. I'm not talking of right atrium. So when we reviewed the literature, there was one paper from Turkey who described same size of left atrium, and still the patient in sinus rhythm. And there was another presentation also. So I think this doesn't look giant at all compared to those cases actually which we had seen. Although as such RA and LA size are equal.
Yes, sir.
Yeah, thank you.
Thank you.
You have shown us a very rare case of isolated giant right atrium, and you have excluded the possible causes which are often missed, that is sinus venosus defect, unroofing of the coronary sinus, TAPVC and PAPVC, that should be ruled out before saying that this is a giant right atrium. And you have take-home message is this is a benign, relatively benign condition, only the part of some arrhythmia, accepting that it is relatively a benign. So thank you,
sir,
for your presentation. So we call our last speaker, Dr. Dipanjan Bhattacharya.
Good evening, everyone. I'll be presenting the case on behalf of Dr. Dipanjan. So here we are presenting a case of an adult who presented to us with atypical chest pain. So he presented to us a 36-year-old male, atypical chest pain unrelated to exertion, unrelated to food intake. He had no previously known comorbidities, non-hypertensive, non-diabetic. No addictions were there. He was slightly on the obese side, overweight with a BMI of 29, and general and systemic examinations were normal. Nothing significant was there. So we took the patient for an ECG, and this is what the ECG showed. Sinus rhythm with a with a slightly larger amplitude P wave in the lead 2. So X-ray showed no cardiomegaly. And we took the patient for echo. We could see a dilated IVC over here, and something was there which was abutting the right ventricular outflow tract. In other views, here we see clearly there is something that is compressing onto the right ventricle, and this is creating some degree of turbulence in the RV inflow. LV function was absolutely normal, and there was some gradient across the tricuspid wall, a gradient of 14/6 maximum by mean. So what we saw next was a mass was compressing the RV free wall. There was some RV inflow gradient, and the patient was having a good biventricular function with a TAPC of around 21 and RV S prime of 11. So then we sent the patient for MRI, and these are the MRI sequences. We could see that fat has been abutting the right ventricular outflow tract across all these images. And this is what was causing the obstruction. But since the patient was still complaining of chest pain, and angiography was not, conventional angiography was not functional at the center at that time, we sent the patient for a CT angiogram, which again revealed normal coronaries, and here we can see some degree of fat with some specks of calcifications. So we can see all the coronaries are normal. So we made a final diagnosis of epicardial lipomatosis causing mild RV inflow obstruction with good biventricular function and normal coronaries. Regarding the labs, anti-proBNP was normal at 120 picogram per ml. We discussed the options with patient. Generally, as it is a benign condition requiring no treatment, some case studies are there. In cases where it has caused a tamponade, that emergency pericardiectomy has been done. But regarding this patient, we have kept him in medical follow-up, and he has been doing well for the past 9 months. So regarding the condition, there is prominent variation of extensive fat distribution in and around the heart. Etiology is unknown. It is often seen associated with advancing age, obesity, and prolonged steroid use. A slight female preponderance is there, and it might lead to tamponade. One more thing is that normally it may be seen in old age patients. It is seen in the form of interatrial septum lipomatosis, and this presentation is rather rare. So this is some literature. So we can see that it can mimic a pericardial effusion, and at times it might also cause a pericardial tamponade. This again is another series, this is another case of a 68-year-old woman who was initially having ECG changes for that, that is why she was evaluated. She was ultimately found to have a dyskinetic RV segment, near the dyskinetic RV segment on cardiac MRI. On further evaluation, she was found to have an butterfly apex with epicardial lipomatosis. And this is another case series of 3 cases showing varied presentations. So it might present as a thrombus-like mass in the RVOT. It might present as a tamponade. It might be present as interatrial septum lipomatosis. So the take-home messages are that it is a closed differential of pericardial effusion that we have to keep in mind. It might lead to tamponade or any other chamber compression. Cardiac MRI with fat suppression is a diagnostic modality of choice, and decision on intervention or surgery is controversial. Not many large-scale studies have been done, so it still remains an entity that is known but not very well described. Thank you.
Cardiac MRI with fat suppression diagnostic modality of choice. Is much cheaper to do a CT. The house-filled units of fat are not matched by anything.
Yes,
you have minus 50 to minus 150. No other structure can ever give you fat, the house-filled units of minus 100, only fat. So you don't need MRI. So I disagree with the number 3, this thing. There is nothing actually. You can't make you cannot have a differential diagnosis once you do a CT. With MRI, you may still have differential diagnosis. And you don't have to do fat suppression images and spends that much of money. The only thing which I want to say is that there is a thinking going on in the literature that many patients of so-called HFpEF, obese individuals, are actually epicardial fat constriction, and that these people don't respond to diuretics or SGL2 inhibitors or GLP-1 analog. On the other hand, with weight reduction, actually their right atrial, left atrial pressures come down, the E2 E prime becomes normal. So it is being considered that the problem does not lie in atria and ventricle, the problem lies outside in the pericardial fat. And that may be one of the important reasons of HFpEF of the obesity. But that also you can pick up on CT much better. If you see a thick pad all around or at vulnerable places like atrioventricular junctions, right and left, then you can diagnose them to have this thing.
Thank you, sir.
It is a very...
I had a question. What in your that you've read about the other cases, what is the natural history? In the sense, do they progress?
Ma'am, since not many studies have been done, we only have sporadic case reports on it. I even searched the literature. I could not find much about it, apart from the fact that the most common presentation is that of an interatrial septum lipomatosis. So regarding the history, it is said that as the obesity, as sir just said, with greater degrees of obesity, there is higher risk, but the incidence or the progression or regression is not very well studied.
So all that you do is follow up the patient.
Yes, ma'am.
One thing you have done a good job to pick up a case of RV inflow obstruction in a case of chest pain. But why should be there chest pain in RV inflow obstruction?
Yeah, so that is why we even took the patient for angiography as a last resort, because the patient has been extensively taking PPIs and everything. Nothing had helped him for the last 6-7 months. So as a last resort, we did CT angio for him, which came out to be normal.
One thing, we have to give some take-home message that it should be included in evaluation of chest pain. Whether this chest pain is the angina-like pain or dilating pain, that should be very clear to us, and with that we can incorporate this in the differential diagnosis of atypical chest pain in the evaluation. So echocardiography is a very good thing to pick up this clinical, but before that, how should we suspect and corroborate what are the other clinical, should be their clinical findings, any other features of RV inflow obstruction, right, like a venous increase in the venous pressure.
Surprisingly, so this patient had an absolutely normal JVP. It was not raised.
Yes,
Regardless of the gradient, it was not raised.
Important aspect of this. Okay.
Doing because
yes,
we don't know at the present moment what the history regarding the chest pain was. There could be many cases of chest pain, including non-cardiac chest pain, we know in the
Yes, yes.
Now whether these are etiologically related or just a chance coincidence, we don't know at the present moment.
That's why I am asking what are the other salient features we should keep in mind.
So it has been described as benign and silent only in all this.
Okay, thank you.
Okay, thank you.
Is that if from the right coronary artery, the branches have to cross that distance to reach this endocardium of the right ventricle. They have to travel a long distance. They have to travel a long distance, and because of that, you can have ischemia of the right ventricle free wall. So, no, I'm just talking of, in this particular case, the fat pad is all along the RV free wall. And of course, the right ventricle branches actually, how would they finally supply blood to the RV free wall? By giving perforators, small perforators, which will go from epicardium to endocardium. Now you are increasing the distance, and if the vessel size is same and it does not enlarge, then you will have relative subendocardial ischemia, because the vessel will not reach the endocardium.
So in the literature, you have seen the few patients develop tamponade. And this tamponade is because of the sudden increase in the fat or some hemorrhage inside or something like that?
No, sir. Alone due to fat only.
Only fat?
Yeah.
But only just sudden increase in the growing of the fat. Because if it is slow, it cannot develop tamponade.
No, sir. Just like chronic, slowly developing pericardial effusion might lead to tamponade someday. In the same manner, it might lead to this tamponade.
Anirudh, this kind of thing is being described more and more actually.
Yeah.
The people can present at constrictive pericarditis. Many people with epicardial fat actually can present typical with constrictive pericarditis.
Agree.
And surprise, as a matter of fact, Shantanu is not here. He actually gave Monjaro to one patient where all these features disappeared on treatment.
One series.
Yeah, he had one case, but it was a very interesting case he showed actually.
So I will request my co-chairperson to have their concluding remark.
We had a very interesting case, as so many questions from the audience is a proof. So we close the session today. In fact, we end today's presentation, and I hand over the mic to our MC.
So we are concluding today's session. Thank you all to all the speakers and the audience. We'll now proceed towards the banquet and dinner. See you all there.